Testing 1 2 3 1 2 3. Is my audio okay?
Yes.
Oh, okay.
Yes, sir.
Oh,
Yes,
perfect.
Kashish.
Guys, can you all check the virtual venue audio? I will mute myself and hopefully this should be audible to us in another 30 seconds. Himanshi, can you check the audio on iPhone as well?
Okay.
Yeah. Testing 1 2 3 1 2 3. Testing 1 2 3. I'm going to switch on my video as well. I can see myself in the virtual venue with my video on, and now I will mute myself.
Yes, Kashish.
I will also stop. Good evening, Mangesh sir. My apologies. Good afternoon, Mangesh sir. Just wanted to test your audio, sir. If you
Hello. Hello, Vinesh.
Good evening, sir. Kashish here. Sorry, good afternoon,
Yeah,
sir.
good afternoon. Can you hear me?
Yes, sir, I can hear you, sir.
Okay. You can test the mic and video. If it is okay, then
Yes,
we
sir, I
can
can hear
proceed.
you clearly, sir.
Okay, no problem.
Yeah.
Virtual background you have already uploaded or
So you'll have to do it at your end, sir. We can guide you with the same, sir.
okay. Means I
Rahul, can you
haven't
guide,
signed.
sir?
Yeah. Hello.
Yes, sir. Rahul, are you online?
Yeah,
Sophia,
yeah, I'm
if can you guide,
online. You
sir?
can guide me.
Oh, sure, sir. I'll just do one thing. So you'll have to start your video first, sir.
Okay.
So can I request you to start your video? Yeah.
Yes, I'm starting.
Rahul, Rahul, can you help, sir?
Yeah, just a second.
Yeah.
Yes, I agree. Good afternoon, sir.
Good afternoon.
Just confirming, so you have downloaded the JPEG image which you have sent on mail.
Yeah, I have downloaded.
Great, sir. So on the bottom left corner, you can see an icon of stop video.
Just hold on.
Awesome.
Okay. Can you repeat?
So on the bottom left corner, you will have an
Bottom
icon of stop video
top
on the
video.
Zoom screen.
Okay. Yeah.
Right, so just on top of that, there is a upward arrow.
Yeah. I can see choose virtual background option.
Yes, sir, you can click on that.
Okay.
And now you can see yourself on the screen.
Yeah. I can see virtual background.
Yes, sir. Just below that, there is a plus sign.
Okay.
Yes, sir. When you
Add image.
click on that, it shows add image.
Okay.
Yes,
This
sir.
I can add.
After,
Add it.
yes, sir, you can add the image. Great,
Is it
sir.
added?
Yes, sir. This looks perfect for me, sir.
Okay.
Yes,
Can
sir. Now you
I
can close the
means
tab.
now close
Yes,
it?
sir. Yes, sir.
Is it fixed now or will I have to?
It's fixed, sir. It's fixed. You
Okay.
don't need to do
Okay.
these
Fine.
steps again,
Thank
sir.
you.
Thank you so
Okay.
much.
Fine. Thank you. So we will be starting at 1 p.m. Correct?
Right, sir. 1 p.m., sir.
Okay. Fine. Thank you. I have taken the confirmation of all the speakers. Dinesh, are you there? Hello.
Yes, sir. Please go ahead, sir.
Yeah, I have taken the confirmation from all the speakers yesterday only. So they means none of them had any problem. So we will be going ahead as planned.
Mangesh, sir, just give me 1 minute. If you were asking something.
Okay.
Sorry, Mangesh, sir, were you asking something? I was on the call with Dr. Sonal.
Yeah, no problem. Actually, I have already taken the confirmation from all the speakers yesterday only,
Perfect,
and
sir.
all of them are available. Means none of them had any problem. So we
Okay.
will be going ahead with the session as planned.
Correct, sir. And I've informed Sau sir as well about Dr. Piyush
Moderate.
Chaudhary being in the panel.
Okay, okay. I will introduce
So,
him because
yeah,
yeah, no problem.
perfect, sir.
Thank you.
So we'll be very strict with the time because we've got a lot of sessions and we want to be
No
on
issues.
time.
We will start at
Yeah.
sharp 1
We'll
p.m.
start
and
sharp at 1 p.m. So we'll
okay, fine.
hopefully if Kshitij sir is online, we can start the welcome address a little earlier, and then 1 p.m. we can start sharp.
Yeah, fine.
Thank you, sir.
Okay.
Good afternoon, Harsh sir.
Good afternoon. Good afternoon. Hi Rahul, how are you doing? Hi Kash. Hi
Hi,
Kashish.
hi, sir. Kashish here.
Hi Kashish. Hi. How are you doing?
Long time, sir.
Long time. Long time. Yeah. Hope everything going well.
Sir, everything is going well. Hope things are getting better at Kolkata as well.
Slowly. Very slowly.
That's great news. I think they're
Yeah.
following
Yeah.
Mumbai and Delhi the same way.
Yeah. Good.
Uh,
So
Rahul,
congratulations on the conference. Yeah, it looks great.
thank you
And
so
I
much,
think
sir.
MOC is doing great work. MOC is doing really good work. We're
Thank you so
actually
much, sir.
we probably need Purvis sir's guidance and starting something like that here. Should work well.
Definitely, sir. I'll pass on the message, sir.
Yeah. I'll talk to sir after the meeting today also.
Done,
So
sir.
yeah. So how do I arrange the thing? The background?
I'll guide you, sir.
Yeah.
Sir, on the left-hand side bottom, you'll be
Yeah.
able to see an option where it says stop video. Don't click on stop video. Just on the right-hand side, you'll see an upward arrow.
Yeah.
Once you click on the upward
Choose
arrow,
virtual
you'll be able to
background.
choose
Yeah.
virtual background.
Yeah.
Now on the right-hand side, you'll be able to see an option which says plus, the plus sign.
Yeah. So I'll add.
Yeah,
Correct?
you'll have to add the image. I hope you've
Yeah.
downloaded the image.
Yeah. I've got it downloaded.
Good afternoon, Sudeep sir. Good afternoon, Udip sir. Hello.
Hello. Yeah. I'm just downloading it. It's I think happening. Yeah. This looks okay. So yeah, I think I'm done.
So this is perfect. Thank you so much, sir.
I'm seeing some background effects on the
I think
screen.
that's
Is
because the
it looking
lights, sir.
okay? Is it
It
looking
looks perfect, sir.
looks okay? Okay.
Yeah.
Great.
Sir, if you feel that at any time that it does not look nice, you can remove the virtual background.
Sure. I'll do that.
Thank you so much.
Thanks, Kashish. Sorry for missing the demos. I had a
No
very bad
worries, sir.
week. Yeah.
No worries.
Okay. Thanks. I'll log
Thank you,
out
sir.
and then rejoin later. Yeah.
Perfect, sir.
Thanks.
Thank you, sir.
Yeah.
Good afternoon, everybody.
Good afternoon, Vasil, sir.
Hi, Kashish.
Good afternoon, Vashish bhai.
Hi, good afternoon, Mangesh.
Good afternoon, Udip.
Good afternoon, Mangesh bhai. Good afternoon.
Good afternoon, Kshitij sir. Good afternoon, Ashish sir. Good afternoon, Shirish sir.
Hi, good afternoon, everyone.
Good afternoon, everyone.
Am I visible with the background?
Yes, sir, you're visible with the background.
Okay.
Thank you so much
Good.
for adding the virtual
Good.
background, sir.
Thank God. Thank you.
Good afternoon, Govind sir.
Good afternoon, Kashish.
Good afternoon, Dr. Govind bhai.
Good afternoon,
Govind sir.
How are you?
Fine, fine. I'm fine.
Good, good, good.
How is Bangalore?
Slowly settling down.
Okay.
Yeah, last 3 days the numbers are less.
Oh, good.
Beds wise, almost 80% are empty now. So that is a
Oh.
good thing. Yeah. So hopefully we are over the peak.
Good.
How about your place?
Yeah, much less. Like tomorrow it's opening out practically. Everything is opening out. All the offices, everything. Buses, the BRTS, everything.
Oh, good. That theory which was saying that it was an engineered virus is becoming stronger now.
Yes.
The Indian data.
Indian, yes.
Yeah. Let's see what comes out. But the
You think
damage.
it's true that trio, the 3 people who were there,
Correct. But the damage is done,
that is done. Yes.
Yeah.
So how will we coordinate this, Dr. Govind Babu, sir, today?
I thought Kashish will tell us.
Okay, fine.
So we'll take all the chairpersons' expertise, and we're hoping that we could give the expertise in the panel discussion, sir. So we've informed our moderator, that is Sahu sir, also that to involve you in the panel discussion, so that
Okay.
you can get your best the expertise from.
Fine.
Or however you want to take it, no problem.
So you are inviting the coordinator and the speakers and the
Yes, sir. We
panelists.
will do that.
Oh, okay, fine, great. Dr. Raghu has joined? No.
Yes.
Yeah,
Hi,
very
Raghu.
much there.
Good morning.
Yeah, very much here, Dr.
Good morning,
Siri.
sir. Good morning, sir. How are you?
I was listening to your conversation with Govind.
Okay.
So good, Raghu. Your anniversary of the Baba Center. I saw the pictures and all. Very nice.
They're very old pictures.
Oh, yeah, I know. When you started.
Yeah, very much so.
I know.
I just read your in memoriam to Gauri
yes.
Shankar.
Correct.
Very nicely written in for the International Association Study of Lung Cancer.
Yeah, they wanted, so I thought 3 of us will put together.
Yeah, very nicely come out.
Thank you. So just came, so I just circulated.
Yeah.
We really miss him, of course. What to do?
Yeah, but I never knew he could speak Oriya.
Oh.
Because I know Burla Medical College. I had a cousin working there in medicine and then neurology.
Okay.
For a very long time till he almost left the place. And
okay.
He's now settled in Bangalore. So.
Oh, okay.
Hemoglobinopathies are something which are very unique.
Yeah, correct.
If you go into the hill tribes, you will find something which is very unique to a tribe.
Correct. For a general medicine, all these were classic examples.
Yeah. We used to, my father used to work on hemoglobinopathies with a professor of medicine who described it in some tribes, specific tribes in Andhra Pradesh. They're not seen anywhere else in the world.
Okay.
So they're very nice to study.
Yeah. No, we have such isolated tribes all over India,
You're right.
In fact, the Andamans has tribes where nobody can even go. The Jervas.
I know.
Yeah, and the Sentinels, 2 of them.
Yeah, you might extinguish them like.
No, it is very good that they have not allowed anybody to get in touch with them. Several years ago, I went and met a tribe called the Onges in Little Andamans. So they were also just 72 people, but the government said that they're going to rehabilitate them. They did a bad job of it.
Always.
Really, they should have just been left alone.
Messed up.
You could really see 3 different generations there. The older generation, so fit, slim, they were fishing with spears. And after the government took over, the middle generation, all pot-bellied, useless people. I don't know what government is trying to do. It's horrible.
There must be a lot of consanguineous marriage in the tribes.
There are just so few of them, but they're protecting the jungles and all so nicely,
Sir, I'm very sorry to interrupt you.
Yes, we are.
Yes, please.
Time to start.
Kshitij sir, sir, I'll just guide you on the virtual backdrop if you want to do it right now. Sir,
We'll
you'll
do
be,
it for next session. So
yes,
it is
sir. I'll
getting
have.
too late.
Okay, then, sir,
So
I'll guide
better
you on
to
the
start.
WhatsApp, sir.
I will
Yes, sir. We'll
do
start.
it
Just give me
later
one.
on.
So thank you everyone for joining us for the 44th ICON conference, the day one of the main conference. So without wasting any further time, I request our organizing secretary, Dr. Kshitij Joshi, to please give the welcome address. Over to you, sir.
Thank you, Kshish. Thank you, ICON, for giving MOC the opportunity to organize 44th ICON. It is our privilege to organize this meeting and this conference. So without wasting further time, I want to introduce our first coordinator. So the first session that we are going to start today is COVID-19 and cancer. And our medical oncologist, Dr. Mangesh Mekha, who heads our MOC in Pune, is going to coordinate this session. So I will just hand over this session to Dr. Mangesh Mekha and he will introduce everyone. Thank you very much.
Thank you, Kshitij. Good afternoon, everyone. Today we are going to start our session with the COVID and cancer session. Basically, just now also we saw when discussion between our senior colleagues started between Shirish sir and Govind Babu sir. They also started the session with the discussion with the discussion regarding the COVID. So nowadays, whenever two medicos are meeting, they are asking each other how is the COVID situation in your city or your hospital, whatever it is. So similarly, we are also starting today's session with COVID and cancer. We are blessed to have the senior most colleagues from our oncology society, which are stalwarts in the chairperson for today's session. So I would like to actually they none of them require an introduction, but I will try to introduce them. So we have Dr. Raghunath Rao sir, who is a senior most medical oncologist who is currently working at KIMS Hospital, Visakhapatnam. We have Govind Babu sir, medical oncologist from SCG Cancer Hospital, Bangalore. We have Shirish Alurkar sir, medical oncologist, Apollo Hospital, Ahmedabad. And we have the speaker. First speaker for today's session is Dr. Udip Maheshwari, who is medical oncologist and hematologist at Mumbai Oncocare Center, Mumbai, and he is a consultant at Saifi Hospital, Mumbai. So I would like to invite Dr. Udip Maheshwari to start his presentation and go ahead with the proceedings. Thank you.
Thank you, Mangesh bhai. Thank you so much. It is a pleasure to be indeed a pleasure to be presenting in front of our teachers, our examiners, and it's a real pleasure to present our COVID experience in the last 1 year that is past. So I it's a first presentation. So we have a Shubharam today, and I'm privileged and obliged to be the Virender Sehwag of our icon, 44th icon, and that's the opening batsman. And guess who is the bowler? Bowler is COVID-19 for sure. So it's been bouncing us all day, all night, every for the past 1 year. And like Sehwag, I'll promise to be very short and very sweet. So, so I'm Dr. Udip Maheshwari. My topic for today is COVID-19 and cancer, community oncology perspective. So I would be throwing light on what we as community oncologists at MOC have tried to dig in data and how things have been for the last 1 year. So coming to next slide, there is no doubting that the healthcare in India and world over is stretched to its limits and beyond in the current pandemic. Managing patients of COVID-19 and cancer has its own challenges, especially in Mumbai, where majority of oncologists are community oncologists, and most of them are freelancing and have multiple attachments at multiple small nursing homes as well as corporate hospitals, as well as their own OPD clinics or daycare clinics. So here is presenting the data of COVID-19 disease and cancer patients from a group of oncologists at MOC. So going roughly through the numbers, the total number of cancer patients coming for chemotherapy at our daycare centers across Mumbai during the first 4 months, that is from April, May, June, July of 2020, were around 1215 patients. These were patients who have come for chemotherapy. They were the admissions at daycare, that were 1215 patients. Only symptomatic patients, of all of these patients, only symptomatic patients were tested. Not every patient was tested prior to chemotherapy during that time, as the test cost was very high, and a patient as well as their relative uh, needed to be tested at that time. So only symptomatic patients who had any symptoms of COVID-19 related disease were tested in the last 1 week, were tested. So out of all these patients, there were 4.27% of all patients were infected. So out of 1215 patients that we had, the test positive were 4.27% of them were tested positive. 46.2% of these positive patients had one or more comorbidities. So these almost more than 50% of the patients, barring cancer, other two one or more comorbidities. So roughly going through the data, that 52 patients that were there out of 1215, out of that 23, that is 44.23% of patients were hematolymphoid. Every next patient that we saw was COVID positive was a hematolymphoid malignancy, including multiple myeloma, leukemia, MDS, high-grade lymphoma, and ITP. So most of them, many of them were hematolymphoid, and second most common was breast cancer, lung cancer, colorectal cancer, ovarian cancer, and testicular cancer along with it. So this was grossly the number of patients that were there, including different malignancies. So coming to the next slide, how many patients of these required ICU? So there were around 52% of these patients required ICU at that time, and
So 1 minute left, sir.
out of that, ventilatory support was required in 28% of the patients. So 25% of the patients succumbed to COVID-19. Most common cancer-associated death due to COVID-19 was multiple myeloma. Presence of comorbidities, advanced stage, multiple myeloma on chemotherapy status was associated with significantly inferior survival, and the p-values are there to show. So we concluded that hematolymphoid malignancies is the most common malignancy that were getting affected by COVID-19, and out of that, multiple myelomas had the most death rates. So limitation of this study was, the nature of the study was retrospective. The treatment of these patients had limitations: poor health, infrastructure, poor preparedness, lack of consensus guidelines, limitation in availability of drugs. However, it does provide us the way ahead for the future, where to look and what to protect. So I will end the presentation by this quote: while it may seem small, the ripple effect of small things is extraordinary. Thank you. Thank you so much for your patient hearing.
Thank you, Udik. You kept your word by showing the presentation, which was really short and sweet, and sharing your experience of Mumbai Onco Care Center regarding this COVID scenario. I would like to invite our next speaker, Dr. Lavnish Goel, who is a medical oncologist at Aadhar Health Institute, Hisar, to share his experience regarding this COVID pandemic. Over to you, sir.
Yeah, good afternoon, everyone. It's a pleasure to be talking about COVID-19 and cancer today. And it's my pleasure to be a part of this talk. The most important thing for is, if we go to the background, the COVID-19 actually has affected cancer care differently in various parts of the country. The first wave we saw the last year, basically we saw a lot of patients initially in metro cities. And due to that, there were some differential treatment patterns that were seen in the metro cities, whereas in cases of tier 2 cities, that actually data I'm presenting today. And the travel restrictions due to the first wave started on 22nd of March 2020, and there were the mainly challenges were seen in diagnosis and treatment both. We saw late diagnosis later on also. So biggest problem was the interstate, and the interstate travel was restricted during this time, leading to patients opting to take treatment at local cancer centers instead of going to a nearby metro city. So this data was collected from 6 centers in tier 2 cities to see the trend in treatment and diagnosis and impact of COVID-19 in all the patients. The mainly patients were seen, the collected patients are from Faridabad, Department of Medical Oncology, Sarvodaya Hospital, Bhubaneswar, Vizag, Hisar, Nagpur, and Mehsana. Total 59,171 chemotherapy infusions were given to the patients and the data is from 1st January 2019 till 30th November 2020. So 28,284 chemotherapies in 2019 and 30,887 in 2020, but that is only 11 months of data from Jan to November. The change in the pre-lockdown period, that we considered the pre-lockdown period as the January to March 2020, and it was compared to the impact in the subsequent months, that is April 2020 onwards. And basically we should see the first 3 months, that is January to March, as normal. The lockdown was announced on 22nd of March and the maximum effect we will see in April. And after the release of lockdown began in 1st of July, these restrictions were continued to be lifted and we will see how the pattern changes according to that in July and August. So if we see, this is the tabulated data and the blue bars represent the 2019 and 2020 is the red bars. If we see the January and February and March, yeah, January, February, March, this will consider the normal. If you go to the April, you will see the number of patients will come down. In the May, both the bars are almost equivalent. In June, the patients began to rise, June and July. August, again, it came down. That was because the travel restrictions were again lifted and the patients began to go to metro cities again. Maybe that's why the tier 2 cities numbers came down. September, October, and November, again, the patients again increase. So this is the relative change in the percentages. If we see the March, that is the normal period. April, it is negative effect is there, almost minus 12% because of the severe lockdown restrictions. Even everybody was afraid to go and seek treatment. Patients on treatment, new patients. In May, it was almost normal, like neither increase or no growth was seen. June and July, we see a rapid growth in these patients coming to tier 2 cities for getting the treatment. August, again, it is the negative part. Again, the patients most probably went back to their metro cities. And the September, October, again, we see more patients coming in the 6 tier 2 cities. So again, this is in the graphic form, April being the lowest, May is at the unity, June and July we see increase, August again dip, and September, October, November, again the patients increasing. So basically we concluded that the maximum reduction in chemotherapy infusions was seen in the month of April. As expected, severe lockdown, 12% dip. May and June, there was an increasing trend in number of patients receiving infusional chemotherapy in the tier 2 cities due to lockdown effect. More patients coming down to our hospitals. Again, there was a dip in July and August. Presumably, maybe because of the significant lifting of travel restrictions, allowing the patients to go back to the oncologist in tier 1 cities. However, patients soon realized the benefit of continuing quality treatment in tier 2 cities, and many of them actually came back in September and November, October again to get them treated to our. This is our thinking about that. That's how we are thinking. The main thing is that all the data on the main thing was done by Dr. Purvish Parikh sir. So I am very thankful to him and other people who are involved in these studies in different centers. That is Dr. Sumit Gupta, Dr. Biswas, Dr. Reddy, Sushil, and Dr. Trivedi. Thank you very much.
Thank you, Lavnesh sir, for enlightening us regarding the impact of this COVID-19 wave in our practice in tier 2 and tier 3 cities. So we have seen in what has happened in metro cities as well as in tier 2 and tier 3 cities, the impact of this COVID-19 in our clinical practice in the field of oncology. Now we will move on to our next session. I would like to invite Dr. T.P. Sahu sir, who is the senior medical oncologist at Silver Line Hospital, Bhopal, and he is an eminent speaker in the field of oncology.
Okay. Yeah.
Yes, sir. Good afternoon, sir.
Yeah. Thank you.
May I invite panelists?
Yeah, please do that.
So I would like to invite
Sahu.
Yeah, thank you. Thank you. Let's go on with the job. Okay.
So I would like to invite our panelists for today's session. We have Dr. Rahul Kulkarni, medical oncologist from Sahyadri Hospital, Pune, Dr. Pinaki Mahato, medical oncologist from HCG Cancer Hospital, Vadodara, Dr. Anup Tamankar, surgical oncologist from Dinath Mangeshkar Hospital, Pune, Dr. Sonali Pingre, radiation oncologist from Dinath Mangeshkar Hospital, Pune, Dr. Vikas Kothawade, radiation oncologist from Jupiter Hospital, Pune, Dr. Amit Verma, molecular oncologist, Max Care Hospital, Gurgaon, Dr. Dipesh Agarwal, critical care specialist, Saifi Hospital, Mumbai, Dr. Piyush Chaudhary, infectious disease specialist from Jahangir Hospital, Pune. So I would
Yeah,
like to hand
so
over the mic to Sahu sir for the next session. Thank you.
thank you, organizers. My only thing is, let us be. This is a very short panel of 20 minutes, and knowing Dr. Purvesh sir and the way the conference are held, so we will not skip the time, and that's how we should do that. And I request all the panelists to be very short in the answer, crisp, and that's how it should be. And Dr. Piyush is not joining us. That's what the message I got last. So if there are any changes, Kashish, you just let me know. Yeah.
Okay.
So,
So can I also
yeah,
request you
yeah,
to include the chairpersons as well in the panel?
yeah, sure, sure. We have Dr. Govind Babu, Dr. Raghunandan sir, and
Dr. Shirish.
Dr. Shagri Shirish. Okay, so that will be also there. And one more thing, the chair can chip in with their wisdom any point they feel that something is missing in the discussion, apart from what I will ask them. So I'll start off with starters. I have made it very simple and I made it more practical how we should go it. And let's come down to these issues of diagnosis, which I feel is very, very important. So if I can start off with Dr. Dipesh, who's a critical care specialist and would be dealing with a lot of COVID cases. So what do you think is a test sample? Do you think a nasopharyngeal sample or a throat swab, which is good enough? Do we need both? Or is anyone is better than other? Can we have a short answer on that?
Good afternoon, everybody. So the sample should be nasal and pharyngeal. It increases the yield of you getting an appropriate result. The false negatives are pretty high. And most importantly, the method of sample collection is of utmost importance. A poorly collected sample will give you a false negative result.
Okay, so basically you are telling us that although there is studies to tell us the nasopharyngeal and throat swab both can be both match in terms of positivity, but ideally you should be taking both the swabs so that you can decrease the chances of false negativity, and that's what should be the way. And the sample collection method should be okay so that you can decrease the chances of false negativity. Is that a fair statement to make at this point of time? Yeah.
Yes.
Okay. So this is something very important because a lot of us treat on one report and sometimes that report can be erroneous because of the samples. So second point, if I come into Dr. Amit here. Dr. Amit, just can you tell us what is a day on which the sample should be collected? Because all of us medical oncologists, the patient comes to us, we do a sampling test, we get it done, let it be a rapid antigen or a RT-PCR, and we go on with that. But if a patient is symptomatic, what do you advise to the panel? What do the house? What should we do?
So if the patient is symptomatic, then definitely
mildly symptomatic. Let's say
mildly symptomatic. So at least 48 hours before your visit, they should get the test done. That is a minimum requirement. And if the patient is asymptomatic, then the chances of false negativity is very high, and the caution has to be taken into account because the patient might be in the incubation period. So in that case, if there is any doubt or a contact history is there, you can ask categorically to the patient if there's anybody in their family who was positive and they have traveled. In that case, a 2 swab test that is apart 72 hours should be done before concluding the patient is 2 negative.
So basically, the take home could be that you could in one test the timing is important. And if the patient has just been in contact with with someone or has been the day one of symptoms, he or she could still test negative. And if you're going for, let's say, a procedure like a surgical procedure for a cancer surgery, it is always good practice to do a test at least 72 hours post, because this graph also shows you that you may get the false negativity comes down post 72 hours, and the maximum positivity of a COVID infection is at the day 5, 6, day 4 to day 7 is where you get the maximum positivity. Is that a fair statement, Dr. Amit?
Yes, exactly.
Okay. Dr. Dipesh, any point which you want to add to this small thing? And you also, I would like you to take this one. If a patient is negative, let's say we as medical oncologists, let's keep to the purview of medical oncologist or someone who's dealing with cancer. If the patient is symptomatic, let's say mildly symptomatic, even has that okay, myalgia coming in, I want to give a induction chemotherapy for a blood cancer, let's say. If a patient is negative, do you recommend that we as oncologists should not just rely on that report, test X number of times and at what intervals? Dr. Dipesh.
Yes. So as the false negative report is very high in RT-PCRs, you cannot just rely on an RT-PCR. Clinical parameters are very important. You may use other methods also to diagnose. A single negative report or two or maybe three also does not preclude that the patient is negative. So high degree of clinical suspicion is required. If you suspect that the patient is unwell or having any symptoms, it is better to err on the side of caution and not go for chemotherapy, especially hematological malignancies, because such patients, any which ways, have a very, very high risk, as was also demonstrated by Dr. Kshitij Joshi in his slide, that hematological malignancies have very high mortality. His myeloma patients, around 6 out of 8 people didn't make it.
Okay, let's come down to the take home on this part of it. Dr. Shirish, as a chairperson, what would you tell us? We saw the timing. I would like you to comment on the practice of number of tests repeated, because that is not happening in our practice. Please.
I mean, repeat RT-PCR you're asking?
Yes.
So I think if you have a high clinical suspicion that this patient has, for example, radiological or clinically, and one test is negative, then I would repeat the test maybe after 48 hours. The symptom persist. Another issue, just if you have permission.
Yeah, please.
How the test is done. We have seen like the technicians standing with their arms way apart and taking the sample either from behind the patient or above front of the patient. Or
so basically, a correct technique of collection is what has been highlighted upon. That's what you are again highlighting.
Right.
I'll just ask Dr. Govinda sir a very simple question and move on to the next part of the panel. Sir, if I have a patient of leukemia, there was a comment that in a blood cancer, acute leukemia, I would wait. Does leukemia give us that liberty of waiting for acute leukemia induction chemotherapy, or would I take that chance, get a test negative at least maybe 2 times in 3 days? And if it is not, I will just carry on and give the induction, because leukemia itself is lethal and probably more lethal than the COVID.
Correct. I agree with you on that, Sahu. But you have to weigh the pros and cons of either of them and then take an individual decision. So if you are looking at, say, acute myeloid leukemia, then you might even start hypomethylating agents where it is not very toxic to start with, and then wait for 48 hours, get 2 or 3 repeat tests for COVID, and then subsequently, if that is negative, go on to your high dose.
So basically, that's the point, that you have to weigh, do the pros and cons, individual the patient. But the take home is, if you are clinically suspecting that it could be COVID positive, just do not hesitate to repeat. Even 3 times, you still could get a false negative report. So we move on. Just a short answer, quick yes, no. Mutants, has the positivity rate differed, Dr. Amit? Or is it the same? Because there was some data coming in initially, the hue and cry, the Pune variant, it looks that it could be lesser positive picking up on RT-PCR.
Yeah, so as of now, the techniques used does not have any difference in the picking up the variant percentage, so it will be the same. There are few kits available who categorically evaluate the S spike gene in their test analysis. In that scenario, you may have a miss, but majority of the laboratories across India are not using S-based gene analysis. So they are using standard RDRP, N gene, E gene, or ORF. They are not using S gene as of now. Yeah.
So basically, could we just simply take home that you should not be worrying about this part? Science is not very clear on it, and we take it that both the variants would be picked up on a RT-PCR, the same percentage.
The answer is yes.
Yeah, Dr. JP in the chat has told that the bubble around the patient is very important, means that you have to keep the attendants also COVID-free or make them not come into contact, because they could be the major persons who, through mainly pediatric age groups especially, where they could transmit this infection. So we move on. And this is very simple. And now get the medical oncologist first in. Cancer and COVID, mortality. Let's come very quickly. Short answer, yes, no. Do you think cancer and COVID, the mortality is high? And if yes, is it because of the cancer or is it just something else that is happening? And second point also I want to come up with the medical oncologist is, do you feel chemotherapy makes more contributes to the mortality in COVID? Dr. Rahul first.
Yes, so to answer first question, definitely whatever experience we had in last 1.5 years, we saw that the mortality is little bit higher side with cancer patients. There is no doubt about it. And regarding the cause as such,
what could contribute to that?
Yeah, so basically, if the disease is also involving the lungs, that can also be a contributing factor. But apart from that, most of the patients are also on chemotherapies and they are having immunosuppressive treatments. So maybe that also can contribute to the complexities in the treatment and maybe the outcome. But whatever said and done, definitely mortality is a little bit on the high side.
When Dr. Pinaki, you differ on some part, or you feel that this is what it is?
So in my limited experience, sir, I have not found a difference in the mortality in a major way. That is probably because I don't deal with much hematological malignancies. So most of the patients, 95% are solid malignancies, and the mortality was, I think, almost the same.
Okay. So solid malignancies, you feel is no different.
No, I didn't notice a difference.
Yeah. And with chemotherapy also, you feel there has been nothing much to associate with mortality.
No, sir. On the contrary, I feel that the immunosuppressive effect of chemotherapy actually helped some patients.
Dr. Sonali and Dr. Vikas, a quick, Dr. Sonali, Dr. Vikas, very quick, yes, no. Do you feel cancer and the cancer treatment modalities have contributed to the mortality due to COVID in COVID era? Dr. Sonali first.
We have not observed. We also gathered our data during the first wave, and we did not see any increased mortality.
Dr. Vikas, your answer, no or yes?
No, sir. No. In radiation, we are not finding increased mortality.
Okay. Basically, I'm starting with a retrospective series from Turkey, and the take-home message that should come from this is that the patient who had the higher risk factors, especially had more mortality. The lymphopenic was a very big risk factor. The high inflammatory markers were one of the risk factors. And if you look at it, they basically pointed to the severity of the disease and the lymphocyte counts absolute, which could be the contributor in a retrospective series. But come down to the UK prospective data from the Birmingham University and the Oxford, they just contoured that the take-home message should be, it was principally driven by age and comorbidities, and chemotherapy also per se did not play any role. The third factor which they felt, although the percentage of patients of COVID with cancer dying was around 20-25%, here is 28%, and that has been consistent across the studies. 15 to 30% what we got across studies. Started with the China report. One more important is the stage of the disease. If there's an advanced stage, these patients are more likely to die because of these comorbidities and other risk factors than not. And p-value was not significant for chemotherapy, radiotherapy, immunotherapy, target therapy. Dr. Raghu sir, your take on this. Do you agree to this statement, or do you feel?
I fully agree to this statement. I don't see much of a mortality in solid tumor patients at all. And I'm not lost a single myeloma patient so far. I have not lost a single CML patient who had COVID. Quite a significant number of my patients have COVID. I did manage them at home continuously, constantly on the phone, but I didn't lose them.
So basically, we agree to the prospective data from UK. That's what it is, and that is the same. Although some colleagues among us also feel that there has been increased mortality, but that is as experience on a single center retrospective. They have their own baggage with them. So now with rituximab, very short answer, and we will just we'll have 3 minutes on rituximab. Let's come to Dr. Pinaki. You do not practice HIMAT. That's what you told. Can you take it? Yeah. So can you, would you give rituximab in a COVID era? Yes, no.
I would give rituximab.
Okay. Would you give rituximab in a patient who has been having COVID, just recovered from COVID, has a high grade NHL? Would you give re-challenge the patient with rituximab? Yes, no.
I would wait, sir. I would know.
You would wait. Dr. Rahul, your take on that?
So definitely, if the patient has already got a COVID and documented lung involvement as such, I would wait for starting rituximab for initial first 1 or 2 cycles as well. And then later on, based on the lung recovery and also based on the other inflammatory markers, then I would like to add on rituximab later. Definitely, I would like to avoid in the initial 1 or 2 months.
So basically, you would put your clinical judgment based on the severity of disease. That's what I want. Dr. Dipesh, do you agree to this part of severity of disease? Rituximab,
Severity of
if I
COVID.
can bring you in, and if you have anything to say on this part.
Could you just repeat severity of
the COVID infection? So would you avoid rituximab to any patient and be apprehensive who, in spite of would have been mildly or asymptomatic, is positive, has recovered, is due for a rituximab? Would you avoid rituximab in that also as a critical care? Would you tell our colleagues no, don't give it, or would you just tell if he had a severe disease, then don't give it?
So any patient who has COVID, lymphocytes play an important role. Rituximab would suppress those lymphocyte count. So I would ask them to wait or delay the therapy till there is complete recovery from COVID. Delayed COVID, recrudescence of COVID is also seen. We would not want a patient who was well initially, then we gave an immunosuppressive or a
So
lymphocyte.
basically, you will put a note that please, as a doctor, I would recommend you to wait because it has its own issues. That's what it is. That's what you are telling.
Complete clearance. Till complete clearance.
Till complete clearance. Okay, that's an interesting point. I'll spend half a minute on that. Dr. Amit, any differences on what has been spoken?
So I think we know that the solid tumors have a hypercoagulable state, and so do the COVID infection, and they are at a higher risk of clots. And most of the protocols, what we follow in our tertiary care is DVT prophylaxis. So there are chances that the lung-related mortality may be higher, but the other related mortality may be lower in COVID with chemotherapy.
Dr. Govind Babu, rituximab, mildly symptomatic, wait, or would you give it? And if only severe, you will wait.
Yeah, I'll wait and then.
Okay. So what is the thing? When to restart therapy? Normally we restart in asymptomatic in a solid tumor.
So Dr. Sahu, I want to add, I just missed that part. I want to add, most of the antiviral immunoresponses the body has is basically cell-mediated immunity. So we are not talking about the antibody-mediated immunity to control the severity of that. So the CMI still remains active.
We have 4 minutes. We have 4 minutes. Quick answer.
CMI is still active even if we give rituximab. I don't think that should be a contraindication.
Okay, so when to restart? Normally 14 days is what we look at solid tumors. In a blood cancer, you could weigh chances with the risk that is with the cancer. Wait for RT-PCR negativity. Most of us feel comfortable, but in a solid tumor or in a hemat malignancy patient, asymptomatic, people have done chemotherapy with a persistent RT-PCR positive in an asymptomatic patient in a COVID ward. So if there is for rituximab, there has been data that there is a delayed shedding that goes on even till 2 months. The problem with rituximab is there could be a delayed reactivation of virus. And that is why there have been reports, although the final word has not been told, these patients shed virus for a long time. The rest period is, if 2 weeks is enough, I'm not sure. There is no data. You have to weigh the degree of the grade of the lymphoma versus rituximab. Antibody titer, the point told by Dr. Dipesh, they do not develop a good amount of sufficient amount of antibody because their lymphocyte depleting and the B cell depleting. And that the case study which happened here is a leukemia patient published in Oncology, and they told that it was a positive for ALL with on a rituximab, then became negative, and after 10 days the patient became positive again with the antibody titer being lost totally. So this patient, after 25 days of recovery from the first infection, actually developed up with a severe COVID infection and a reactivation. So these issues are there with rituximab. That is why people are little bit not going for rituximab. And our point one, we discussed this in COVID and cancer is in the different sessions, we would avoid rituximab. Be cautious. Would not give rituximab even for the mildly symptomatic patient on recovery. Only give chemotherapy. And very, very carefully choose re-challenging with rituximab in a patient already infected with COVID. So that would be my take on this, because the data from rituximab from the rheumatoid arthritis, it causes more severity, more duration hospital stay, and more deaths. And that is where I will stop the rituximab part, and I will go to the surgical colleagues. A quick 2 minutes. Surgery and COVID after recovery. Can you tell me, when do you want to restart or redo your surgery if a patient is severely COVID recovered or a mildly to moderate COVID recovered? Dr. Anup.
Yeah, so post-COVID, we would wait till the patient is actually completely fit for from surgical perspective in a general condition-wise manner.
What is the time period?
Yeah, so typically we would delay the surgery, a major surgery, by at least 3 to 4 weeks post-COVID recovery. So I'm not talking about the diagnosis date. but I'm talking about when the patient has been fit to be like sort of out of the home quarantine or out of the hospital discharge. Suppose that we will wait for another at least 3 to 4 weeks before we subject the patient to a supra-major surgery. But if it is a minor case, something like a mastectomy or a simple neck dissection, then we might err on the side of doing it earlier also.
So basically, the take home for surgery in COVID would be for a patient who severely symptomatic has recovered from a severe infection, 4 to 6 weeks is what my panel is suggesting. For a moderate, for a case like a breast cancer surgery, 2 to 3 weeks also is fine. And the waiting period is because of the possible anesthesia complications that could happen because of the surgeries. That also contributes to it. Okay, fair enough. So for my RT colleagues, I have 2 questions. Would you give radiotherapy to a person who is having active COVID, has a spinal cord compression with a lung cancer? Would you recommend radiotherapy during the 3 day 5 of a COVID infection? Dr. Sonali.
No, we would not recommend it because mainly by the time the COVID diagnosis comes, it is already too late.
So can I just presume that you are suggesting here, Dr. JP can do in the chat, that if the patient is having a medical emergency of a cancer emergency and needs a radiotherapy, if it's COVID positive, you would defer radiotherapy?
No. What I said was that if the patient is diagnosed.
Yeah. Patient has a spinal cord compression, you are due for it.
So in that case, we would be taking all the necessary precautions. We have done it in a case of spinal cord compression. So if it is diagnosed, we would have to take all the necessary precautions for the patients as well as for the technicians.
Agreed. Okay. So the point is,
cases we wouldn't do. Routine we would defer.
Even there's a point which has been there. The ASCO guidelines came out last month or maybe March, and they told that you can take radiotherapy patients with COVID. You could probably, if it's a 1 machine, do it at the end of the day. If it's a 2 machine, very good. But there is no enough data that it really can be taken away from, but due precautions has to be taken.
We have to take all the precautions for the safety of the technicians as well as the other patients.
Okay. So last question to Dr. Vikas on radiotherapy. What do you feel is the role of radiotherapy in the cytokine storm? There was a much of hue and cry.
Yes, there is trials are going on, but there is no mature data. But low grade radiation around 0.6 to 1.2 grade, people are giving in cases of cytokine storm. But we are not giving. We are not started yet because there is no.
Dr. JP on the chat. You are a very evidence-driven person. Would you say yes or no on the chat, sir? At this point, data is lacking, and would you just recommend it for? So my last 2 questions on the chat, sir.
Sorry.
Yeah, sir, because I have to restrict the time, sir.
Okay.
Sir,
the
GCSF
definition of cytokine storm is not yet established. What is the cutoff? So there is a lot of gray area.
Sir, on the chat, sir. On the chat, sir. Sir, I have to just finish off in a minute, sir. So now your take on GCSF, Dr. Pinaki, would you be comfortable giving GCSF?
Yeah, I'm comfortable giving GCSF.
Dr. Rahul, yes, no?
Okay. I would be a little cautious while using.
Okay. Basically, there is a neutrophil which is accumulated in the lung that could cause problems. That has been shown in lung cancer patients. But you would use GCSF based on the risk profile that Dr. Govindrao told. If the neutropenic patient, severity of disease is there, the chance of losing patients is there due to neutropenia, probably GCSF could be advised. But routine GCSF use probably should be restricted because there could be a lot of lung issues because of the neutrophil accumulation. That's some data that has come. And vaccination in cancer patient, I'll skip it for some other day because this is a topic in itself. I will not do it because the time is over. Just the last word to Dr. Dipesh. Would you tell a cocktail therapy, the antibody cocktail, has it changed? Is it the most significant thing that has happened in COVID care? And would you recommend it for cancer patients due for chemotherapy?
So casirivimab and imdevimab is a monoclonal therapy against spike proteins. It is very important that patients who are immunosuppressed or immunocompromised and cannot mount a cell-mediated or a humoral immune response this drug can then change their outcomes. In fact,
So
in
you
hematological,
you would recommend that?
yes, and hematological malignancies definitely yes, because it just neutralizes all the active viral particles in the body and eliminates it.
Okay. So basically, the recommendation comes from phase 2, phase 3 data. That phase 3 is not coming to publication. Phase 2 is into publication. That lower dose is as good as the higher dose. If a patient has a serum antibody positive, the antibody cocktail does not work. The patient has to be serum antibody negative, and the higher the viral load, the better it is. Basically, you are giving the antibody itself so that the patient can protect itself, and it prevents hospitalization. I've seen case reports where people are given hospital patient as a desperate measure. No, it is indicated on an OPD basis, and it prevents inpatient hospitalization to the tune of 70-75%. And even there's a data that if there's a contact in the home, high risk contacts, and if you have that is COVID negative, if you give that, this cocktail antibody has prevented the infectivity, positivity also for these contacts. So with that, I have skipped my time by 2 to 3 minutes. Sorry, organizers. Thank you for giving the extra opportunity. I would just end up with to Dr. Govind Babu sir and Dr. Raghu sir. Any quick one-liner you would like to say, which we have missed in this discussion of COVID and cancer?
I think cancer is old and COVID is new, so it's a learning process. Nothing is as it finalized. Last year, most of us were very frightened out of our wits of what to do, especially the bigger centers in the country. I'm very happy the tier 2 cities data has been presented. It opens your eyes to many things. And I'm also very happy that the medical and hematologists here on the panel are ready to give the treatment, keeping the caution at the back of their mind. Yes, Govind?
Yeah, that's right, Raghu. And, Sahu, if you see the treatment of COVID, the drugs that we've used start from leishmaniasis to cancer. So that is how our understanding of COVID today is. So I think we are learning every day. And I think you should personalize your treatment to each patient that you see, weigh the risks, benefit, and use your treatment.
Thank you so much, sir. Sahu, sir, your mic is muted if you're trying to say something.
No, I told on that note,
Dr. Sahu, Dr.
Yeah.
Sahu, any comments on immunotherapy and COVID patients?
If you look at the data, it is not recommended to stop immunotherapy at this point with COVID. On infection, I'll wait for 2 to 3 weeks. That's what it would be. I'll weigh the balances, the risk and the benefits. But there is no data to tell it's contraindicated.
Right. Thank you so much, sir.
Thank you.
Now I request our organizing secretary to please introduce our next coordinator. Over to you, Sajid. So we'll just move on to the next session. The next session is on head and neck cancer. It gives me great pleasure to introduce our coordinator, Dr. Sonal Dande, medical oncologist from Mumbai Oncocare Center, Nasik. Over to you, ma'am.
Thank you, Kashish. Without wasting time, I think warm welcome from me to everyone. And we'll just, I have an immense pleasure to call upon my chairpersons. So we have Dr. Anil Dikruz, sir, who is ex-director and chief of head and neck services at TMH Mumbai. And currently he's a director oncology at Apollo Hospitals, Navi Mumbai. A warm welcome from our MOC group and ICON family.
Thank you.
Dr. The next chairperson being Dr. Ramesh Nimgarda. He's a director medical oncologist at Apollo Specialty Cancer Hospital from Chennai. Welcome, sir. The next chairperson we have Dr. JP Agarwal, sir, who is being very much active in the previous session. So, sir, a warm welcome from our ICON family and MOC. He's a senior radiation oncologist at TMH Mumbai and special expertise in head and neck and thoracic malignancies. So I'll call upon my first speaker. That also the topic being a management of neck in clinical N0 head and neck cancer. And none other than we have the topic will be given a very well justice by Dr. Sudeep Sarkar sir, who is a chief surgical oncologist at Nanavati Super Speciality Hospital, Mumbai. And he's been a TMH alumni and over 35 years of experience in a head and neck cancer specialty. So I'll welcome Dr. Sudeep Sarkar sir for the talk.
Sudeep sir, you'll have to unmute your mic, sir. Sir, can you hear us?
Yeah, am I audible, visible?
Yes, sir, you're audible and visible, sir.
Yes, sir.
Good afternoon, respected chairpersons, participants, organizers. Thank you for giving me this opportunity. And since I have just 10 minutes, with the permission of the organizers, I have limited my talk. I'm going to limit my talk to N0 neck metastasis from oral cavity primary. So, do I
Sir,
advance
if you
the
want,
slide?
I can share the slides, sir.
Oh, even I can do that.
Yes, sir, you can do that, sir. Please go ahead.
Let's try. Where's the first one?
Sorry, sir.
I can't see my slide. I can see only Kashish Parikh.
Sir, if you want, I can share the slides, sir.
Please do. But who's going to advance them?
Sir, I'll do that, sir, for the time. You can just tell me next and I'll just move it.
No, I think it will waste time.
I'll just give you the control, so just you can take
Yeah.
the control. Sir, have you got the control, sir?
Yes. Not really. No.
Sudeep,
Yeah. I think there is. I don't see only half.
Yeah, now we can.
Sir, it's still saying that it's waiting for you to take control of the screen, sir.
Sudeep, you speak because you've already lost a minute and a half. He will forward it. Don't worry about these formalities. Please go ahead.
Okay. So, as we know, nodal metastasis is the single most prognosticator for the oral stomach cell cancer. And we know that node positivity in any primary from the oral cavity reduces survival by almost 50%. And if we have extranodal extension, that further reduces the survival by more 50%. So the management of neck is of paramount importance. I would like to advance. I can't. So looking at the primaries, there's a lateralized primaries from the oral cavity. We can see the probable lymph node levels. Next. And as the tumor moves posteriorly, we might even have involvement of other lymph node groups like 2B and 4, but majority remains around 1 and 2. And if the lesion approaches the midline, we can have contralateral metastasis. Next. As is seen, as is evident in this floor of mouth and soft palate lesions, the incidence of contralateral metastasis increases. Can you see the full slide? Because I can't.
Can
Next,
see,
please.
sir.
Next. Okay, so for management of the N0 neck, we need to accurately stage the neck and establish that it is really N0. And then the second thing is the need to address the N0 neck. And if so, what is going to be the extent of surgery? Now, accurate staging involves clinical examination, imaging, and in of late, there is something called sentinel node biopsy, which has come up, juxtaposition from the breast sentinel node biopsy. So clinical examination alone is very inferior for detecting lymph nodes, and we know that from the study by Merritt et al. That the next week, the CT scan accuracy is far greater than that of clinical examination. And this is landmark study from Chowkar et al., Dr. Dipiti's group from Tata Memorial Hospital, which compared clinical examination, USG, CT scan, and PET CT, and found that overall the accuracy of CT scan was far better. Next. So in addressing the N0 neck, we know that in spite of a very rigorous preoperative workup, there are still 20 to 30% occult metastatic nodes. And we know that depth of invasion, although it is very important in the occurrence of neck node metastasis and prognosis of these patients, these indicators are not available to us preoperatively. So given this scenario, should we treat the neck electively? Next. We know in early cases, we can manage the patients per orally, and we don't necessarily need to enter the neck for management of the primary, like and neck, the reconstruction and all that, which is seen in C3, T4 cases. So there are two methods. Either you do an elective neck dissection or you observe the patients. Now the proponents of both say, for example, for the elective neck dissection, we know that this procedure will deal with the occult. This information that we get about the lymph nodes will also also tell us about what adjuvant therapy to give and when to deliver it. We also will know the various selective node levels, not a complete comprehensive neck dissection to be done. And of course, this translates into better survival. That is what is claimed. Whereas the observation group, they say that we can spare neck dissection, unnecessary neck dissection in 70 to 80% with accurate assessment. This is to be underlined. And if the patient does come back with positive notes, we can do a good salvage with equivalent survival. Next. So a meta-analysis by Fasnula next regarding 4 trials, randomized controlled trials, did say that the forest plot was in favor of elective neck dissection. Next please. And there was a definite reduction in the disease-specific death rate, and therefore they recommended elective neck dissection in oral cancer with N0 neck. So the problem is that this meta-analysis is not without shortcomings. The numbers were inadequate. The follow-up and how they did salvage those necks which did come back was not uniform. And on one of the trials did show that there was a need for a wider and a larger randomized controlled trial. And this question, the very important question, was answered in an original article by Dr. D'Cruz's group from Tata Memorial Hospital in 2015. Next. The trial design randomized the patients into elective neck dissection and wait and watch policy with therapeutic neck dissection. And the second randomization took place in the follow-up scenario in which patients were subjected to only physical examination or physical examination with ultrasonography. Next. So the endpoints were overall survival and disease-free survival. So let's see what happened. Yeah. So there was a definite improvement in overall survival and even a better improvement in disease-free survival. Next. So much so that we could prevent 1 death for every 8 patients that were treated, and we could prevent 1 recurrence for every 4 elective neck dissections that were taken. Sentinel node biopsy is a diagnostic and therapeutic tool. It's a minimally invasive procedure, and it allows the surgeon to identify and excise the targeted echelon nodes. And if this node is positive, then we go ahead and do a proper comprehensive neck dissection. Next. There's a Sentinel European, the SENT trial, which gave us 3-year results, and it says that it's a high negative predictive value and a sensitivity of 86%, but the drawback is that there is a high false negative rate, which is not acceptable. But the one good thing that came out was that it did detect contralateral nodes, which is hitherto not apparent. Next. So the pitfalls are, these are technically demanding, slow, the learning curve is very slow. And the important thing is you have to add serial step sectioning and immunohistochemistry to this sentinel node biopsy technique, which is not available. You can do it at the time of doing the sentinel node biopsy. And of course, it is a 2-step procedure. First, you do the SNB, and then 3 weeks later, the neck dissection if it is positive. And of course, it is not possible for fluoromorph lesion because of the shine through effect. Next. So, what should be the extent of neck dissection? This was answered by a prospective study of more than 500 neck dissections in oral cancer from Dr. D'Cruz's group again. Next, which said that 91% of the lymph nodes were incorporated by doing a level 1 to 3 dissection only, and almost 96% of the lymph nodes were incorporated by doing a level 1 to 4. Next. Next. Yeah, so there were no isolated metastases to levels 4 and 5. Next. So the other thing which came out was that level 2B nodes were associated with 2A nodes next. And if there was a positive 2A node, this was significantly associated with 2B and level 5. Next, please. So the key points for the extent of neck dissection are that the selective neck dissection has similar outcomes to modified neck dissection. Level 1 to 3 or level 1 to 4 suffices for an N0 neck without level 2A involvement. And for those who have level 2A positive, we need to address 2B and 5. Next. Now the depth of invasion, we know it is a key parameter to evaluate risk for occult nodes, for prognosis, treatment planning for primary and adjuvant, but it has to be preoperatively correlated with clinical, radiological, and histopathological evidence, which may not be possible. And we still should have a low threshold for the elective neck dissection. So the recommended policy is elective neck dissection is the default mainstay treatment for clinically N0 neck because it provides accurate staging. It gives good local regional control to the patient in the prophylactic and therapeutic way. It is giving us the information about adjuvant treatment planning and the delivery of the adjuvant treatment. Sentinel node biopsy we have to reserve in a clinical trial setting for very carefully selected low risk cases, clinically thin, less than 2 millimeters, and definitely not for Toro mouse. Next. And future research, therefore, would be concentrating on more accurate profiling of primary tumors to assess its probable biological aggressiveness and then to tailor the therapy accordingly. Lymphocytography and sentinel node biopsy can be used for diagnostic mapping. We have to research this applicability in tumors close to the midline and especially in previously treated patients like recurrent or metaclonal disease setting, because in these cases you have altered or aberrant lymphatic drainage. Next. So in summary, 20 to 30% of oral cancer patients will have a pulmonary metastasis, which will be undetected in spite of the best workup. There is definite survival benefit as has been demonstrated in performing END against wait and watch. We know the SND of levels 1 to 3 and 1 to 4 suffices for N0 neck. 2A positivity may be used to guide the extent of node positive neck dissection for levels 2 and B and 5. And sentinel node biopsy does show promising results as a diagnostic tool, but still has not been proven to be equivalent to an END and should be done only in a clinical trial setting. I thank you for your patient listening and apologize for the delay.
Dr. Sunal, you'll have to unmute your mic, ma'am.
Sorry. Thank you, Sudeep sir, for that evidence-based crisp talk. So we'll move on to our next topic, that is a debate, which is a very age-old debate, and yet we have to come to the consensus of which, and to give it justice, we have two eminent speakers. So the topic of the debate will be locally advanced oral or oropharyngeal cancers, whether we should do NSAT versus upfront surgery. So first I'll call upon Dr. Suhas Agre sir, who is a medical oncologist at Asian Cancer Institute, Mumbai, for giving a talk on NSAT. Dr. Suhas?
Suhas, sir, you'll have to unmute your mic, sir.
Yes. Thanks, organizers, for the opportunity. And this topic will be include the locally advanced oral cancer, basically, rather than the oropharyngeal cancers. And I will be speaking in favor of the neoadjuvant chemotherapy. So why the neoadjuvant chemotherapy? Because we know that almost 30% of the cancers in India, the oral cavity squamous cell carcinomas. According to the Globocon 2018, they constitutes almost 10% of the all cancers. While it is most common among the Indian male, it is second most common among both the sexes. While the problem with the head and neck oral cavity is that 85% will present with the locally advanced disease and which will require a multimodality approach. While the radical resection offers the best outcome, but we know that the outcomes are still far from the satisfactory. So the role of NSAT in oral cavity includes either in case of resectable tumors, which will help in tumor shrinkage, organ preservation, and maybe the data on OS is still not available that much. So again, the borderline resectable tumors, it will help to reduce the surgical margins, increase the resectability, and achieve R0 resection, while in unresectable tumors, it will help to improve the DFS and the OS. So coming toward the data in the resectable cancers, so this was a randomized control trial of almost 200 patients studying the primary chemotherapy in the resectable oral cavity squamous cell carcinomas. So the results showed that the need of the post-operative radiotherapy was reduced by 13% in the patient who underwent the chemotherapy. Similarly, the mandible resection was performed in 52% of the patient with the control arm, while 31% in the chemotherapy arm. So the mandible resection rates were reduced by 21%. So they concluded that the primary chemotherapy seems to be play a role in the reducing the number of patients who need a mandibulectomy or a radiation therapy. And also they emphasize that there appears to be a room for using a preoperative chemotherapy to spare the demolitive surgery and or radiation therapy in patients with advanced resectable oral cavity cancers. So coming toward the another study, it was a phase 2 study from the TMH, and what they showed that the mandibular preservation could be achieved in almost 49% of the patient and without compromising any local control. And as we know that the mandibular preservation is ultimately associated with the improvement in the cosmesis and the functional outcome. So can we select our patient with the good prognosis? As we know that the patient who do respond to the induction chemotherapy are supposed to have a favorable prognosis. So this was a study by Licitra et al. And the pathological CR rate in the patient who achieved a path CR had a 10-year OS of 76% versus the patient who did not achieve a path CR had a 10-year OS of 41% with a significant p-value. So similarly, this was published in the JCO randomized phase 3 trial of induction chemotherapy followed by surgery versus upfront surgery in the locally advanced resectable oral squamous cell carcinoma. What they concluded was that although there was no OS benefit in the study, but the patient in the induction chemotherapy arm with a clinical response or a favorable path response with less than 10% viable tumor had a superior OS and the loco-regional as well as the distant control. So as we can see from the subgroup analysis that there was improvement in the OS and the distant metastasis-free survival in the patient with N2 disease who received NSCT. Similarly, there was a trend towards the improvement and the lowering the incidence of distant metastasis in the patient receiving the NSCT versus upfront surgery. So whether there is in this study, they could not document the OS benefit, but it was thought that it was related to the underpowered studies. In the similarly, Licitra et al., when they planned out for a sample size of 258 with 90% power, the power of the study was reduced to 78%. Similarly, the Zhong et al., the power of the study was only 83%. So to analyze the multiple, although the multiple studies have failed to demonstrate the OS that need to be taken with the caution because of the underpowering of the studies, but the effect of NSCT on reducing the distant mets, mandibular preservation in the tumors without the gross invasion of the mandible and the disease control in the patient with higher nodal stage seems interesting, and it would need a further investigation. So coming towards a locally advanced and technically unresectable oral squamous cell carcinomas, this was a study from the TMH published, and what they included is that almost they analyzed almost of the patients, and the results 700 patients were included, and 43% of the patient had a sufficient reduction in the tumor size and they underwent a surgical resection, while the loco-regional control rate at 2 years was 20.6% for the overall cohort, 32% of the patient undergoing surgery and 15% of the patient undergoing non-surgical treatment had a loco-regional control rate. While the
request you to please conclude, sir, as we're running short of time.
Median OS was also statistically significant. Similarly, this was another study from the TMH itself. They also concluded that induction chemo was effective in converting unresectable to the operable disease in almost 40% of the patient. Another study, they also had a similar conclusion. So the use of induction chemo into T4 cancers who fit the criteria it looks feasible, and surgical resection approximately 40% of the patient, and it need to be considered as a standard of care in this setting. Particularly, we have to treat a patient aggressively to achieve resectability that has shown to improve the survival. The only question whether it would add to the additional toxicity and post-operative mortality and morbidity. 3 studies are there. From the TMH itself, they did not found the increase in the post-op major or minor complication rate. Lysitra et al., although the less than 5% mortality rate, which is acceptable, and Zhong et al. Also did not increase any complication rate. Whether there is any compliance and the tolerability issues of the post-chemotherapy patient, TMS study, almost only 0.7% of the patient had a toxicity. Another study, 3% of the toxic deaths, while Zhong et al., only 1.7% of the patient could not complete the treatment. So overall, it seems that the TPF is well tolerated pre-operative chemotherapy. But I think maybe the number of the percentage is small in this particular studies because the patient selection was quite stringent and they had a fit and the young patient in their study. What we see in the clinical practice is there is slightly higher toxicity and the mortality. Thus, the chemotherapy appears to be a safe option without additional risk of toxicity. And I would like to conclude my session.
Thank you, Suhas sir. So, in favoring of upfront surgery, we have a senior surgical oncologist, Dr. Ajay Jadhav sir, who's currently working with an RNE hospital, Nasik. So, I welcome Dr. Ajay Jadhav sir.
Hello. Am I audible?
Yes, sir, you're audible, sir.
Yeah. Okay. Is my screen shared now? Can you? Hello.
Yes, sir.
Yeah. Okay. Everybody has stuck to the time, so I'll start my talk right now. We're speaking about NSAT versus upfront surgery. So when we are talking of NSAT, what we are looking at, the most important thing is actually the overall survival. Improved resectability, as in tumor shrinkage, improving the resection margins, improved locoregional control, and organ preservation if possible. In that order. Okay. So we decide, actually make it into 2 parts. The first is the resectable oral cancers, wherein you consider NSAT. We have 2 important trials here, Lysitra and from Zone. So the first one, the trial from Lysitra, I think Dr. Agre has already gone through it. So it is a well-balanced trial with around 200 patients, T2 to T4, N0 or N2. And again, as you see, the chemotherapy and the control arm are well balanced. So what you see in the surgical techniques is that, as he has already pointed out, the mandibulectomy rates are lower in the chemotherapy arm, okay, as compared to the surgery upfront arm. But if you look at the overall survival, which is the most important criteria, the curve seems to match and it does not give any advantage in this section. So to conclude, even after a 10-year, 11.5-year follow-up study to follow-up analysis of this study, it did not show any impact on the locoregional control, distant metastasis, or the overall survival, except for in a small subgroup of patients who responded very well to chemotherapy, in which the distant metastasis-free survival was slightly better. But again, the overall survival remains the same. The second study from Zhong, again, around 256 patients, he has already gone through the trial. At 30 months, no significant difference in the overall survival or in the disease-free survival. In both the arms, the survival was around similar. So no improvement in the overall survival. This is again a similar well-balanced study. So if you go through the, as he had pointed out, the patients who have good pathological response seem to show a favorable prognosis. But if you look at this chart, and if you look at the patients, CR and PR showing around 72 patients, 72% overall survival, versus if you look at the other part, which has stable disease or a progressive disease, the prognosis goes down significantly on this part. So it is probably the tumor biology which is coming into play here. Again, the curves here for the disease-free and the overall survival remain similar in both the cases. So from the study itself, it is difficult to discern whether survival in responders who to chemotherapy, is it a response to chemotherapy itself, or is it just a marker of the cancer biology? And again, the author goes on to say that our study is not powered to detect improvement in incidence of distant metastasis. It is just to be considered as exploratory in this scenario because the study was not designed for that. Another meta-analysis, again for overall survival, showing no difference. In this study also, they have said that, again, a subset of patients showed a better survival who had responded to chemotherapy. The distant metastasis is low when the response is good to chemotherapy. But again, overall survival, no difference.
So 1 minute left.
Yeah. Okay. Okay, fine. So organ preservation he has gone through. Neoadjuvant chemotherapy in locally technically unresectable patients. He has gone through the paper with by Patil et al. 721 patients. Median overall survival was slight better in the surgeon arm. And in this subset of patients, probably chemotherapy might give us an advantage. But if you go look at the other studies where surgery was not involved, but neoadjuvant chemotherapy was involved, the tax 323 and 324. If you analyze this study well, you'll see that the overall survival improvement with chemotherapy was mainly attributed to the local regional control. And also the treatment was not optimized, as the surgery was not involved. The patients were treated with radiation only. So these two studies actually cannot be used as a surrogate for good response to neoadjuvant chemotherapy or neoadjuvant therapy being used routinely for surgical patients in head and neck cancers. The paradigm study again involved unresectable or low surgical curability patients, and it did not meet its accrual target. And treatment again was not standard because post chemotherapy the patients were treated with radiation. No surgery was involved. Besides study, again similar planning, it also did not meet its accrual target, and treatment again was not standard. If you look at the RTOG trial, which was not a oral cancer trial, but if you decipher the analysis, again the locoregional control and larynx preservation was significantly better with concomitant cisplatin, but not in the induction RT. So neoadjuvant chemotherapy even in this setting did not help. Different set, NSCT in recurrent settings. Prabhash et al. Had done a study, retrospective of course, 40 patients, 2 cycles of NSCT, no benefit again. Response evaluation, the kind of response evaluation that we use right now, the RECIST criteria or the clinical implications, both can be very subjective, especially in head and neck setting. Yes, and no said that no correlation between the radiological response and postoperative pathological response. And 30%, 35 patients of patients with stable disease, as per RECIST criteria, could undergo surgery with negative margins. So RECIST criteria may not fit in this scenario of head and neck or oral cancers per se. A typical Indian scenario, logistic, financial constraints, tolerance, Indian scenario with poor patients not wanting to coming back, a lot of other things come into play when you're thinking of NSCT. Tumor shrinkage, everybody knows it's not uniform. It can be different types, and you cannot actually decipher the margins accurately. Clinically, I'm saying, when you're planning for surgery and intraoperatively, I'm operating. So post NSCT, what is the extent of excision? Not clear, because Lisitra and Zong had used the preoperative margin status, while Patil in his study had used the postoperative status. Intraoperatively in mandible it's fine, but tongue it may be very difficult to actually define the excision of point of excision when the patient has responded to chemotherapy. Pre-chemo margins during surgery, as I've said, the same thing. What is the effect on extranodal extension? I have no idea how the chemotherapy affects that. So if the patient in the final histopad does not show any extranodal extension, whether he receives radiation or chemoradiation, not clear. Similarly, with the findings being post chemotherapy, does the patient receive adjuvant chemoradiation, RT alone? Because the two trials, main trials, the Licit trial and Zong trials, use radiation alone. Again, may not be standard. And adding chemotherapy to the adjuvant form of radiation may actually have benefited the patient with surgery also. These questions remain unanswered. Role of
So request you to please
HPV
conclude,
and
sir.
neoadjuvant chemotherapy is very debatable. I think I'm done with this. This is my last slide. So there is limited role of NSAT in locally advanced resectable oral cancers. In unresectable, it might help in making the patients resectable to around 30-40 patients, 30 to 40% of patients. And NSAT has failed to demonstrate an improvement in control rates, overall survival in resectable OS. The other things need to be evaluated further. Thank you.
Thank you, Ajay sir. And to have a like justice to our debate, I like to have some expert comment. Quick comments from Dr. Govind Babu sir, who's a senior medical oncologist, and if time permits, I think short quick comment from Anil Dicruz sir as well. Govind Babu sir.
Yeah, basically, I'm a medical oncologist, so I think what has been discussed is really worthwhile. I think Anil will have a good say on this.
Yes.
Anyway, quickly to Sudeep's talk, yes, operating is standard of care. There are two recent publications showing that sentinel node biopsy is equivalent to elective neck dissection. Out in JCO, one last month and one 2 months earlier. It's called the French and the Japanese trial. Equivalence demonstrated, shoulder function better, but it pans out at the end of 1 year. So for the youngsters listening, maybe these are references that you'll have to look at. But treating the neck is imperative. Whatever you do, whether END or sentinel node, it has to be treated. To the second talk, both Ajay and Suhas, I enjoyed your talks. But I think, in my understanding, I think the organizers wanted oropharynx, where the debate is a little more, given that CTRT, which is the standard of care, causes a lot of complications. So whether the neoadjuvant route would decrease then the CTRT and decrease complications as opposed to surgery with robotic, which is a new treatment. But to conclude on this front, the jury is still out. There are a lot of studies going on, some randomized, some not randomized, and hopefully in the years to come, we will get more data. And oropharynx, just this debate has come because the epidemiology or the cause of oropharyngeal has changed to HPV positive abroad, which is biologically a better disease. So with these brief comments, I hand back to the organizers.
So much, Dicruz sir, for that crisp expert comment. So we'll just move on towards our last session of panel discussion. So I invite my moderator, Dr. Nandini Menon. She's a senior medical oncologist working with TMH in Mumbai. The topic of our moderation will be implication of TP extreme versus keynote 048 in metastatic squamous cell carcinoma, head and neck. Ma'am, should I call upon panelists as well?
Yes.
So our panels are Dr. Ankit Patel, who's a medical oncologist from Surat Oncology Center, Surat. Then Dr. Sandeep from Sohana Super Speciality Hospital, Mohali, who's a medical oncologist. Dr. Parthasarthi Roy, who is from medical oncologist from Guwahati, working with Dr. B. Baru Cancer Institute. Then we have Dr. Bhavesh Parekh, senior medical oncologist from Shalby Hospital, Ahmedabad, and surgical oncologist as well. We have a Dr. Harsh Dhar, who's working at Kolkata in a Narayana Super Speciality Hospital. I welcome all panelists and handing over to the Nandini ma'am.
Ma'am, please note Dr. Sandeep will not be able to join us. We request you to please introduce, to involve our chairpersons, that is Dr. Anil, Dr. Ramesh, and Dr. JP Agarwal.
Okay.
Over to you, ma'am.
Yes, thank you. Can I share my screen?
Yes, ma'am, please.
Is it visible, the slides?
Yes, ma'am.
Good afternoon, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to moderate this panel. So today's panel is going to be on the implications of TP extreme and keynote 48 in metastatic or recurrent squamous cell carcinoma in the head and neck. I would like to welcome all my panelists. I think Dr. Sandeep Kakkar has not been able to join us now. So without wasting time, we'll move to the panel discussion. So the panel today, the case for today is a 52-year-old male with right squamous cell carcinoma of the buccal mucosa, who had extensive disease which was involving the high infratemporal fossa and the skull base. And after a discussion in a multidisciplinary team, the patient was not amenable for any curative therapy. So he was referred to us for palliative chemotherapy. So with this, I would like to pose the first question to all my panelists. To start with, Dr. The patient had symptoms of pain, foul-smelling discharge, difficulty in eating and mouth opening. He was fit otherwise. The biochemical and the CVC parameters and CVC was normal with the normal cardiac function, and a TPS was 45%. Patient was explained regarding the need for systemic therapy and the outcomes. So with this, I would like to ask the first question, that is the expectations of patients with squamous cell head and neck carcinoma. What do they expect from palliative systemic therapy? So I would like to ask this question to Dr. Harsh Dharsa. What is your experience when patients are explained that they're going to be treated with a palliative intent? What do they want? Is it only prolongation of life, symptom control, or both?
Yeah, hi. I think the first and foremost important question that they ask of us is specifically the prolongation of life, the longevity, which is associated with various therapeutic regimens. Added to that, of course, symptom control is a very, very important factor that needs to be looked into. So I think both would be my answer.
Thank you, sir. I would like to ask Dr. Bhavesh Parekh, sir, do you have a different experience, or is it similar to what Dr. Dhara said?
Mostly the answer is the symptom control. Looking to this picture, mostly symptom control is the most important, but as we clinician, we also explain them that it is just a prolongation of life. So I think both is the appropriate answer.
Okay. So Dr. Ankit Patel or Dr. Parthasarathy Roy, sir, do you have any other insights into this? What do your patients expect when you counsel them about palliative systemic therapy?
I think, yeah, please go ahead. Please go ahead.
Most of the patients, first, their priority was symptom control, particularly this type of case, difficulty swallowing and severe pain. And obviously, second, their expectation was prolongation of life. On primary, most of the patients, they are asking about symptom control.
Okay.
Yeah, same with me. The first thing is the symptom control, and then definitely the second thing comes with the prolongation of life. So I will definitely go with the both.
Thank you to all the panelists. So this was a study done at Tata Memorial, published in 2016, which also had similar results as what all our panelists have said. So it seems to be the patient expectations seem to be similar across the board and all over the country. That is 41% wanted prolongation of life, 35% wanted both. So I think both symptom control and prolongation of life are both equally important to patients when we counsel them for systemic therapy. So this is further data from the same study, where around 76% of patients who wanted prolongation of life were agreeing, were ready to accepting the daily life disturbing toxicities, and 51% of patients who had wanted both were agreeable to life disturbing toxicities. So this was the maximum preferred financial expenditure per month for treatment that patients were willing to spend. And you can see that there is a definite limitation here, that the patients, very few patients can spend large amounts, which often are required with newer therapies. So since this panel is regarding the keynote 48 and the TP extreme, so in this scenario, I would like to ask my panelist, Dr. Ankit, what would be your preferred regimen in this patient?
Patient having already TPS score is 45, but he is also much symptomatic. So I not only go for only immunotherapy, but Keytruda plus cisplatin and 5, because of a patient require rapid symptom control.
Thank you, sir. Dr. Parthasarathy, would you agree or would you differ in your management plan in this patient?
No, I will also agree with him, because this is a symptomatic patient. So probably I would like to bring chemotherapy in the first go, and definitely I will counsel for cetuximab to add on with chemotherapy for this patient.
Thank you, sir. I would like to ask any of the other panelists, would any other approach would be taken other than chemotherapy with cetuximab in these patients?
Yeah, I would like to add that this particular decision-making process is not a simple one. We need to include various factors into play. First and foremost is the general condition of the patient. Secondly, the rapidness with which the disease is increasing, and of course the symptomatology. So I think all these three factors put into together would help us in making the right decision.
Thank you, sir. So
Nandini, can I just add something?
Yes, sir.
It is also important that it is a primary tumor, which is a very extensive tumor versus a recurrent tumor. So because both the things may be a bit different. So we need to keep that also in that context.
Yes, sir.
What?
Yes. As sir said, discussing the keynote 48, the study had 3 arms. So that was one arm was pembrolizumab monotherapy. The second arm was pembrolizumab in combination with chemotherapy, and the third arm was the extreme regimen. And both the chemotherapy arms in the study used cisplatin and 5-FU as a backbone. And these were the endpoints, the primary, secondary, and the exploratory endpoints. So basically, they looked at overall survival and PFS in 3 categories of patients. That is, those who had a CPS of more than 20, had a CPS of more than 1, and the overall population. And as we can see that the single agent pembrolizumab arm perform better in the patients as compared to the extreme regimen, that is cetuximab with chemotherapy, in patients with CPS of more than 20, in CPS of more than 1, and it was non-inferior in the overall population. But if you look at the progression-free survival, like this table shows, the patients who received pembrolizumab alone initially didn't have such a good progression-free survival. If you look at the 6-month estimate, it was 32% as compared to those with cetuximab and chemotherapy. But at 12 months, those with pembrolizumab had higher progression-free survival. And this was seen in both the PDL1 more than 20 and the more than 1 populations. So this is similar to the responses with immunotherapy we see in other tumors as well, where initially the chemotherapy arms appear to do well. And like our panelists also discussed, that a symptomatic patient with a large disease burden responds better to chemotherapy-based combination. This is the evidence which points to the same. And hence, as the panelists said, the right choice would probably be to use a chemotherapy backbone with either cetuximab or pembrolizumab. So in the keynote 48 regimen, does it control symptom, improve survival, and maintain quality of life? Yes. But finances, as we know, are a problem because of the cost of therapy. So in the same vein of discussion as the panelists discussed before, that symptom control is important in patients who are very symptomatic with a large disease burden. Single agent pembrolizumab unfortunately didn't have very great response rates. They were in the CPS more than 20 population, only 23%. It was 19% in the CPS more than 1, and in the overall population also it was only 17%. As compared to extreme regimen with the use of cetuximab, with 36% of patients having an objective response. So my question to the panelist, Dr. Bhavesh, does the response on symptom control and improvement of quality, equate to improvement of quality of life and outcomes? Is it response translates into better symptom control, better quality of life and outcomes? What is your experience?
My experience is like definitely once the response is better, like in this trial also, if there is a 36% in extreme, then definitely the symptom control and improvement of quality of life is also improved.
So would any other parameters influence quality of life? For example, the extreme had higher toxicities as compared to single agent pembrolizumab. So would that
So
again negatively
because
impact?
this is head and neck primary rather than recurrence, as one of the panelists also speak, I will feel that as a medical oncologist, in spite of toxicity, if my more response and more improvement and quality of life, then definitely I will go for more response because that ultimately gives me a more overall survival also.
Thank you, sir. Do the other panelists, Dr. Ankit Patel or Dr. Parthasarathi Roy or Dr. Harsh, have any different view on this issue?
No, I think Dr. Harish has rightly said out that the chemotherapy definitely would have better response, that which will definitely will give right to better quality of life. But in this point of view, I would like to add on one thing. We can choose a TP extreme based regimen versus extreme based regimen, which is associated with more toxicity. So although cross trial comparison is not feasible, but I will go with the TP extreme regimen, which is associated with acceptable toxicity, with good quality of life, good response to disease, and probably will translate to better survival. So,
Thank you, sir. Thank you. So we move on. Dr. Pathasati Roy said that TP Extreme would be a less toxic regimen because the Keynote 48 chemotherapy backbone was a very high dose of cisplatin and 5-FU. Though the outcomes were good in the study and response rates were better with chemotherapy, the dose of the chemotherapy led to a higher degree of side effects. So my question is to all the medical oncologists in the panel, do you use cisplatin and 5-FU commonly in the palliative setting? At curative setting, we all prefer to use cisplatin-based therapy. And what is the dose that is used? Is it the Keynote 48 and the Extreme, the original protocol, which used 100 mg per meter square of cisplatin and 1000 mg per meter square of 5-FU for 4 days? Or like Dr. Roy said, modified to TP Extreme or other doses of cisplatin 5-FU? So I would like Dr. Ankit Patel to respond and then the others to respond after that.
Definitely, we are in palliative setting, according to patient condition, we are most of the time modify the doses. Either we decrease the 5-FU dose of 750 mg per meter square, or we can go for taxane cisplatin combination also many times, because patient condition is most important. How is the eating? Main problem in advanced cases issue is of dysphagia. So we have to definitely change the dose. In my experience, full dose I can give only one patient in palliative setting, or rest of the 9 I have to modify.
Dr. Bhavesh, would you like to comment?
Definitely the 5-FU dose is rather than 1000 milligram per meter square, we are using 750 milligram per meter square, round about approximately a 1 gram in a rounded dose in a palliative setting, because in palliative setting the quality of life is more important rather than giving a toxicity. So definitely some modification of this dose. Even in cisplatinum also there are sometimes nephrotoxicity also happens. So I will definitely use 75 milligram per meter square rather than 100 milligram per meter square.
Sir, just a question to all the panelists out of curiosity. How many of our palliative patients do we actually on a day-to-day basis use cisplatin 5-FU in our setting, in the Indian setting, in real life, real world scenario?
Dr. Nandini, can I start take this question?
Yes, sir.
So my personal opinion is that since last 1 or 2 year, I am not using cisplatin and 5-FU combination in the palliative setting. Who is fit patient, I am offering them for docetaxel plus cisplatin in a combination with cetuximab, probably if affording. If those patients are not affording cetuximab, then docetaxel plus cisplatin alone in palliative setting. And in a little bit frail patient who are having cardiac comorbidities, probably those patients I am offering paclitaxel plus carboplatin. So that is my take on. So probably I am not using 5-fluorouracil along with cisplatin.
Absolutely agree with Parth Sarthi.
Any other comments from the panelists? So
I would like to add
yes,
that yeah. So in our setting as well, what I've seen from most of the tumor board discussions, there has been a trend towards using the TP Extreme regimen versus the standard Extreme regimen, even at our center for the last 1 or 2 years. So that has been a significant change, which I have also noticed.
Just to add on, Dr. Nandini,
yes,
this is not only the toxicity, this is also the logistic problem. Maybe I'm having chosen 5-fluorouracil, I have to admit the patient, or I have to based on your pump-based therapy. So docetaxel is a single. Only thing is that I have to add GCSF support. That's it. So
yes,
logistic is also feasible.
Yes, sir. Totally agree. That is what we also follow at TMH. The main issues are toxicity and logistics, which I think is practical all over our
Ma'am,
country.
5 minutes left, ma'am.
Oh, okay. So we move to the next. As all our panelists have discussed, toxicity, doses of which were higher incidence of adverse events, death, and again with 5-FU, the issue of DYPD mutations, which range up to 25% in a study published by TMH. So again, this question has already been discussed, so I won't repeat it. It's already palliative setting, cisplatin versus carbo. Many people prefer to avoid using high doses of cis. And as discussed by all the panelists, the TP Extreme study has provided an alternative, though it did not meet its primary endpoint of overall survival. But because of the lower toxicities, it was considered that the docetaxel cisplatin could be an alternative. So this is the interpretation which said that even though it didn't meet the primary endpoint, it could be an alternative standard of care, especially if they are not fit for other therapies. So these are the response rates and the second line uptake with the TP Extreme regimen. These are the adverse events. They were adverse events significantly in both groups, but then the serious adverse events was around 9% lower in the TP Extreme group, with lower 5 deaths less in the TP Extreme group. So this was already highlighted by all our panelists that the TP Extreme regimen seems to be a more convenient and easy regimen. So just as a comparison, this has already partially been answered. What would be the preferred backbone with cetuximab, cis5FU or the taxane platinum?
Taxane platinum.
Taxane platinum.
Yeah,
So
same taxane platinum.
I think taxane platinum is what we would give it our center.
I think
commonly.
TP Extreme is something which is more practical for us, and I agree with the panelists. So this is what we also commonly follow. Just to conclude, in the patients who receive cetuximab-based chemotherapy regimens in the first line, how many patients end up with receiving subsequent therapy? It was around 63% in the TP Extreme arm in this trial, and 40+% received immunotherapy as second line. So what is it in our setting? What do our patients, do they reflect the data from the trial, or is it different? Anybody can take the question.
I think the data of Western data is not exactly reflecting the Indian patient because of this, again, financial burden. As because I am using cetuximab for say about 8 months, 9 months, and after that I am offering the patient for pembrolizumab. So I don't think the percentage will be more than 20-25% in a real Indian scenario.
Thank you, sir. Dr. Ankit, Dr. Bhavesh, or Dr. Dhar, would you like to comment?
Yeah, I think I would agree with that 20% margin. I think that is the same what we've done at our center as well.
Okay, so since there's a shortage of time, I probably will move on to the next. This is already discussed. 44% received chemotherapy, remaining 40 received IO, and this is the QL, which was obviously better with TPEX, and all our panelists agree with this. So this was our patient who had a very good response after 4 months. So just to conclude, the concluding remark from all our panelists, that how would you place Keynote 48 and the TPEX in the Indian setting? Which patients would you prefer Keynote and pembrolizumab based, and which would you prefer cetuximab in our patients? Dr. Parthasarathi, would you like to start? Sir, you're mute. Sir, you're muted.
I'm sorry. Yeah, the patient who is a very fit patient, around 60, 62, no comorbidity, patient had very good, heavy burden of the disease. Response is what is the most important scenario. In that scenario, I would definitely go for TP extreme based regimen rather than going for Keynote 48. Whereas a patient in the extremes of age, performance status allows me to go for not aggressive therapy, slow growing tumor, then in that scenario, probably I will go for pembrolizumab alone therapy. And definitely this needs to be discussed with the patient. Patient will be the particular person who will decide on whether to go for the Keynote or TPX therapy.
Okay, so Dr. Ankit, would you like to add?
If patient having CPS more than 20 and having a high comorbid condition and age factor is considered, then we go to single agent. Otherwise, CPS score more than 20, then go for pembrolizumab plus chemo combination. If CPS score is less than 1, then definitely I will go for TPX.
Thank you, sir. Dr. Harsh or Dr. Bhavesh?
Ma'am, request to conclude as we are
okay,
short of time.
Yeah, I think that's the last question. So just the concluding remark, Dr. Harsh, you were saying something.
Yeah, I just wanted to add that while we're discussing Keynote versus TP Extreme, it's important to remember that therapy has to be sequential. It is a cascading kind of a therapy. It is not just one particular agent that we take and stick to. So we must always think of second line options. And in that, we must not forget the important role of oral metronomic, which has already shown significant, locoregional benefit as compared to cisplatin alone. So I think we need to keep that in mind as well.
Thank you, sir. Just a concluding word from our chairperson, sir. Would you like to say anything, Dr. JP, sir, Dr. Anil, sir, or Dr. Nimmagoda, sir? Anybody who wants to give a final comment?
Thanks, Nandini. So 2-3 things very important. I think we need to differentiate between a primary palliation versus a recurrent or a metastatic palliation. Differentiate between an oral cavity versus non-oral cavity. And lastly, the supportive care is extremely important. We cannot substitute good morphine, oral hygiene, etc. with any of the drugs. So they are extremely, extremely important. That's what I wanted to say.
Thank you, sir. Thank you to the panelists and the chairpersons and organizers. I hand it back to Dr. Sonal. Thank you.
Thank you, Dr. Nandini, and all panelists for the practical oriented panel discussion. And I really just wanted a very quick comment from even Govind Babu sir and Dr. Ramesh as well regarding our panel discussion.
Yeah, this was a good panel discussion, and I think the final thing is, if you are looking at rapid responses, then it is better to use cetuximab with the chemotherapy. But if you think that you can wait for some time and have lesser toxicity, then use immunotherapy. Of course, this was specifically between two studies that was being discussed. Otherwise, we have our own Indian monoclonal antibody of nimetuzumab, which has been used. So we have several options now in India. Unfortunately, the rest of the world does not have this luxury of using nimetuzumab. So I would even look at that as well.
I think the immunotherapy part, I think we should really look at it maybe over time, how it pans out, because that may be the only hope of a long term. Chemotherapy, yes, it gives us quick responses, but we are not seeing long term. So if somebody can afford, and maybe over time it proves to be like lung perspective, subgroup of patients, that's what we should not ignore.
Thank you. Thank you to all my chairpersons and the all participants, like all speakers and all moderator and panelists. And I conclude our head and neck session, and I'll hand over the proceedings to Dr. Kshitij for next session.
Thank you, Dr. Sodhan, for this excellent coordination and excellent discussion by panel. So let us move on to next session, that is a thoracic. As we are aware, in the last few years, the treatment of thoracic oncology, that is a lung cancer for most prominently, has changed a lot with a lot of introduction of targeted therapies and immunotherapy. And we are looking towards this lung as index case or index disease on the basis of which the entire oncology treatment will be designed in future. So let us welcome our chairperson for this session, Dr. S.H. Advani, sir. Dr. Advani do not require any introduction because we know that he is the senior most medical oncologist, and we can say that he is the Bhishma Pitava of our oncology, who has taught majority of our oncologists how oncology is and what to be done. He is a consultant medical oncologist at Jaslok Hospital, Sushrut Hospital, and Reliance Hospital. Welcome, sir. Now we'll move to our first session, that is how to interpret quality of NGS in non-small cell lung cancer. So I welcome Dr. Kumar Prabhakar. He is the most respected name in the thoracic oncology, in the lung cancer, and there will be no other person who can comment on this NGS topic better than Dr. Kumar Prabhakar. So without wasting much time, I will request Dr. Kumar Prabhakar to just teach us about this NGS and how to interpret from a clinician, that is a clinical oncologist point of view. Thank you very much. Welcome, Dr. Kumar, sir.
Hi, can you hear me, Dr. Kshitij?
Yes, sir, we can hear you. Yes, sir. Yes, sir. And it's just to, there is no introduction required, but he is a HOD of Medical Oncology Department in Tata Memorial Hospital. Sorry not to mention that because everyone is aware. Thank you, sir.
Thank you, Dr. Kshitij, for kind words. And so starting with my talk today, and my talk for today is quality of NGS. And primarily, I know that we have a clinicians here. So, and I have around 15 minutes odd. So try to put things in place. What are the things we need to look for? We are happy to try. We are trying to put things in place so that there can be reference for everyone to read. But at this moment, I'll be restricting to put in place what a clinician should be looking for when they get the report. This is a bit of an introduction. What we know that previously we had anatomical classification. Now, subsequently, we had some good histological classification and IHC work. And now we do have molecular classification. We know that in lung cancer, we can't get away with it. Not only that, in many other tumor, if you want to treat anti-RK positive tumor, you don't have to look for which tumor you are treating. They are partly useful, but you can MSI positive, or red positive, in fact, BRAF. So now you do have many more tumors where molecular classification is very important. I am not saying they are required above what we have for histology, but they are required, and without them you can't treat those kind of patients. So we are getting into an era where more and more molecular classification will be required. We know in oncology, whatever is there never goes away. So I'm not saying histological classification is going to go away, but the molecular classification, the kind of value it adds, we are slowly and definitively seeing in many tumors. And I mentioned some of them. Now, some of the tumors and the genes where we do have a targeted therapy. And this is not limited only to this. This is just a showcase that you do have multiple genes which are there in multiple tumors and where you have treatment available. Again, highlighting that we will be doing not only lung cancer, many other tumors, many more mutations as the time goes by, and as we have the treatment available, and as we see the patients benefiting, and we get more reassured, and we'll be doing those tests. Once we have a tissue, once we want to do the test, these are the steps which happens, that you have a pathological review, then you have NGS sequencing. Once you have those sequencing, then you do have a read alignment and mutation detection and clinical reporting. What is important for us to remember that, as we know in everything, in every step, one can go wrong. And this is true for NGS testing also. Starting from pathological review, the sequencing, the read alignment, and the clinical reporting, one can go wrong at any one of those steps. And it is important, once we have the report in our hand, we are able to see that each of these steps are documented, and we are able to see in some form or other these steps are there in the report. If you see the once we order the test, trying to divide some more steps, what you have there. Once you have the test, you have decided. You decide about tumor types, the sample types, and the previous workup. Then you decide the assay, the target gene panel, the whole exome, the whole genome, which you want to do. Usually we do target gene panel at this moment in diagnostics. Then you have a sampling method. You want to do fresh frozen, the liquid biopsy, or FFP. Then subsequently, once you have bioinformatics, that is when once you have the report available with you, you align with genome, call sequence variant, and you have a filter for artifacts. Then you check databases. Once you have the report, it is the known mutation hotspot. Is it actionable variant or not? Does it have a prognostic value or predictive value? And once you have the report, then you decide the action. Do you have a targeted therapy for it? Does the patient, if they don't have a targeted therapy in the clinic, can they participate in the clinical trial, or can they avoid unnecessary therapy the way we do in KRAS for colon cancer? Subsequently, which is not there at this moment in the clinic, but looks like it may come later on, to see the continuous monitoring for these patients once we start treating them. And this time, ASCO, you have more than one paper suggesting that seeing the cfDNA in the blood has a value as far as the prognosis is concerned. And my feeling is that in next year or two, when we have seen the data, and some of our work, which I have seen the data personally in the hospital, looks cfDNA monitoring in some form or other will be there in the clinic in a year or two. Now, as I said, once you want to see the quality of NGS reporting, it starts from what tissue we have given. And this is the first thing we should be looking at the report. When the tissue has gone, have the lab looked into what is the percentage of tumor it is there in those tissues. And what I'm highlighting here, this is a generic one, that usually a lab, if you have more than 20% tumor, they consider it as adequate. If you have 5 to 20%, maybe. Less than 5%, they don't usually consider for NGS testing. There are enough now data that more than 10% also may be adequate. But again, important is that we need to see that in report, has it been mentioned or not? Because if you have less than 20%, then the lab has to do certain work there to see that they get those tumor tissue by microdissection in some form or other, to see then they take those tissue for testing for NGS. Otherwise, there will be a lot of artifacts because the tumor tissue is less, the surrounding tissues are more, and whatever you amplify in the tumor tissue also gets amplified in the normal tissue. So thumb rule remains, more the tissue fraction, reliable the NGS finding is. Look for those percentages. I'm not saying 20% is sacrosanct. It will depend upon the lab and the lab and the technology they use. But having said that, yes, I want to convey that look for those 20%. If they write less than that, let them qualify the statement why they are taking less than 20% to do the test. Next is to see the type of specimen. Histological or cytological specimen was sent. Looks like as the data has gone by, in many of the tests, cytology and the histopathology, that is histological specimen, they give a similar report. It primarily depends upon how much the tumor tissue is there. Molecular testing can be carried out in genetic material from tumor tissue and also cell-free DNA. But again, as I'll be showing in the subsequent slide, once we have the specimen which is not tissue, then again we need to ask different questions in the report, that what are the things should be there, what we should be looking for. Next should be how was the tumor fixation done? We totally forget, because once we have the tissue, we have sent the tissue to the lab, we don't try to see how has been the tumor fixation being done in the lab. We know that biochemical alteration begins in 10 minutes. Less than 6 hours, if you have prefixation time, then FISH and IHC analysis gets adversely affected. More than 48 hours, DNA quality deteriorates and results in the weaker FISH signaling. Formalin fixation is recommended for biopsy specimen. Alcohol fixation generates superior nucleic acid yield but may alter the nucleus morphological detail. Frozen specimen provide high quality of nucleic acid and protein and are optimal for molecular analysis but do not preserve morphological details well. What it means? We are stuck with formalin fixation, but there are sometimes, and this we also learned while doing some of the NGS work, that many times non-standardized formaldehyde treatment worsens the DNA quality. It is important to look into it, what kind of formaldehyde treatment is being done for the tissue. The tumor cell content, mutation testing requires approximately 100 to 400 tumor cells. More sensitive methods are utilized for lower tumor yields. But again, that needs to be mentioned. For FISH, 50 to 100 accessible tumor is good enough. Sanger sequencing, 40 to 50% tumor cell content is required. But for comprehensive genomic analysis, more than 60% tumor cellularity and less than 20% necrosis is important. Again, some information which is will be useful for us once it is there in the report. PCR method, 1% mutant DNA content is good enough. But for PCR and versus hybrid capture NGS, for PCR, if we require 5 to 10 nanogram of DNA, for the NGS, that is hybrid capture NGS, that is a targeted NGS, 100 to 200 nanogram of RNA/DNA is required. Again, this information becomes important to be there in the report, that what kind of DNA and RNA they took as far as the quantity is concerned to take it forward. So what is the thumb rule? Younger the FFP block, better the chance of successful NGS, and non-standardized formaldehyde treatment may worsen DNA quality. Now, once you have a DNA, you want to know what is the quality of DNA. Traditionally, we do nanodrop, but it appears once we do NGS and we try to do it in nanodrop, and it doesn't give you a good a way of deciding what kind of quality of DNA you have. The dye-based quantification, that is qubit, or the fragment analyzer, that is DV200, is preferred for NGS library QC. So it is important again to see what was the method used for checking the QC once the library has been made. Once you have the tissue or the liquid biopsy, it is important to remember that what are the differences we are going to have once we see the report. But bit of a differences otherwise. Liquid biopsy is simple, fast, minimally invasive, easily accessible, captures tumor heterogeneity, and can provide prognostic information. But the limitation typically have reduced sensitivity. Validation studies report 30% of the patient have no alteration in ctDNA when it is there in the tissue. Risk of false negative is higher than what we have with the tissue, and usually no direct correlation with histology or cellular phenotype is possible. And that is important once you have the liquid biopsy as a test to have NGS, and I'll come to that, what we'll be looking in that report. Tissue biopsy remains by and large standard. Liquid biopsy can be considered once you don't have a tissue biopsy, and for continuous monitoring in case the patient prefers or you want to do in a study. Different type of NGS, you have whole genome sequencing, whole exome, whole transcriptome, and the targeted panel. These are the differences, but by and large, we do targeted panel. If we do these different way of doing, but in case many times people do order a whole exome, whole genome also, then these are the kind of data you get out of the testing. Remember, these are sometimes not there in the what is provided to us. But for a good test, what kind of output you got from the test becomes important. So depending upon number of gene and number of mutations, for every test of every panel, they will have minimum amount of data which comes out. And if gets provided into the report, it becomes far important. And this highlights what kind of data you're going to get. If you're getting less, you are getting lesser data, and you're getting lesser report from the test you are doing. What I want to convey is targeted NGS panel are highly optimized and reliable for clinical application. Whole genome, whole exome, and whole transcriptome technology, by and large, people would not use for patient care. It is best suited for research, but yes, sometimes.
So 1 minute left. Sir, are you there? Kshitij sir, I think Kumar sir is having some issues, sir. So would it be possible if we move to the panel discussion and come back to Kumar sir's lecture?
Try once again. Otherwise, we'll move. Will be.
Sir,
it is almost over, I think.
Online, sir. His screen is stopped, sir. He's offline.
Okay. Fine. Okay. So, thank you very much, Dr. Kumar Prabhas, sir. So we'll get back to you once the connection is reset. And now let us move to our next session. So what we have seen in the last few years, there is a lot of different studies that are coming up for adjuvant treatment in the lung cancer. So we have discussed a lot about the metastatic lung cancer, and we'll have more options. But there is a little less discussion about the adjuvant treatment, and we have some excellent results. Like there is a Pacific trial about the durvalumab by tumor PD-L1 expression in unresectable non-small cell lung cancer, and then we have ADURA trial, that is osimertinib in resected EGFR mutated NSCLC. So for this panel discussion, we have none other than Dr. Ullas Batra sir. So we are all him to conduct as a moderator of this panel discussion on adjuvant treatment in the NSCLC. So Dr. Ullas Batra sir, welcome. And he is Senior Consultant Medical Oncologist at Rajiv Gandhi Memorial Hospital, Delhi. Welcome, sir.
Okay, thank you, Kshitij, and
So
thank
I
you.
will also introduce our rest of the panels. Yes, sir. So before handing over to you, I will just introduce our panelists today. So Dr. Indranil Ghosh, Medical Oncologist, Apollo Hospital, Kolkata. Dr. Abhishek Kakru, Medical Oncologist, HOC Cancer Center, Ahmedabad. Dr. M.V. Chandrakant, Medical and Hemato-Oncologist, Narayana Multi-Specialty Hospital, Kolkata. Dr. Ranjan Bang, Radiation Oncologist, HCG Cancer Center, Mumbai. And Dr. Ajay Kolse, Radiation Oncologist, Holy Spirit Hospital, Mumbai. Dr. Ramakant Deshpande, sir, and Dr. Tanvir Majid, sir, could not join because of some prior commitment. So let us hand over this to Dr. Ullas Batra sir for further discussion. Welcome.
Okay, thank you, Kshitij, and thank you, team MOC and ICON, for giving me an opportunity. And I feel very bad for all the audience and the panelists who have to sit on a Sunday 3 o'clock afternoon session to listen to this boring topic. Anyway, I'll try to make it interesting. And again, apologies. I mean, I'm sure Kumar would have made it so interesting. It was such a beautiful session going on. Apologies for you have to listen to me now for next 20 minutes. Maybe Dr. Deshpande was very smart. He knew this will happen, so he dropped out early. So my first reactions when I was asked to conduct a panel discussion on early stage lung cancer, and I saw my esteemed panelists in which there were 3 medical oncologists, there were 2 surgeons, and there were 2 radiation oncologists. Imagine, ladies and gentlemen, in an early stage lung cancer, you have 3 medical oncologists having this, in the discussion. I'm sure, so I would normally ask this question, and the best part is out of the 2 surgeons, both the surgeons are actually not come. So I see Dr. Advani there. Dr. Advani sir, good afternoon. I'll ask the first question to you, if you can tell me, is it the new normal, sir? Sir, you are muted. Yes, sir. So
Yeah,
is it the new normal, sir? Medical oncologists are going to rule the roost in early stage also?
I think it is happening.
Okay.
Whatever, things are coming, they are coming through. Things are happening. I can tell you that 40 years ago, medical oncologist was nowhere there. And then over a period of time, the medical oncologist has almost taken over the metastatic and advanced disease. In the early stage, the integration of the 3 modality treatment has become important. And therefore, I think the medical oncology is going to be a pillar sort of in all the treatment.
Okay, so that is Dr. Advani's comments for this. I think Kumar has joined again. So can I request Dr. Kumar also to be a part of the panel? But I'll ask my radiation oncologist colleague, Dr. Basu or Dr. Ajay, what do you think? Is it the new normal? Medical oncologists are going to come into the early stage lung cancer at least also?
Hi, good afternoon. Why to segregate for one particular modality? I think everybody is required for all diseases now.
Okay.
I think the days are gone that there would be a single modality for early stage disease, because if early stage are living more, then there will be requirement of other modalities as well on that patient's life journey. So I guess it's more pertinent to say that there may be group of thoracic oncologists where you have different categories, requirement of surgeon, medical or radiation. Similarly, a group of head neck oncologists where again you require the 3. So
okay.
With my limited experience, I would
that
put
is
it
absolutely
in this
all
way.
right. That is absolutely all right, and that is what I actually thought. I thought Dr. Ramakant Deshpande would have strongly objected to this statement. This was actually kept for him. And my subsequent reactions basically that it is going to be a team effort. Dr. Basu, you have said it absolutely right. And because we actually believe that in together everyone achieves more when it's a team effort. And this is what we are looking at as a combination of medical, surgical, radiation oncologists, pathologists, intervention radiologists. We're going to help that one person, that is a patient, to get more cure in lung cancer. And that is probably what we are striving for. So let me start with Dr. Indraneel Ghosh now. Dr. Indraneel Ghosh, how early is early lung cancer according to a medical oncologist?
According to TNM staging, we will go for stage 1 and 2.
Okay, and stage 3 will come into locally advanced. And what is your proportion of patients who come into early stage lung cancer?
It's around 5 to max 10%.
Not maximum 5 to 10%. Dr. Abhishek?
Anything which I can send for surgery, I would consider operable, because I hardly see any operable. It's like 1 or 2 a month. They are most of the times
fantastic.
They are
1 or 2
mostly
a month is actually fantastic.
So I was lucky enough to see 5, 6 this month, but they are mostly metastatic. That is what we practice routinely in the clinic.
True that. So very less. Dr. Chandrakant?
So there is a bit of selection bias in this, because I usually do not see early stage. They get away with
The surgeons and the radiation oncologists. So Dr. Basu?
So again, if early stage, then we only get to see either as a discussion or as a point where surgery cannot be done because of medical comorbidities for early stage. So maybe if I say in the last 1 year, because then our role comes big as SBRT. So maybe 5 or 6 in the last 1 year.
Okay,
That
so
too working in
it's
Mumbai.
rare.
It's rare. Yeah,
That's
it's
right.
rare.
That's right.
It's rare.
Working in Mumbai also has its disadvantages. There's a Kumar Prabha sitting over there, who takes away all the thing. That is the working in Mumbai.
No. That's quite advantageous. I would put it different way. Being Kumar sir around is quite advantageous.
I know that. Trust me on that. Dr. Ajay?
Yeah, rarely we see early stage lung cancer, but as Trinanjan has said, they do SBRT, so they do get cases, but we get all locally advanced cases.
So I will now like to get Dr. Kumar Prabha. Sir, are you there?
I'm there.
Yeah. Dr. Kumar, what are your opinions about screening in lung cancer? I'll give you my feedback. Ever since HRCT became the talk of the town and every damn guy got HRCT because of COVID, we have now started to get new lung cancers and early stage lung cancers, other lung cancers. So did we ever needed to prove that screening was important? And do you think screening will get widespread more popularity right now?
First, my apology for that net issue. Screening, there is no doubt that we all know all the discussion what we have. We know that we are missing good number of early stage lung cancer. But I think the question what you are asking is screening the answer? I'll give you one number to get a hang of it. So in a Western world, people were resecting 20-25% of the lung cancer without screening. In Tata Hospital also today, we resect almost 5% of our all lung cancer. When I talk to my other colleagues in other regional cancer center, this drops down to 1 to 2%. What it suggests, there are many more methods to first get into those 20% where we are able to resect them, because screening is a mammoth task if you want to implement. And these are not screening; these are the regular CT scan being done. If you're asking opportunistic scans and other, sure, one should do it. That's where we are missing. But implementation of a screening it is someone did a calculation. The amount of resource required for screening will be enough to treat all the lung cancers, if you put it.
That is right. That is absolutely right. And so, but still, I have a feeling that if you want to catch them young, we have to find out, we have to get more people, the patients under the knife, and we have to get more SBRTs in the early stage lung cancer. We have to give more consolidation RTs in order to improve the survival of lung cancer patients in the early and the locally advanced stages. Okay. Since the surgeons are not there, can I ask the radiation oncologists, is there even a debate, early stage operable lung cancer, SBRT versus surgery, or you will give all operable lung cancer patients to the surgeons? Dr. Ajay first.
No, those who have medical comorbidities, definitely SBRT is a option for them.
A 55-year-old fit young patient, no comorbidities, is saying, doc, do whatever is best for me. I am okay for surgery. I'm okay for radiation. Just convince me. And then I'll ask Kumar to give the final comments on this.
I would go ahead with the SBRT.
You will go ahead with SBRT. Dr. Basu. Dr. Basu, you are muted.
Yeah.
Fit operable, 55-year-old young lung cancer.
I would say fit operable, they should rethink for meeting a thoracic surgeon, because the data for operable is still not very strong for SBRT. Though there are pros and cons for any meta-analysis, because there are no planned randomized control trial. Two trials started, both were closed. But I would still prefer they should have a complete surgical evaluation. If it is really not, for any reason not doing, then for operable. For inoperable, Fantastic. It's a completely different.
One surgeon, one radiation oncologist says to surgeon, second says I'll give SBRT. So as usual, having Kumar as an asset always, advantage. Kumar, what would you do?
As much we all want non-invasive technology for lung cancer, till now it remains surgery preferable. but I do concede as the time has gone by, SBRT as an option, you are more keen to discuss, which was like 10 years back, we were not. So no doubt that option remains if patient doesn't want surgery. Otherwise today in
So I think
localized
surgery,
tumor,
I mean, as Dr. Basu said it, right, I mean, the first option, this thing of saying no goes to surgeon first. I mean, let them see first and then it goes to radiation oncologist. N2 disease, somebody has resected.
always
Okay,
not
sir.
always will last. For
Okay,
example,
not
I'll say,
always. Sir,
like
we will talk about
T3
Adara in
larynx
Pacific,
tumor.
sir. Sir, we will talk about Adara in
I'm saying
Pacific,
I'll
sir.
give you. Sorry.
Okay. Role of post-op RT, lung art trial. Has it changed your practice? Dr. Ajay, Dr. Basu, and if Dr. JP is there. N2 disease, somebody has done it for the incidental N2, T2, N2, M0. Would you give post-op RT?
To be frank, I have not yet treated a post-op RT patient till date. And I feel there will be more cardiopulmonary toxicity with by giving post-op RT. So
Dr. Basu.
I have no...
I agree with Ajay. It's very rare to see, to be honest. Maybe I have treated just one over last 1 year for an N2.
Fair enough.
Yeah,
Dr.
just
JP
one.
Agarwal, Dr. JP Agarwal is there? I saw him at the head and neck session. Okay, not there. Dr. Kumar, you'll have to come in again. Have you guys changed your practice at Tata Memorial after the lung art trial? Dr. Kumar, you're muted.
Yes. Ullas, yes. Routinely we don't give it for N2 disease now, but you do have some other indications which remains, and that.
Fair enough. So let's now talk about what we were asked to talk about. That is the elephant in the house, and that I'm going to ask about the ADORA trial. So let me get my medical oncologist first on board over there. This was the ADORA trial in which people who were resected lung cancer were given 4 cycles of chemotherapy and then were randomized between osimertinib versus a placebo. This was an unplanned analysis because the safety committee said that the data over here, what we saw in stage 1B, stage 2, stage 3A was fantastic. This was presented at ASCO 2020. This is people who took chemo, without took chemo. Both the subgroups really showed advantage over there. The OS has not yet been reached. So, your views on adjuvant osimertinib, is it hot or not? So let me start with Dr. MB Chandrakant. Chandrakant, hot or not?
Oh yes, sir. It's hot, and we must expose all
so
patients.
No, you will just tell me this, and I'll come to this. So hot 1. Dr. Abhishek, hot or not?
No, not.
Okay, 1:1. Dr. Indranil Ghosh, the decider.
Not.
1:2. Let me get radiation oncologist. Dr. Basu.
We'll take opinion, of course.
Okay, 1, 2, no says no, 0. Fantastic. Dr. Ajay.
No, we'll also take opinion.
You will also take opinion. So we are saying 1 hot and 2 not. So let me ask 3 reasons from people. For people who said hot on osimertinib, for people who said not on osimertinib, and as usual, having Kumar Prabhash is an advantage. We all spoke about that. So tell me, Dr. Chandrakant, why is osimertinib hot?
Oh,
and I'm not talking about the wife's temperature right now because it's 3 o'clock and we are still sitting over here. I'm definitely not going to get my food hot this afternoon. Tell me, Chandrakant.
Sir, the hazard ratios for chemotherapy is negligible when compared to the hazard ratio with osimertinib. So I don't know what else we have to wait for, what data we are waiting for.
It's almost like saying, it's almost like saying Akshay Kumar saying, "Ab kya bacche ki jaan loge kya? Itna to difference aa gaya karke." Fantastic. So the hazard ratio for DFS, Chandrakant, that is what was probably you said was hot on osimertinib. So Dr. Abhishek and Dr. Indranil Ghosh, why is it not hot? Abhishek.
Sir, in adjuvant setting, we are traditionally taught to wait for OS. So I'd still like to wait for OS in order to subject a patient to for 3 years of, let's say, what, 40 lakh rupees, 50 lakh rupees. I would like to wait for the OS to mature or come.
If it was 1 lakh rupees per this, it would have become hot.
No, sir, still not.
No, it would still not have become hot.
I would go by the traditional thinking that we need to have some OS advantage for it to be in the adjuvant setting.
I know Kumar is licking his lips to give you an answer on that, but I'll first go to Indranil Ghosh for that. Dr. Indranil, why is it not hot?
Yeah, one thing is that OS, because we don't know the osimertinib is just delaying the metastatic development of recurrence. And some of those recurrences may be just asymptomatic lung nodules, etc., which can easily be controlled with a second line osimertinib or any TKI. And the comparator arm was placebo, which is not acceptable at this date, because we know that the first line first generation TKIs also had some benefit, even though their trial designs were not perfect. We have the SELECT trial with erlotinib. It was a single arm study, but it has shown almost similar results if we compare with that.
Okay. So not hot.
Trial design.
Okay, trial design and OS not being over there, and some small symptomatic recurrences which can be there. Dr. Kumar. Sir, hot or not?
So hot, yes, because this kind of result, I don't remember. I don't know if anyone remembers for DFS of this kind of result with any treatment. I know if anyone remembers. But now, having said that, everyone, there is a counterpoint. That's what the discussion is about. But having said that, cost is an issue. We are living in this is a cost issue in the US. Cost is an issue in India, so that will always be there. But in case we discount it, now then if we look into it, that this data, then it is important to remember. I wanted to ask Abhishek, does he give letrozole, anastrozole, or exemestane?
I knew this
Any
will
chance?
come. I knew this will come.
Yes, sir, definitely. But sir, what about using the traditional geftinib? If at all I had to give something, or erlotinib.
No, Abhishek, that's a different issue. We'll come to that. I'll come to that. I assure you, I'll be happy to. So think about it, and I'll say compare that DFS or PFS with this PFS.
So yes, I agree.
So if you're thinking that now coming to why we say this, why we talk about this, and we will be waiting for OS result. But for the sake of argument, let's agree that OS was not different. I always give people two examples. Go ahead, Abhishek.
So if I can just rephrase, if I had to use it, maybe I would use it for a 3A, or maybe not for a other stage disease, because I'm worried about that 3A guy.
Okay, worried about the 3A guy because you think it's very close to the 4-1.
He's on his limit.
Okay.
Yeah, but he's on his limit.
I'll give you some number for 3 and 2 also.
Yeah, I knew that was again coming.
60% people they fail.
Yeah, I know.
Yeah, 65 if I'm not wrong.
Yes, it is.
So I'll say what we need to learn. I'm not saying tomorrow I'll be giving to everybody, but
I would discuss.
Is there a reason for discussion and a comparison? I'll say compare with I do treat head and neck cancer, and this I learned from someone, and the person taught me you have a patient with 4 years of life, and one patient remains without disease for 3 years and dies on 4th year. Other patient remains disease free only for 1 year and then dies in 4 years. Is controlling the disease for 3 years important or not?
Fantastic. Dr. Kumar, we have Pacific also. So I think this is one drug which needs to be discussed definitely in the adjuvant setting. Whether the patient is able to take or not, that's a different take. We could have discussed more about gefitinib and all, but Abhishek, gefitinib did not really, the DFS did not translate into the OS. That was one, and it does not prevent the CNS recurrence. Number 2, having said that, I know Kumar has a smile on the lip. The survival advantage seen at 79 months was the highest you have ever seen with adjuvant lung trial. So we will continue to debate this. We will come about it later. This was ADAURA at ASCO 2021. Sorry, this was the mobile picture since I took it at 12 o'clock in the morning today. And this is basically what it shows, that if the cost effectiveness ADAURA, if you have the HR value of it, if it causes to it at 25 to 30% OS increase, and if everybody gets osimertinib on recurrence, then it probably is cost effective. Otherwise, it's not. This is just an abstract that I've just seen 2 hours back. I have not really gone into it, but that's the way it is. So we will have to wait for the OS data. We will not go into this. We'll go to Pacific trial now. I hope I have 5 more minutes. How much time I have?
So you have 7 minutes.
Okay, fantastic. So this is what Pacific trial showed, and this is what the updated PFS of Pacific trial showed. PFS benefit at 4 years, OS benefit of 49.6 versus 36.3. So your views on Pacific trial. Now, yes or no? That is what I wanted to ask. Is Pacific trial a new ocean or an abnormal wave? I'll ask my radiation oncologist first. Dr. Basu and Dr. Dr. Ajay, what do you think? After RTCT, would you refer your patient for adjuvant durvalumab? Yes or no?
Single
Just
answer
yes or
would
no?
be yes.
Just
Yes.
yes or no,
Single
and
answer
then we
would
will
be
ask the
yes.
reasons later.
Yeah. Yes.
Yes. Yes.
Yes. Yes. Fantastic. Medical oncologist.
Yes.
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 Yes, yes.
Indranil, you are the only one waiting to get an answer.
Yeah, I told yes.
Okay, you told it. So it's a 5-0. We don't need to discuss anything more than this. So I think everybody has said yes. Now let me say, and that is why we don't need Kumar Prabhash to come over. That is chota mota thing we only can do. Only when it comes to difficult thing, we'll ask Dr. Kumar. Okay. Is there an ideal time to start durvalumab after CTRT? 14 days, 42 days, the initial data said 14 days and people said 42 days. Let's say my patient is 2.5 months later down the CTRT. Did I miss the bus? So somebody, some patient is there, RTCT finished on January 1. It is February 14th now. Did I miss the bus by not giving adjuvant durvalumab? I'll ask Dr. Indranil Ghosh first.
Yeah, I won't say that we have missed the bus. There is some data that even beyond 42, some patients received and they got benefit from real world study.
Okay. So Indranil says we have not missed the bus as yet. Dr. Abhishek?
So there is a French data about 550 patients, if I'm not wrong, which said that after 42 days, 40% of the patients were more than 42 days and beyond.
Okay.
And they still had the same control.
Some benefit. So will you keep a end of the date somewhere around that, or will you say that it's okay, we can give it any time? But there has to be a cutoff,
Sir,
right?
I would stick to Pacific.
Oh, 42 days. So you said I missed the bus. Okay.
No, I didn't miss the bus, but I would try and enroll my patients as early as possible. I won't wait for the later part.
And Dr. Chandrakant?
Yes, sir. We must give we must give this drug because the amount of difference again is very significant. I'm okay up to 3 months, sir.
Okay, I mean that is what even I thought. 3 months is what reasonably things are okay, but the earlier the better. People who took it less than 14 days did much better actually than and that whatever. But that was also the point, that maybe these people were fitter. They did not develop radiation-induced pneumonitis, and that is why probably the advantage was there. The next question which I'm going to ask over here is now. This is something which I get, keep on getting asked every time. Will you do a EGFR and PDL1 status before starting durvalumab? So somebody has got an RTCT done. Now you have an initial block. Would you get a EGFR and PDL1 status before starting durvalumab? I'll start now with Dr. Indranil.
Yeah, this is hypothesis generating at this point because only 6% were EGFR mutant and 10% were PDL1 negative. So definitely the study was not designed to capture that difference in this population. So as of now, I don't do it.
You do not do. Fantastic. Dr. Abhishek?
Sir, that's a gray area in this trial, both
I know
EGFR and PDL1.
There is no black and white areas with me. That is why I kept Kumar also.
It worked in EGFR patients also, although less. And PDL1 is a theoretical wrong in this, probably because they're working on the funda that PDL1 increases after RT. So I don't know whether what PDL1 will do to help us.
Okay. So you do not do. You give it to everyone.
No, sir. I haven't used it in anyone.
Okay, but you would, given a chance, you would.
I would.
Chandrakant.
So I would not do, even though there is data that an exploratory analysis showed PDL1 negative won't benefit. And my gut feeling says probably EGFR, I should give osimertinib. As of now, no durvalumab for everyone.
So can I ask you one thing? We have a trial, and I'm sure TMC Kolkata also has a trial going on, which is called a LAURA trial, in which we are giving osimertinib after CTRT. We also have a phase 4 study of durvalumab going ahead, in which, I mean, we will get it hopefully, in which we are going to give durvalumab post RTCT. Kumar, your point of view on this? Dr. Kumar is there?
I will ask. If I have a trial, see, we did analyze some of our data for durvalumab. EGFR mutation positive. If I don't have any trial, I will give it. If I have a trial, I will sure not give it. I will put in the TKI trial, no doubt about it.
But sir, So, sir, let us say somebody has got, let us say, I would say it's 3-0 in favor of not doing EGFR and PDL1. In my opinion, in my practice, I do EGFR and PDL1 in every patient, even in stage 3 lung cancer. Because in my opinion, EGFR mutant patients, as is shown by this trial, which was published in JTO by Heather Wakely et al., that they do not benefit from a consolidation durvalumab. So, what is your take on that, sir? I mean, let's say there is no trial going on, patient is going to pay out of his pocket.
I will do it. I do it. What you said, Ullas, is true. Yeah, I will do it. And because it, so I may end. I have given durvalumab in EGFR mutation positive patient subsequently, because I don't have a trial and I need to tell my patient. And this is also true that most of the people who have failed, they are mutation positive. Mutation positive majority have failed. It is ultimately the mutation negative and the higher PDL1 they have sustained. So it is a value, it gives you a prognostic value. It doesn't help you in decision making and giving treatment. That is true. But if I have a trial, sure, I'll do it. Otherwise also I concede with you, I do it.
I would do actually. I mean,
also,
I would probably differ. And one more important point which comes to my mind is, you know, if somebody fails in 6 months, leave the last 3 lines of the results.
I was with you. Ullas, I think
Yes,
you got it wrong. I say I
No.
do it routinely.
Sir, you are always with me. That is why I'm here. Otherwise, I would have been sitting somewhere else. Just read the last 3 lines of this. Consolidation durvalumab should be approached with caution in this setting and concurrent CTRT. Basically, you know, let's say somebody you have given durvalumab for 6 months. The durvalumab has got a high half-life. And then when you have to give osimertinib or gefitinib, the incidence of pneumonitis is very, very higher because the half-life of durvalumab and pembro and things are very, very high. So I'm slightly skeptical of giving IO in a biomarker positive patients. That is one. Having said about PDL1, I think it is, you know, splitting here. If patient is biomarker negative, irrespective of PDL1, I am going to give durvalumab consultation. That is my take on that actually. So with this, I hope I have finished in time. I thank all my panelists for a wonderful discussion. And we must remember that nothing lasts forever, not even the COVID virus. It may pass like a kidney stone, like the rest of Sunday will pass now that we are half an hour late, but this Sunday also will pass because lung cancer deserves a cure. And this is my favorite slide. I showed you initially, we were pulling the last guy over there. I'm sure as a team effort, we are going to get the patients, the radiation, surgical, medical, pathologists, IR, counselors, everybody I need together to help the patient. Thank you. And I hand it back to the organizers. Thank you.
Thank you, Dr. Ullas Batra, sir, for this excellent panel. And we believe that this team effort will help us to treat more and more patients. And definitely, before we are moving to our expert comment by Dr. Advani, sir, I would like Dr. Kumar Prabhas, sir, whether he want to conclude his lecture because he was
So I'll be happy to do it, but I think so. If I see the clock, I don't want the program to be late because of me.
Kumar Prabhas, sir, would you like to?
You want, I can make
some. You can just give some.
Fine, sir.
Give some final comments.
Yeah, so I can give some final comments because otherwise the program will get late. So for NGS testing, it is important the all aspect from the tissue, from DNA quality, from library preparation, how the they have used those pipeline to do bioinformatics. Those information not all labs gives us, and we should get into habit of asking those that should be there on the report. Actually, once it is there in the report, we start learning. I learned while doing our molecular tumor board, which we have every week, and there each aspect is put by molecular biologists and bioinformatics people, and that helps us understand that what kind of report we are getting. So I request all clinicians, if we ask, we start asking, you will start seeing that all these reports are all this part of the quality check is available on the reports. That's all from my side. Thank you so much. Thank you so much. And my sincere apology again, for net
Thank
connection.
you very much, Dr. Kumar Prabhas, sir, for this practical guidance that he has given to us. And definitely we'll try to use in our clinical practice. And the final comment, I will request Dr. S.H. Advani, sir, to give final comment on both the sessions.
I think all the experts have done their justice to give us an insight into what are the problems and how to really proceed in future. And I'm sure there are many more trials will come up and will give a light on many other indications where it will be useful. Among all these things, if you look at it, what is really important? Important is that each one of us, a multidisciplinary team, should be extremely knowledgeable, not only just the NGS, but you have to know about the medical oncology in terms of chemotherapy, immunotherapy, and radiation oncologists should know the new word, the precision oncology. So I think each one of us have to become smart and give the best for our treatment. Thank you.
Perfectly agree with sir. Thank you very much, Dr. Advani sir, and thank you very much every panelist and moderator and speaker. So let us move on to our next session. So I will request our senior medical oncologist from MOC Mumbai Onco Care Center, Dr. Vashisht Maniyar, to take over for the session of precision medicine. Welcome, Dr. Vashisht Maniyar.
Thank you so much, Kshitij. The fact that we are having a session on precision medicine probably tells us how the management of malignancy in general has evolved from a mindless bullet with broad spectrum chemotherapy now to probably bespoke understanding of the tumor biology and then defining therapy. Till recently, we are, or rather even now, we consider precision medicine as a subset of a type of a tumor treatment. For example, we do specific mutations in a specific tumor biology, HER2 mutation in breast cancer or stomach cancer, or EGFR cross mutation in lung cancer. Have we really moved beyond looking at the tumor site of origin and only focusing on the biology? Is what an area we will try and address with having a team of extremely well-known and intelligent people with us here. So I have the pleasure of introducing Dr. Rajeshwar Singh, who is a senior medical oncologist at Panchula, and he will be chairing today's session. And the first talk is going to be given by Dr. Devarat Arya, who's a senior medical oncologist at Max Delhi. He's going to be talking about common targetable mutations in uncommon cancer, an approach to them, and are we really picking the right strategy? Over to you, Dr. Arya.
Yeah, good afternoon, Vashisht. I hope I am audible.
Very, very clearly.
Okay, let me just put my slides up on the screen. Okay, I think can't start with conclusion. So thank you, Vashisht. Thank you, Mumbai Onco Care team, for this invitation. Thank you, organizers, and thank you, chairpersons. So it's a very tricky topic that you've given me, Vashisht, and I had a couple of sleepless nights because I have 10 minutes. I thought, how am I going to, talk about all common mutation in uncommon cancer and what is the right strategy? So what I've done is I've taken an example. I'll try to over the next few minutes share my approach to a situation like this. Now we know NGS has gone up by leaps and bounds. Dr. Kumar very nicely shared his thoughts of what a good NGS report should look like. I think the advent of targetable mutations in common cancers actually changed the paradigm of treatment in a variety of ways, and it's very tempting to for a clinician like me sitting in a clinic to actually see if a tissue agnostic strategy will work, where if I have a mutation which I know how to address in a common cancer, and if I find it in an uncommon cancer, will that work? And I think that is the key question that the field of precision oncology is currently facing. Now, what are common cancers? So just for the sake of completion, this is a list of mutations which are currently being explored for a tissue agnostic approach, and this is across all malignancies, both common and uncommon. And therefore, these are some of the mutations that will we will probably face. Now, how common are common mutations? Now, if you look at the Cancer Genome Atlas data, the most common mutation have actually been TP53 alterations, which as of now, in most settings, we are not able to target. In some settings, we are giving them with using VEGF inhibitors. But when you talk about the other common mutations, most of them have varied between 5 to 10% in terms of incidence across cancers. And majority of other mutations actually occur in less than 3 to 2% cases. So this is not a common clinical scenario where you have one common mutation, and therefore it's a very challenging aspect of investigation, where trials are going to be very difficult when the number of mutations are going to be small and you really need to see a lot of patients. So I'll very quickly share a case, and to summarize this case, this is a 54-year-old lady who presented in March 2018 with a locally advanced triple negative breast cancer. BRCA was negative, treated with neoadjuvant chemotherapy, underwent surgery. There was significant residual disease, completed radiation and capecitabine, but unfortunately, approximately 13 months later, had a systemic relapse. Now, at this point of time, patient consulted a doctor in MD Anderson, was advised an NGS, and this is what the NGS report turned. Now, when I saw the report, I said, okay, this has got a PIK3, and I know the PIK3, you have alpelisib and things like that. But then when you look at the disease context again, this is a triple negative breast cancer. It's not just a PIK3 mutation. You're talking about PTEN, you are talking about CDKN2A, and a number of other alterations like MTAP loss and Notch2 mutation. So how do you deal with this? And obviously, sitting in a clinic, these are some of the questions that you're going to have to answer. And I think doing research for these questions becomes very formidable at a lot of times. So is this a common mutation? The mutation that we saw, yes, the answer to that is yes, it's an exon 9 mutation. So it's a common mutation. But has this been described in the disease? Yes, there are 10 to 15% incidence in a triple negative breast cancer. Is there any impact of this mutation in this disease? So while we know through the SOLAR and the BELIEVE studies that alpelisib with fulvestrant or with AIs in later line may be active, but is it really active in triple negative breast cancer? Alpelisib doesn't work in triple negative as a single agent. Interestingly, PTEN loss will also ensure that there's resistance to both everolimus and alpelisib. And there are ongoing trials combining capivasertib with taxanes. Initial results are promising, yet updated results show that the advantage is irrespective of presence or absence of PIK3 mutation. So clearly, interpreting an NGS report can be very painstaking. You have to go through a lot of data, and therefore you have to have a clear-cut approach as to how you are going to deal with the situation. Now, the entire onus is on the clinician to find the right match. I think we have a debate later on the tissue agnostic approach. I think they are going to talk about the Shiva study. For me, the interpretation of the Shiva study was that unless you have a biological rationale in combining a mutation with a particular target, and if the drug is active, only then it is going to work. And if there are a lot of other things, for example, presence of a resistance mutation, or the mutation is actually a common looking but an uncommon mutation, the drug is unlikely to work. So coming back to the questions that we need an answer to. Now, a variety of societies like ESMO and ASCO have actually tried to classify mutations into different tiers. And tier 1 obviously is a setting where you have targets available as standard of care. Unfortunately, most of our mutations that we encounter in uncommon cancers, fall in tier 2 or beyond. There are already tissue agnostic cancer drug approvals. For example, there's approval for pembrolizumab for MSI high tumor or deficient MMR. There's already approval for pembrolizumab for solid tumors with a tumor mutational burden greater than 10 mutes. There's also approval for drugs like larotrectinib for enter fusion, or entrectinib again for enter fusion, but also as a ROS1 inhibitor. And therefore, if you're lucky and you have any of these alterations in the NGS report, there is tissue agnostic approval across the board, and therefore you can use it. Now, there also are some mutations for there is a lot of robust data. For example, BRAF mutation, BRCA mutation, ERB2, again, where even when you have an NGS report that comes to you, you can use some of these drugs. For other mutations, ideally you should enroll in a clinical trial. The challenge in India is that a clinical trial may not be available. And with the COVID epidemic, a lot of our patients may not be able to travel to the countries where a clinical trial is available, where enrollment can happen, and they may get access to drugs which are not available in India or are not marketed as yet. Again, if you don't have a clinical trial, search for data. You will find data, for example, MET mutation uncommon settings, papillary renal cell carcinoma data exists that you can expect overall response rate of 50%. Remember, these numbers are small. If you have a MET or ALK pathway aberration in other tumors like clear cell sarcoma or alveolar soft part sarcoma, it is not going to work. So sometimes you will get data and you will be able to interpret whether the target that you have in mind is going to work or not. It's also important to pay strong attention to the kind of alteration that you're looking at, because similar looking alterations may actually may not mean that the alteration will have sensitivity to the same drug. And for as an example, this study of pamigatinib in cholangiocarcinoma, very or reasonably active in FGFR2 gene fusions or rearrangements, but if you have any other FGFR gene alteration, the activity, at least the responses are not so much, and all you can expect is clinical stability. There's also very important to look at the other coexisting alterations, whether you need to combine therapies, whether they predict resistance. For example, NCI match, which is an ongoing study trying to have, they have 30 sub-protocols trying to match targets to the alterations found. Nearly 1/3 of these patients had mutations which was expected to confer resistance to the planned target, and then those patients were excluded. So it's very important to look at those potential targets. Similarly, IMPACT-2 study, a retrospective study, showed that there was advantage in terms of failure-free survival and overall survival when you had a matched targeted based therapy offered to a patient compared to a non-matched targeted therapy. But they also found that for patients with a PIK3 mutation, if you have any alteration in the MAP kinase pathway, targeted therapy does not help. So important to look at, what alterations there are. A tissue agnostic approach may not work. We all know about BRAF V600, how beautifully it works when you're dealing with a case of malignant melanoma. But then when it comes to colorectal cancer, it's not going to work. Similarly, we have seen with drugs like imatinib, HER2 inhibition with trastuzumab, pertuzumab, that the response to therapy will be also dependent on the histology, the histology that you're dealing with, and therefore a tissue agnostic approach may not always work. This is a lot of work, and I think there are some manually curated precision oncology knowledge databases which can be used. Makes life easier. You can fill in the biomarker, look at the alterations, look at potential clinical trials, look at potential clinical data. That will help. I think Dr. Kumar Prabhash was talking about having a molecular tumor board. They are known to improve outcomes. You have to sit with your molecular oncologist, pathologist, if possible, a bioinformatics specialist, geneticist, and try understand, analyze, interpret the report better so as to be able to have better results in the clinic. And lastly, a molecular biologist and oncologist, even if you don't have a molecular tumor board, there has to be a two-way interaction with a molecular oncologist to see whether the alteration can be targeted and whether that targeted therapy is going to be better than whatever alternative that you may have. So I'll quickly conclude and say that the advent of NGS means that you have mutations coming up in your reports and common genetic alterations and common settings. I don't think as yet we are ready for a tissue agnostic approach as a broad strategy. As a clinician, I would always, having looked at my NGS report, want to search the relevance of the alterations, the relevance of coexisting multiple alterations, how they impact treatment. If possible, encourage a patient to enroll in a clinical trial, use resources like online tools, molecular tumor boards, whenever possible. And if I've used a drug and if I've had any toxicity or a response or lack of it, publish the personal experience. Thank you very much. And back to the organizers.
Thank you so much, Dr. Devratarya. Now you know that why we give you such topics, because you're phenomenally good at them. You are demystifying topics which are shrouded with mystique. Moving on to the next lecture, I have Dr. Joydeep Ghosh, who's a medical oncologist at TMC Kolkata. He's going to be talking at the other end of the telomere. He's going to be talking about uncommon mutations in common mutation-driven cancers. What's new? Over to you, Joydeep.
Thank you, Dr. Vashisht. So I'll start off right away. Good afternoon, everyone. So I'll be talking about uncommon mutation in common mutation driven cancers. So when it comes to common mutation driven cancers, the first thing that comes to my mind, everybody's mind, is lung cancer. We know that EGFR is the most common mutation found in lung cancer. Almost 90% of mutations found are EGFR mutations are either the exon 19 deletion or the exon 21 substitutions. But there are 10% of lung cancers which do have uncommon EGFR mutations. For example, the G719X, sorry, the G719 S768I, L861Q, exon 20 insertions. So I'll be talking about them in the future slides. So if you look at the 18 to 21 section, the common ones we know. The uncommon ones are those in the exon 20, that is G719X. Then we have the insertions in the exon 20, T790M, S760I, and in exon 21 we have the L861Q. So these are all the numbers. I understand it's sometimes difficult to remember those numbers, but this is how the things are. And if you look at the response and the efficacy of TKIs to uncommon mutations, it is definitely less compared to those who have common mutations. And this pie chart shows me that the most common distribution of these uncommon mutations are the 719X and the exon 20 insertions, and followed by the rest others. And there have been multiple retrospective analysis to look at the data that we have for the effect of TKI on these mutations. So for example, for the exon 18 G718, we have prospective data with a 77% response rate and a median PFS of 13.8. Similarly, for the exon 20 S768, we have another prospective study of 8 patients, unfortunately, which had a response rate of 100 patients. So the TKI was second generation, that is afatinib. In exon 21 L861, we again had a couple of retrospective studies and one prospective study which showed a median PFS of 8.2. And similarly, in exon 20 insertions also, there are a couple of studies which showed a response rate, although quite dismal, at around 9%, and at PFS also a dismal 2.7. So this tells me that of these rare mutations, probably the worst ones are the exon 20 insertions, which do very badly with the TKIs, available standard TKIs, followed by the L861 and the S768I. Now, these are the drugs that have been recently approved. We have the amivantamab molecule that has recently been approved by FDA for treatment of exon 20 insertion, because it directly blocks the exon 20 EGFR moiety. We also have the drugs like poziotinib and mobocertinib, which are looking at the inhibition of exon 20 insertion. As I pointed out, FDA has granted an accelerated approval based on a phase 2 study, which has shown a good response rate of this particular rare situation where we really do not have much agents. So although there are data, but still the treatment of these uncommon mutations are rare, and mostly it is extrapolation from standard EGFR directed therapies. Now, switching gears to colorectal cancer, we all know that I'm not going to the details of cetuximab, bevacizumab, etc., the anti-VEGF and target therapies, but recently there is increase in the usage of PD-L1. Also, we have a trial for PD-L1, so that is one of the rare options that we have. So these are the series of trials that has been conducted for colon, and these are the specific targeted therapies. For example, if we have the BRAF mutation, we have the options of vemurafenib, dabrafenib, as well as the combination of Encora, binimetinib, and cetuximab, as shown in the phase 3 Beacon trial. Although the improvement in the survivals has been very modest, 1 or 2 months, but that's the only high quality data that we have. So BRAF is one of the targets that we can use. HER2, yes, I think a lot of us are using HER2, and there are in clinical trials which have proven some efficacy compared to chemotherapy alone. Although in subsequent lines, you can use it as single agents also. There are trials looking at that. And this is a huge list of the newer molecules that have been targeted. For example, you have PIK3 mTOR inhibitors, you have AKT pathway inhibitors, then you have various TKIs also looking at the EGFR pathway. So the list goes on, and if you open the clinicaltrials.gov, you'll be perplexed by the number of drugs that have been tested. Every single molecule has already been targeted in colorectal cancer, and it's still getting targeted every day. So this is in short how we are trying to target the various aspects of colorectal cancer. We have the VEGF and the EGFR, which have been the older ones. Now we are getting slightly into the c-MET inhibition, the PI3 kinase mTOR pathway inhibition, and also some specific BRAF mutation like the encorafenib, trametinib, etc. So this is in short how we should molecularly evolve our treatment paradigm when it comes to colorectal cancer. This is suggested by the NCCN. This is an easy chart. So if we have progression on the initial lines, we can actually look at these mutations, BRAF, HER2, etc. And if we have these inhibitors in our hand, we can use it. Now, these are the list of the drugs that are being tested now for breast cancers. We have breast cancer has been beaten and battered when it comes to targeted therapies, especially the HER2 and the ER positive tumors. But the other pathways are relatively rare in breast cancer, like the NTRK pathway or the PIK3. PIK3 is still common, but the other pathways are quite rare. So the number of trials are probably less in that situation, and they are not showing much efficacy also. Even the immunotherapies are not being very bright in the aspect of breast cancer. Now coming to head and neck has also been not been much of a success story when it comes to targeted therapies. We have EGFR, PIK3, cyclin-dependent kinase pathway dysregulations, and DNA pathways, BRCA, etc. There are initial studies with these drugs, but none of them have shown a significant benefit as for example, palbociclib is also being used in head and neck cancer, but it has not shown significant benefit as of now in head and neck cancer. So head and neck largely stays combinations of immunotherapies as well as a combination of cetuximab plus chemotherapy. And thyroid, yes, although I wouldn't say it's a common tumor, but still we do have the BRAF pathway option of targeting BRAF pathway in thyroid cancers. There is a list of other mutations also which you can look for in the NGS panel. And now switching gears to the lower down, like for example, endometrial cancers, people now differentiate endometrial into 4 subtypes: the pole type, the MSI, copy number high and copy number low. These are all based on the mutation profile that they have, out of which the pole type is the most favorable one with a very good survival. So now there are strategies which are looking at de-escalation of the pole mutant endometrial cancers, like for example, omitting the adjuvant radiotherapy or omitting the adjuvant chemotherapy also. And the PROTECT-4 trial is basically looking at that, whether they can molecularly classify endometrial cancers and based on that de-escalate based on a adaptive Bayesian design. And talking of endometrium, close is ovary. Ovary is also, like, other than BRCA, which is very common, so I've not included in the list. P53 is found in high-grade ovarian cancers, the type 2 variants, but as Dr. Ari has rightly pointed that we cannot target P53 as of now. And there are other KRAS and BRCA mutations also, which are seen in some of the variants of ovarian cancer. Like for example, if you get a mucinous, you can do KRAS mutation and treat it like a colon cancer rather than an ovarian cancer. Similarly, there was a drug called binimetinib, which was tried once in low-grade ovarian cancers, which are expressing the specific pathway alteration, but it has not shown the light of the day, unfortunately.
So 1 minute left.
Yeah, so so there are multiple trials looking at these particular mutations, and most of these trials are in the phase 1 and phase 2 stage. So I'm sure we will see a lot of targeted therapies also in ovarian cancer coming up. So this is the extensive list. So a lot of exciting and confusing times ahead. And lastly, just one slide on melanomas. Also, this is another area where we have a lot of targets in place. Some of them are already well recommended and some of them are coming up, like for example, the NF1 pathways, the P10 pathways. So, and the list goes on like that. So definitely, we are looking forward to these molecular targeting agents in the next at least 5-6 years of time. Let's hope for the best. Thank you for the opportunity.
Thank you so much, Joydeep. I think that was very succinct and quite interesting, because now we are moving when we have so many targets available, and it's very heartening to know that for every uncommon mutation, there is a drug in the pipeline. So it may not be long when these uncommon might again become common. Moving on to the next session, we have now an interesting debate. After hearing these two lectures, one often wonders, is histology really required at all? So the debate is it time to treat cancers based on their mutations over histology? Or as Dr. Devraj said, that no, it's tissue agnostic approach, which is still the king. So for the first talk, I have Dr. Praveen Mahajan, who's a very senior and a respected histopathologist at Sir S.L. Raheja Hospital. He's going to be talking about, and he's going to be saying about, no, histology is still the king. Over to you, Dr. Praveen Mahajan.
Thank you, Dr. Vashish. So you can hear me, right? Hello?
Yes, you are very clearly audible. Yes.
Oh, thank you. So thank you, Dr. Vashish. And since the 1 o'clock, you are all hearing that how the mutations are very important in the diagnosis, and so many discussions which have happened here on this platform. But here I'm going to say that no, the histology is still king. We have not yet come to the era where mutations will take over histology completely.
Dr. Praveen, your sound, sorry to interrupt, your voice is muffled.
Oh,
Yeah,
sorry.
Yeah.
So here I'm going to tell you that histology is still important, and you cannot, histology is not going to overrun by just mutation analysis. And for this, I'm going to cite few examples, and because the time will be less, I'll be short and brief. So to introduce the histology, which we do by using very simple technique, which is called as hematoxylin eosining technique, gives us a vast information about the tumor type and the classifications not in a short time, as well as it is very, very economical. And there's so much of information is given that includes diagnosis of the cancer, what is going to be the prognosis of this particular cancer or the patient, and how it's the prediction that the response to the therapy it's going to predict. And not only that, it also, when you examine the surgical specimens, it tells you about the pathological staging, as well as if you are given a new adjuvant therapy, it also tells you how much response this particular therapy has given for the members are still treated with only the information which is gained from a pure histopathology report. And this is when I'm saying only histopathology, there are things which we use as ancillary techniques like immunohistochemistry also. But for the sake of debate, I will say that this is the part of only histopathology. And if you take the cancers which are treated on the basis of mutational status are still few in number. And the cost for doing these mutational studies, as well as the treatment which are given for these mutations, are still very high. This cost is so high that it's going to be still a major constraint for this target therapies, especially in the resource poor settings like ours in India. So I would like to give you a couple of examples why histology is still king. And I would quote here Dr. John Rosai, who is a very eminent, he was very eminent surgical pathologist of this century. And he has written that there is no technique in all of the medicine that provides so much information so quickly and for such little cost as the H&E technique. And there are two examples which I cited, and I thought was very important to tell you how histology is still very important. So first example is that if there is a biopsy of a cervical lymph node in a 25-year-old woman, which shows a papillary carcinoma having features which are called nuclear pseudoinclusions and psammoma bodies. Now, as a pathologist, I know that if I see something like that in a thyroid, in a cervical lymph node, then most likely it's a papillary carcinoma of thyroid. So what the pathologist examining this section will be able to tell my fellow clinicians, and this it is like this. This patient has a metastatic tumor in this lymph node. The primary tumor is located in the thyroid gland, most likely in the homolateral, that is ipsilateral lobe. It may be very small and not detectable by clinical and radiological means, but trust me, it is there. It is made up of epithelial, more specifically glandular, and even more specifically thyroidal follicular cells. It is likely to be accompanied by multicentric microscopic foci throughout the gland. And if radiation had been administered to the neck of this patient during infancy, you should assume a causal relationship with the tumor.
So
Other
1 minute left, sir.
Sorry?
1 minute left, sir.
Okay. Other cervical lymph nodes likely to be involved, and particularly those in cervical in the central compartment of the neck. The other areas of can be involved by metastasis will be the lung, and if you are to give any treatment, then this tumor is most likely to respond to the radioiodine, and that the patient is going to alive for 10 years from now on. So much information can be given just by the looking at it. Another example is a 72-year-old gentleman having a malignant spindle cell tumor in the neck, having necrosis and the blood vessel invasion. And what information can be passed on from this? Just looking at the HNE slide is that this tumor is very similar to spindle cell sarcoma, but it is an undifferentiated carcinoma having a sarcomatoid appearance, and it is of follicular origin. And this is like progression from a previously well differentiated tumor. Even though now the well differentiated tumor is not there, it could be a papillary carcinoma of thyroid, which was a differentiated tumor, and this is an anaplastic carcinoma of thyroid, and patient will definitely land up with the lymph node and distant metastasis and may not even live for next 2 years, and we will most likely die in a few months. So what are the drawbacks we are looking at when we just use molecular techniques without even taking into consideration histology? For any molecular technique, you have to have identification of proper tumor type from where it is originating, or the histogenesis, as well as the subclassification of the tumor is very important when you are going to interpret molecular results. So one example I will give is of lung cancer. You know that in there are two very common tumors, which are adenocarcinoma and small cell carcinoma. And if you find any EGFR mutation in a lung adenocarcinoma, you know that it is going to be sensitive to tyrosine kinase inhibitor. However, if you find same EGFR mutation in small cell carcinoma, that is not going to be sensitive to this kind of therapy. Similarly, other example would be BRAF V600 mutation, which predicts the sensitivity for this again TKI, which are used in melanoma. But if the same mutation is seen in the colorectal cancer, and that is going to nullify the favorable outcome of anti-EGFR monoclonal antibodies. So you cannot interpret molecular test without integrating the histology. So another example I would like to give is that if you have a mutation or an atypical molecular result, it does not indicate that it's going to be malignancy or a particular type of tumor. You know that RAS mutations are seen in benign tumor like follicular adenothyroid, as well as malignant tumor of the thyroid, which is a follicular carcinoma thyroid. So if you send tissue directly without doing histopathology for RAS mutation, so you may not be able to tell a benign tumor from a malignant tumor. Similarly, NTRK gene fusions are seen in so many tumors here, which is like pituitary carcinoma, breast, mammary analog secretory carcinoma, salivary gland, cellular mesoblasthic nephropathy, and the list is so more and more. So if you just do this gene fusion without doing histology, you may not be able to tell which tumor it is. So these findings are going to be very common in the future when we are going to study minute amount of cell-free DNA from the plasma. And so the role of pathologist and histopathology will be going to be very, very important. To conclude, I would like to say that the amount of information that histological examination gives is staggering. And to again quote Dr. Rosai, he has written, the microscopic appearance of a tumor as seen in an HNE slide represents the grand synthesis of thousands of genes working in concert and sometimes in opposition. In addition, there is probably no single gene that plays an important role in neoplastic process whose expression is not manifest in one way or another as a morphological finding that can be detected by those with proper training and ability. Therefore, from a practical clinical standpoint, the challenge of any new technique is to demonstrate that it can provide information of prognostic or therapeutic significance beyond the provided by current gold standard. And what is the current gold standard? It is a histology, which we do by doing simple H&E, and it is still till date, it is a Sundar, Sasta, and Tikau. Thank you. Thank you for the opportunity.
Thank you. Thank you so much, Dr. Praveen. I think that's a lot of perspective. When we're talking about the future, it's essential to not, forget the past as well as the present. To counteract your views, we have Dr. Mukul Garote, a young and a science-oriented medical oncologist. He's very research-driven. He's at Mukta Cancer Care Hospital in Nashik. He's going to be talking about and he will be debating your belief, and he believes that it's time to look beyond histology. Over to you, Dr. Mukul. Mukul, are you around?
So you'll have to unmute your mic, sir.
Yeah.
So let me have a confession in the beginning. My wife herself is a histopathologist. So I'm sorry, but for a debate concern, I would be going, yeah, it's time to look beyond histology. So this was first of all in 1994. Our pathologist bias by clinical information was a study done, and there was found that pathologists do have a bias with the clinical information that was being provided. The bias was removed by IHC that was done. So there was an inter-observer bias that we have, especially in lung cancers. Lung cancer is a prototype where we have a targeted kind of a therapy that has been well established. So limitations of histopathology, now we have prophylactic surgeries being offered in hereditary carcinomas. The limitations is that it can be little used in carcinoma of unknown primary. Targeted treatment cannot be treated on histology. Predictive markers cannot be commented upon, and resistant to current treatment cannot be gauged. If you find on the right side of the optical cousin of microscope is there, that is telescope. We initially had an Hubble telescope. Now we have a James Webb Space Telescope to see out in detail the galaxy. So in this histopathology segment also, we need to go beyond cellular diagnosis. So earlier tissue histology based chemotherapy were non-targeted. There used to be a very big problem. MSS used to be the nemesis. Neutropenia used to be the limiting thing. Now we have a targeted chemotherapy with an oncological addiction being proved. So we have the best example is non-small cell lung carcinoma, where we have a lot of agents to be targeted. Now this is a slide where we have all the tissues, all the tumors where we have targeted chemotherapy being approved by the FDA. So the problem was what to target with additional researches and additional papers coming up. Now we are getting up into the driver mutations and passenger mutations. We can also classify between the stem mutations as well as branch mutations, and we can target accordingly. So with the knowledge of oncological addiction and EGFR, the EGFR are very cheap drugs, and they can be given, the ease of administration is also there. So this was the trial which proved anaplastic lymphoma kinase, that is ALK inhibitors have also been launched. We have PD-L1 inhibitors coming up. Trastuzumab in HER2 has already been talked upon. And we have also CDK4/6 inhibitors in chronic myeloid leukemia. My previous speaker has said about the 10% normal, but we consider 10% alteration in log of BCR-ABL as a normal alteration in CML management. Whenever there is more than 10% alteration, we consider it as a progression in CML. We have 2 papers published on a specific oligonucleotide, where we used allele-specific oligonucleotide to prove how imatinib should be prescribed in CML. Am I audible?
Yes,
hello?
You are audible. You are audible.
Am I audible? Yeah.
So this
was the snapshot of our response when we followed our allele-specific oligonucleotide in an M351T mutated CML, where we used a very high dose of imatinib, and this was the response we got. So in a nutshell, we need something more than histopathology. We need a targeted therapy to give that kind of a response, where we have a 0.00054% of BCR-ABL left over. So that is the minimum level that we can achieve. So we can also get about the downstream mutations, where we can target, if at all, BRAF, what the speaker has said about colon cancer in BRAF. We have a downstream mutation in MEK, which we can combine with BRAF. Then we have a T790M, which can come up later on. Now we know that osimertinib can be prescribed in the initium also, but it can be prescribed even after a downstream T790M mutation occurs after a previous TKI has been given, or for that matter, T315I has been. So take home message is treatment of cancer is entirely different from what we used to learn. Beyond histopathology is what is important. Limited data on actionable mutations, although, but with time we will have that also. So post-translational modifications may hinder the current knowledge that we have. Yes, we need to move on into era of immunology. So we need the data beyond histopathology. We should not miss the histology, but we need to see beyond histology is what I would say. Thank you.
Thank you so much, Mukul. I'm sure you're going to have a tough time at home with your wife post this lecture. I think a very interesting session, which probably combines the fact that there is no one right way, and we will need to utilize all the agents that we have at our hand and move beyond. Precision medicine is looking at tumor agnostic behavior, looking at driver mutations, and providing your patient with the most bespoke therapy with an attempt to minimize the drug-induced worsening of quality of life, and at the same time improve quantity of life as well. I would request the chairperson of the session, Dr. Singh, to summarize his thoughts on precision medicine, and then we can move to the next session.
Thank you very much. I think all the speakers have laid out their case very strongly. This was a difficult session. I mean, first understanding what the headings were was difficult. Then how you see, precision oncology is coming in a big way, and this is a fact that we have to deal with it. In the first lecture, tissue agnostic strategies, though it is found in less than 2%, but if we find those in those metastatic setting, they have a good response. But we have to see in a holistic picture, we have to see the histology, we have to see in the tumor boards, we have to discuss and treat accordingly. As far as the uncommon mutation is concerned, we have seen the plethora of mutation and treatment options are there in lung cancer from an holistic approach a couple of decades back to so many drugs we have. But the problem is that there are so many uncommon rare mutation where drugs are effective. So simply seeing a EGFR report is not the answer. We have to see as per the database whether the particular drug is actionable on that or not. So we have to start testing, encouraging patient to go for these tests. And as far as histology is concerned, still remain, we were trained like this, or oncologists are trained on histology-based treatment, but definitely we have to move on from there, because we are trying to change this cancer from a fatal disease to a chronic illness, and probably the holy grail of cancer, that is, we want to find a cure of cancer, in which precision oncology is going to make a big impact. Thank you.
Thank you so much, Dr. Rajeshwar sir. I think that was very succinct and clear in terms of how the session has moved. And I would like to thank all my panelists and the chairperson for being in a part of this session. I request Dr. Kshitij Joshi to carry forward the gauntlet to the next session. Thank you. Over to you, Kshitij.
Thank you, sir. I'll just move on to the next session. This is a sponsored session 1, which is by Pfizer. It gives me great pleasure to introduce our coordinator for the session, Dr. Smith Sheth, who's a medical oncologist from Mumbai Oncocare Center, Mumbai. Over to you, sir. Dr. Smith?
Smith, you're muted. We can't hear you.
So, without wasting any further time, the topic of discussion is addressing unmet needs in ALK treatment landscape. And our speaker is Dr. Kumar Pravash, who's a medical oncologist from TMH Mumbai. So, without wasting further time, over to you, sir.
Hi, Kashish. Please allow me to share the screen.
So, you can share the screen, sir.
So, Kashish, I'm audible?
Yes, sir, you're audible, sir.
So, good afternoon, everyone, maybe late afternoon. And my topic for today's presentation is addressing unmet need in ALK treatment and the landscape. So what I'll do is I'll brief what are the data till now, some issues, and data from our own center. Starting off the landscape for actionable mutation, and what we can see here, that actionable mutation in Western world and in our world, this is our data, which published in Annals of Oncology, remains similar, but not the same. You have different mutations, some of them are different. The proportions are definitely different. EGFR is different proportion for with us, KRAS is different proportion for us. This was for adenocarcinoma. Subsequently, we published for squamous, and we are due course going to publish for small cell lung cancer profiling data. So this highlights that ALK is maybe the second common lung cancer where we have a drug which is available in India. Now you do have for KRAS also, but having said that, which is easily available in India. Coming to ALK and lung cancer and the treatment development, from discovery of the mutations to having the drug in the market was fairly small. In fact, the drug came into the market in 4 to 5 years. And now you do have multiple options which is available, and at least 4 of them is available in India also. And many more are in pipeline. And interesting is we'll also see how the recent development of drug has been. Starting with the first-line treatment and the current first-line treatment options and the current status. These are the treatment options, crizotinib, ceritinib, which remains one of the important drugs today also in India, considering the cost of the other treatment, which is alectinib, lorlatinib. Brigatinib is not available. And if you compare the two groups, looks like the two groups, there is a perceptible variation in the outcome once we see those numbers. Starting with those, the first generation TKI for ALK mutation positive patient in lung cancer, crizotinib was better than chemotherapy and ceritinib was better than chemotherapy. Usually we don't do cross-trial comparison, so we won't do it, but both of them, they were better than the chemotherapy, and the control of disease was 1.5 times or double in one of those studies which you will look for. Subsequently, the first generation TKI, that is crizotinib, got compared with alectinib, and this was an absolute surprise, definitely for me. I thought TKI being better than chemotherapy was possible, and did happen. But one TKI will be remarkably better than the other TKI, and this is here the case. The control of disease became 3 times than the control with the other TKI, with the progression-free survival with alectinib of 34 months. And I need to reiterate that many of the curative tumor, which we treat with so-called curative intent, they don't have this progression-free survival. I'll remind you, chemoradiation in lung cancer, the progression-free survival is not 34 months. It is, in the best case scenario, if you give durvalumab, then also remains around 15, 16 months. And if you don't, then it remains around 7 to 8 months. Esophageal cancer, similar data. So this is really remarkable for stage 4 lung cancer. That disease control is for almost 35 months with a tablet which can be routinely given in the OPD. Now, this was not alone. Brigatinib was compared with crizotinib, again showing a similar result. And at the same time, lorlatinib was compared with crizotinib, again showing the similar result. And again, I want to highlight here that at 12 months, progression-free survival improved from 39% to 78%, almost 40% improvement in progression-free survival. Again, this is what we have not heard in the past. And that's why I say a very remarkable result when one TKI was remarkably better than the other TKI. But looks like now we see this quite often, which we have not seen in the past. Not only that, these newer TKIs, they also were able to address one of the key problem in driver mutation positive patients, especially EGFR and ALK, and especially in ALK, that is the brain mets. And it appears that they control, or they go to the brain better than the previous TKI, and control of disease is again better than the first generation TKI. And this remains true for alectinib also. Now, challenges for second line treatment, that is resistance. That patient, as much we I'd say tom-tom about the significant development, we do know that ultimately the patients develop resistance to the TKI. And that is around 53 to 71% because we expect them to fail as the time goes by. Amongst all resistance, 29% of the patient develop G1202 resistance, which is difficult to treat mutations. And CNS metastasis, again, in spite of all the treatment we have, a majority of the patient, when they fail in the brain in ALK positive patients. This development of the drug was very important, and this is one of the rare designer drug where it was understood what is the required as far as the crizotinib is concerned in ALK, where one can block the pathway to have a better development and have a better efficacy. And when those modifications were made, it was found that what was done in the lab was seen in the clinic, that yes, there was a better activity for this drug. This was developed initially as phase 1 followed by phase 2, and what we can see with the phase 2 data, that once you have these kind of phase 2 data where almost all of the patients, there is some reduction in the size, we know that these kind of drugs, they get approval. And so we knew that time that this drug is going to get approval. And as for surprise for us, that majority of the patient in the brain also had some response to the some response of tumor when this drug was given. Again, that was remarkable for this drug. Coming to mechanism for acquired resistance to ALK inhibitor, and that's important, which may help in deciding treatment in future. So despite first-line ALK inhibitor demonstrating high activity, pattern of resistance may include isolated CNS progression or various form of extracranial progression. And what kind of mechanism we have? That is ALK amplification, ALK mutation in 1/3 of the patient, and there are activation of oncogenic bypass pathways, which is bypassing the ALK pathway, and here it is EGFR, HER2, MET, KIT, and these are the pathways which gets activated. Apart from that, drug efflux pump in CNS, which leads to flushing the drug from the brain where you have this failure. Depending upon the drug we give, what we have learned, you do have a different kind of mutations in these patients. And what we see here, that in crizotinib, ceritinib, and alectinib, you have those different kind of mutations which happens. And what we have seen as the time goes by, and as the number of TKI the patient gets exposed, the different type of compound mutations increases. And as far as the lorlatinib is concerned, it appears the secondary mutation in ALK kinase domain can induce resistance to the first and second generation TKI, which we talked about. And lorlatinib, if we see the activity in the cell lines, it appears it has a broad spectrum activity, and it works in a mutation where none of the drug works, and that is ALK 1202 mutation, which is very tough to treat. And this develops more and more as the tumor gets exposed to various type of TKI during the treatment process. Now, subsequently, in this study of lorlatinib, the various patients where they were exposed to various TKI, they were they participated in the study, and this was the clinical evidence to suggest that lorlatinib demonstrated anti-tumor activity against all 5 of those common mutations, and again highlighting that the most tough to treat G1202 are mutations where there was activity for this drug which has not been seen in other TKI, suggesting that lorlatinib had the broad activity against most of the ALK kinase domain mutation which patients develop during the therapy. Now, efficacy according to the number of ALK mutations, but it has also been observed that as the time goes by, as the patient develop different kind of mutations, the patient do accumulate multiple mutations in one tumor. And it appears that for lorlatinib also, the activity of lorlatinib decreases if the patients have more number of mutations as compared to single mutations in these patients. Highlighting the same thing, that lorlatinib, if you do have a compound mutations, it does have activity, and especially again G1202 but if you do have a compound mutation, then the activity of lorlatinib goes down. This is one of those charts which we see, or picture we see more often, that we do see in TKIs as we have exposure to different drugs, and as the time goes by, the patient develops different mutations in these patients. And as we can see for lorlatinib, patients do develop multiple mutations once they are exposed to it, and that is the mechanism of resistance, one of the mechanisms of resistance for lorlatinib, and we have to look into how we can overcome it as the time comes in future. Coming to the adverse event with this drug, it is a bit toxic drug. You do have some of those side effects which is common, and if you treat 10 patients, you will see these side effects pretty commonly. So increase in lipids, it is almost every patient gets it. So almost every patient I have treated, they have increase in cholesterol, and by and large, you end up starting statins. Peripheral edema is fairly common and sometimes troublesome, not always. Cognitive effects and the speech effects, these are not so common, or mood effects, but it does happen, and sometimes it is troublesome for our patients. It does lead to temporary dose interruption and dose reduction in 1/5 of the patient. In these, once we treated with lorlatinib, highlighting that this drug is very useful, but maybe a bit toxic than other TKIs, but very effective. Now, I'll share our experience of ALK-positive patients, and this is the data from 2013 to 2018 March. And what we can see, this data highlighting that is, yes, in our population also in different groups. So we had this almost 300 odd patients out of 441, which we treated with TKIs. How we treated TKI upfront, TKI followed by chemotherapy, followed by TKI, or few cycles followed by TKI. You do have what we see that in our patient also, or 4-year survival varying from 40% to 60%, depending upon the way we have treated. Highlighting that in our population also, in ALK-positive patients, if you give TKI and treat them appropriately with different drugs, then outcome we do talk about not in months in today's time. In ALK-positive patient, we do talk about in terms of 4-year or 5-year survival. I'll be showing you some more data. This is the long-term survival data we just analyzed, that we took the patient to 2016, and we had all the patients having at least 4-year follow-up beyond the last patient. So you do have patients from 2013, so you have a good number of patients who has almost 7 to 8 years follow-up in this an analysis. And what we see that if we have given crizotinib first line as compared to other lines, then again we're talking about 5-year survival of around 45% if we do give them TKI in first line, as compared to second line, where it goes down to around 30%, suggesting that we need to expose the patients to TKI upfront if possible in these patients. We also try to analyze the data that if you have given ALK, again beyond ALK, means you have given crizotinib, then followed by the ceritinib, alectinib, or lorlatinib, then it appears the patients do better as compared to if you are not able to give TKI. So it is important that we expose the patients to TKI followed by TKI, and the median survival was 46 months as compared to 30 months in this population. We also analyze the data. This may be useful for some of our colleagues, that if they had the performance status 3-4 also in ALK-positive patient, the median survival in these patients also ranged to around 14 to 15 months, highlighting that in ALK-positive patient, if they are performance status 3 or 4 also, they need to be treated with TKI, and they will have a good palliation with some decent life. And performance status 2 patients, yes, good number of them can have long-term survival also, suggesting that poor performance status patient in ALK who are ALK-positive, they are not a contraindication to not to give TKI. One needs to give TKI to them to have a good outcome in these patients. Yes, the outcome is worse than performance status 0-1 in this situation. Some data regarding our lorlatinib experience, which we had access to, based on our compassionate program. This is around 41 odd patients, and what we see, majority were ALK positive, 3 patients were ROS1 positive, majority were adenocarcinoma, and majority of the patients were third line and beyond treatment. So meaning that they were patients who had really resistant disease, and brain mets was in almost half of the patient. The best response was seen in almost 60% of the patient, which is a bit higher. And here highlighting that ROS1 patient also, they do respond in the second line, and that is 1/3 of the patient. They do respond in the second line setting if you give lorlatinib to them after failing the first line TKI. Adverse event, as I suggested, it's common. As I told, that almost everyone, they get increase in cholesterol, and you do have some patient developing LFT dysfunction and some patient developing QTC, which we monitor pretty closely. This is the progression-free survival that was around 15 months. That is in third line and beyond setting, by and large, to most of the patient. And this is PFS with and without brain mets. Looks like both of them to do well because this drug goes to brain very well. And we did a cost regression analysis. Any factor which impacts the outcome, looks like no, this drug works in most of the scenario very well. This is the overall survival data, and looks like median overall survival around 60 months odd. This was when the follow-up was relatively small. We have done the subsequent analysis, which now the median follow-up on when we started this treatment for all patients is around 20 months plus. And what you can see here, out of 21 patients, 22 of them now also they are on treatment and they have been continuing the treatment. This is the smear plots showing that yes, these patients, they benefit with the treatment. When they benefit, it can be long-term benefit. This is the data for overall survival now, which we have update follow-up. This group of cohort of patient has a median follow-up around 47 months. And what we can see here, that median survival of these patients were 64 months. What it suggests, if you're able to give crizotinib followed by next TKI and an effective TKI, then the median OS of these patients can be really long in these patients. I need to acknowledge, Dr. Amit, who was our fourth year now consultant in Mahavir, who made the slides. And the last one, I forgot to acknowledge Dr. Pratik for my NGS talk. Thank you so much. I will happy to take the questions, if any.
Dr. Smith, sir, it's yeah. Sir, we're not able to hear you, sir. So if we have any questions from our panelists, we would love to take them up.
Sure, if there's any question in the chat box, I'll answer. Otherwise, if there is any, I'll be happy to take.
So it seems we've not received any questions. So with your permission, can we move on to the next?
So, Kashish, if no questions, then back to you.
Thank you so much, sir. Thank you so much, sir. Now I request our coordinator, Dr. Sonal Dandi, to please take the next session forward. This session is sponsored by AstraZeneca.
Before that, it was an excellent lecture by sir. So we'll start with our next sponsored session. It is a panel discussion, the topic being the more commonest mutation seen in the metastatic lung cancer, that is EGFR positive, managing complex cases. Moderator being a senior most medical oncologist, Dr. Krishna Prasad sir from Mangalore Institute of Oncology. And I'll just introduce the panels as well. We have with us as a panelist, Dr. Akhil Kumar from HBCH and MPMMC from Varanasi, Dr. Taha Sajjiwala from SRJ and CBCC Cancer Hospital, Indore. Then we have Dr. Mehlam Kausar from Indore Cancer Foundation from Indore, Dr. Shaunaf Walami from HCG Manavata Cancer Center, Nasik, and Dr. Vikas Salreza, Regency Hospital from Kanpur. So over to you, Krishna Prasad sir, and welcome in our ICON and by MOC family.
Thanks a lot. So can I start?
Yes, sir.
Yeah. So first of all, I thank the organizers for this opportunity. So if I can start with the case. So a 75-year-old lady with no smoking history presented with cough and breathlessness, and you can see the chest x-ray showing significant pleural effusion on the left side. Patient underwent diagnostic tapping and the cytology came as positive. She is a diabetic but well controlled. So this patient has got adenocarcinoma in the cytology. So what next? If I can start with Dr. Vikas, in your clinical practice, somebody has got pleural effusion. It is stage 4. It has come as malignant pleural effusion. What are the tests you would normally do? And what are the tests you want to do but cannot do it? Dr. Vikas?
Thank you for the invitation, and thank you everyone. An excellent presentation by Dr. Kumar sir for giving us a brief overview of the NGS. So definitely would like to say that would like to process the pleural fluid cytology and cell block and put it up to the broad gene panel, especially including the EGFR, ALK, ROS, MET, NTRK, and HER2/neu, but with the limitations of the finances and other thing, the essential I would definitely put for is the EGFR, ALK, ROS, and the BRAF testing for now, because they come with a generous grant from the coupon from the pharmaceutical support.
Okay. Anything else? Would you investigate further in terms of staging, or this would be sufficient?
With the pleural effusion positive, as I suppose it to be, it is no doubt an advanced stage of cancer. So probably will need to do a scan for finding out the baseline where all the mets is. Could be a CT scan, abdomen. Would love to do an MRI brain also if finances are not an issue, to find out the baseline brain met states also.
Fair enough. Dr. Akhil, if I can get you here. So this patient, Dr. Vikas, has asked for cell block and got these investigations, asked for the molecular testing. In addition, what are the other investigations you'd like to have? A PET CT or anything else?
If I need to get a good scan which includes thorax and at least upper part of the abdomen. If that is available, that is good enough for me to start the treatment. PET CT, we do not use it as a routine procedure in all the patients. But if patient is very willing and pressing for it, I will be okay with it. But usually we do not prescribe PET CT as a compulsory investigation in all these patients.
Excellent. Dr. Shaunak, in your practice, what are the things you do and what are the things you would have liked to do but can't do it?
Yes, sir. So yes, I routinely do a PET scan of the whole body and a contrast MRI of the brain to rule out brain mets. And besides the histology for molecular testing, the usual suspects EGFR, ALK, ROS, HER2 and BRAF, and PD-L1 testing as well. So out of this, I think only about 50% of my patients do end up doing the entire panel. And then considering certain profile like a middle-aged non-smoker female, I might shorten the panel to only an EGFR, ALK and ROS.
Fair enough. Dr. Mehlem, what are the minimum mutation testing you do for most of your patients?
So most of the patients, I mostly go ahead with EGFR, ALK and ROS1 and PDL1 and counsel them for the further testing. But considering the history, if female non-smoker, again, as the sir said, that I mostly restricted to EGFR, ALK and ROS because of the financial constraints.
Dr. Taha, in your practice, are there any patient nowadays with adenocarcinoma lung where you don't get mutation testing done?
No, sir. Adenocarcinoma lung, definitely. Mutation is the first choice, sir.
Yeah, I think actually we are in India are in a pretty sweet spot, even though we are financially challenged with the help like how I think Dr. Vikas has already told us. Invariably, most of our adenocarcinoma lung patients will get a mutation testing done, at least EGFR all cross. This is not the case all over the world. If you look at it, the maximum EGFR ALK testing is done in Japan at 90%, around 87% in the US and Western Europe, and then in rest of the world it is pretty less. I think at present, at least in 2021, ours must be at least more than 90%. I think all of you would agree on that. In fact, there are some newer studies which say that up to 91% of them will get an EGFR testing done. This is the commonest mutation testing done. So if at all, are there any barriers to get everything done, Dr. Vikas?
So barriers are always there, because when you look at the barriers, there is a logistic major concern. So always, in my part of world, people get a diagnosis on cytology based, because they are reluctant for most of the times the biopsies. So tissue is always an issue for us for most of the time. Then always the finances, because the complex of these mutations without the pharmaceutical support would be around in a good 1,000 range, again causing a much more problem for it. So apart from the molecular the labs from where we get it, many over the past few years we have seen an upsurge of many of these labs. So the quality reporting always has an important endpoint, because we see discordance between labs for various EGFR and other reports. And another issue is the turnaround time, which you rightly mentioned, because many of these labs are not situated in the tier 2, tier 3 cities. So the transport to the labs into the tier 1 cities, and then the reporting of then leads to a good chunk of loss of time. And also a very important point which you have highlighted is the lack of communication. So you have to, sometimes while you advise them that you have to preserve the tissue for the molecular testing which we are most interested in, and by the time the tissue reaches to the molecular person, it has been exhausted by the pathologist with a range of IHC markers. While we need only 2-3 IHC markers to confirm it's a lung cancer, we need 3 IHC markers for that. It's an adenocarcinoma. They perform a huge spectrum of IHC markers, depleting it every testing, and then causing it a lot of issue for it.
Yeah, I think because you put it beautifully across, a lot of times the pathologists use up most of the tissue and we have absolutely nothing left. So I think I think all of us basically, I think purposefully or not, are coming from tier 2 and tier 3 cities. There is nobody from the metros in this panel. So I think all of us have these issues of getting the test done. Most of our hospitals don't do it. We need to source it out. So it's an issue. So is there a point like this? Because when I went through this paper, even when molecular testing is done, far too often optimal treatment is not administered. This is not in India, this is in US. Is that happen? Does it happen in your practice, Dr. Akhil, that you have sent for investigations, but you do not follow it? I mean, this is very surprising for me that evidence suggests that oncologists are testing too little and ignoring critical information when available. Does it happen, Akhil?
So this in government setups where I am working, that is Tata Memorial, this actually does not happen. But I completely agree this might happen in other centers. I am completely aware that this is possible.
So actually, this probably happens more in the Western world. If you look at this paper, because the PDL1 testing is available immediately, you can see that many of them who are PDL1 positive, they are started on immunochemotherapy rather than await the results of mutation. Probably that will not happen in India because of the financial issues also involved. So imagine this comes as squamous cell. The cytology comes as squamous cell. Dr. Shaunak, do you think any differently from adeno, or would you still do everything which is supposed to be done?
Yeah. So in this current case, I won't think differently because she's a female, she's a non-smoker. I in fact have a similar case. She's a 60-year-old, got her tested, she's EGFR positive, and now she's on afatinib.
Okay.
So I'll do that.
Okay, Dr. Taha, what about you? Which are the patients of squamous cell carcinoma you will consider doing this mutation testing? Taha, are you switched on?
Sorry, sir. I was muted. Can you hear me now, sir? So again, young females, non-smokers, mutation testing is a must. Although it's a squamous, but still we have around 5 to 7% possibility of them being EGFR positive. Also, PDL1 should be done, sir.
Dr. Mehlam, are there any patients nowadays whom you don't do?
Sir, in adeno, no, sir. Most of the patient, at least we counsel for EGFR, ALK, and ROS1. In squamous, as previously sirs also mentioned, like if female non-smoker Asian, and in that cases, definitely would like to do mutation analysis and PDL1 also. But in adeno, so definitely.
So I'll just put across some papers. This is a Chinese paper, Importance of EGFR Mutation Analysis in Squamous Cell Carcinoma or Non-Small Cell Carcinoma favoring Squamous Cell Carcinoma. So if you look at it, the EGFR mutations were found in 5% of patients with a biopsy of pure squamous cell carcinoma and in 46% of patients where it was reported as non-small cell carcinoma favoring a squamous cell. Similarly, if you look at it from close by, I think from Tata Hospital, Amit and Kumar Prabhash have put up this paper, EGFR mutation in squamous cell carcinoma of the lung. In fact, they found out that the percentage positivity is 4.5%, which is higher than many of our ALK, ROS, BRAF mutations, which we are searching for. And in fact, it did not make much difference whether the patient is a smoker or non-smoker. In fact, 34% of them were smokers. And it made a significant difference if they were treated with TKIs, concluding that EGFR mutation, even in squamous cell carcinoma of the lung, predicts a better outcome if patients are given TKI, but may not be as good as adenocarcinoma. Now, what I would like to highlight is in NCCN guidelines, the definition of a small biopsy is probably there or probably not there. Because what happens is one of the indications of getting a mutation analysis done, like how smoker, a female with probable biopsy showing a squamous cell carcinoma, how big a biopsy is a small biopsy. So NCCN guidelines says if only a small biopsy specimen was used to assess histology, bracket, that is not a surgical resection. Dr. Akhil, your thoughts on this?
Yeah, so as a policy, we test all patients of squamous cell carcinoma metastatic at baseline also for EGFR and ALK at least and PDL1. These three are the minimum markers which we use. If we need to use broader panel, we will directly do NGS plus PDL1. That is our take which we follow.
I think it's fair enough because if you look at it carefully, when somebody has got a 8 centimeter tumor and you biopsy it, how many times are you actually going to hit the correct area? You might hit the squamous cell area and that patient might be having adenosquamous. Vikas, your thoughts on this?
Totally agree that the tissue is always heterogeneous. The tumor is always heterogeneous in its approach. Every NGS, when we process it through the molecular testing, runs through a quality checkup when it says that the tumor DNA should be somewhere more than 20% to be analyzed. And as a policy, we are trying to bring in the change in tier 2, tier 3 cities where only a single core biopsy used to be done just to confirm it was a cancer. Now at least we push our intervention radiologists to do at least 6 core biopsies so that we get an adequate tissue right now, because we are looking for molecular testing. We are looking for testing that to put a broad gene panel in our mind. And that's where I believe that the molecular testing and the tissue testing, it's not a single thing, it's an evolving trend. So that's why in every cancer we see that with evolution of therapies, with evolution of cancer down the lane, you need to have a rebiopsy, you need to have a relook at your tumor to see whether you picked up the right place or the tumor has evolved, and that's how the science is going to evolve.
Fair enough. So if this patient, gets a DEL19 mutation positive, what would your treatment of choice be if you are planning for a TKI? What is the usual TKI you actually deliver in practice, and which is a TKI you would love to deliver in practice? Dr. Shaunak?
Sorry. Yeah. So again, I'd like to know what is the distribution of metastasis, whether CNS is involved or not, because that would kind of push me towards one TKI or another.
Okay.
But
No
otherwise, if I,
CNS metastasis, just malignant pleural effusion.
yeah, yes, sir. So osimertinib would be the ideal TKI of choice, but I cannot deliver that to hardly 10% of my patients. So most of them do end up taking afatinib.
Okay. Dr. Mehelam, what about in your practice? If you are going to choose a single agent TKI, which one would that be? And actually, how many of them actually get it in practice? And if not, which is the alternative drug you use?
So ideally, I would love to give osimertinib, but again, hardly I'm able to give to even 5%. And most commonly use gefitinib, sir, because it's easily available and it's cheap actually. That's why mostly single agent TKI gefitinib, or if erlotinib, because of the easy availability.
So Taha, in your practice, if you are looking at osimertinib, which I assume you will as the first option, what are the things which goes through your mind? Why do you select osimertinib and not the other drugs?
So with the current data, whatever is available to us, osimertinib has shown a better PFS and OS when it comes to stage 4 adenocarcinoma lung. Also, the if you look at the side effect profile, it has done very well compared to other drugs. So definitely, and CNS penetration also. So these 4-5 points where I think osimertinib takes over all the other TKs.
So I gather Taha has put it across beautifully that the efficacy, the safety, as well as CNS penetrability is what drives him towards osimertinib. So if you look at this, the overall response rate as well as duration of response is maximum with osimertinib. It has touched 80%. Most of the other drugs, the response rate is around 70%. And the duration of response is maximum with this. Of course, these are cross-trial comparisons, but 17 months is the duration of response with osimertinib. So the best overall response rate, the best PFS, like how all of you have pointed out, of 18.9 months, as well as the best overall survival. This is probably the only drug which has shown clearly overall survival benefit, even though there are other good drugs like afatinib. Afatinib, there is no overall survival benefit. Archer, there is an overall survival benefit that is immersed in statistical issues because it was a hierarchical statistical analysis. Overall survival cannot be assigned a hazard ratio. Also, like how Taha has told, this is probably the most safest and one of the easiest drug to deliver. In apart from gefitinib, probably this is the easiest one to deliver. The discontinuation rate is around 10% compared to gefitinib of around 8%. Rest of the things are quite high. Also, like how Taha has mentioned, excellent CNS penetrability. And I think Dr. Vikas or Akhil also wanted to know whether patient has got brain metastasis, because that would drive him towards osimertinib. So NSCLC guidelines is pretty clear that osimertinib should be the preferred recommendation in first line. So what about sequencing? Vikas, when do you actually think about sequencing? Is it a good idea?
Definitely. So the first therapy is the best therapy which we should be going for.
Okay.
My preference would be in concurrence with all the panelists, but we have a very good data as a part of the TMH team that we tend to use not only on the TKIs alone, we tend to combine with the chemotherapies if osimertinib is not an option. So gefitinib or erlotinib with the combination of the chemotherapy would be my first options for non-affording patients. and then subsequently to look for the T790 and then put osimertinib if that was not an option for new. And in any case, we have a very robust data that has come right now that post osimertinib you add anything. So you add IO, you add bevacizumab. You don't have much options because they did in the ASCO. The presentation was done, and the chemo didn't have any difference between addition of IO and the bevacizumab to it. So post osimertinib, yes, definitely a dismal thing to look forward to. So I also agree that if we have to look for the overall survival, probably sequencing with afatinib followed by osimertinib has a overall survival advantage, especially in the Asian subset of the population. So we have to choose between. We have to think it as how much we have to plan in advance. And also a very important point that nearly 20-30% of the patients don't get the second line as options, because when they progress so bad that they are not deemed in a performance status fit enough to get a second line therapy. So a very intimidating thing to choose between the options.
Akhil, what about you? Are you pro sequencing with probably afatinib? Your thoughts on geotag, or are you against it?
So definitely one point I would completely agree, that first therapy should be the best therapy, because we all know the paradigm has completely changed now, and we completely agree, everyone will agree that if similar in the prostate, where we were using docetaxel abiraterone in the second line after becoming CRPC, now we have shifted to using it in HSPC setting. Similarly, the concept here is despite having if you have a good drug available and if patient can afford it, I will be pro to use it. I will not keep it for the second line after getting a T790M mutation. Dr. Vikas sir has already highlighted that around 20 to 30% patients will not be able to receive the second line drug. That makes a good difference. Also, there is high chances that if patient develops CNS metastasis, the quality of life can become so hampered that even if you can give osimertinib, that might not lead to significant responses in the second line, or even if it's responding, there might be already permanent neurological sequel which precludes the benefit of the drug. Also, one important drawback of the geotag study which I would like to highlight is that in this study, those patients who had dropped out of the afatinib arm could not receive osimertinib were not included in this analysis. So this is definitely a big bias in this study.
Fair enough.
So 5 minutes left.
Dr. Shaunak, you also agree with this, that there are some issues with the geotag study, even though it shows a median overall survival of 41 months?
Yes, sir. I'd like to use the best one first.
Okay. So I think all of you agree that, if you do not use osimertinib upfront, only probably 3 out of 10 would get osimertinib. This is because we are still not smart enough to figure who will ultimately get an EGFR T790 mutation upfront when we see the patient. Not everyone will be well enough to receive additional treatment like you have told, and no, we are still probably not good enough when we try to do a second biopsy. Does race matter, Dr. Taha? Do you think differently? Because in Asian patients, Archer study showed significant benefit, whereas the flora, the curves mixed together. Do you think because we are Asians, or really do you think we are Asians?
So I mean, where we practice, I think the race doesn't matter. Whatever population we get, I mean, for us, this data doesn't matter much. But as per the whatever studies have shown that even the Asian population for geotag also, afatinib followed by osimertinib, they had done better. The survival rates were much better. Okay. So looking at the data, race matters. But for my practice per se, I don't think I care much.
Fair enough. So I think if you look at the FLORA trial clearly, in the Asian group, the curves actually separate very early and remain favorable for osimertinib up to 3 years. At this point, the number of events are so low, there is a high degree of censoring. So I think just because it overlaps after 3 years, I think we should not discard osimertinib. Second thing is, I think Asian patients in this actually mean East Asians, not Indians. So will type of mutation change your choice, Dr. Mehalam?
So if it is an exon 19 or exon 21 mutation, definitely if exon 19, I will be more, data has shown that osimertinib is much more higher response as compared to exon 21, but it won't change that much because in both the subsets, osimertinib has shown to be effective. But yeah, if it is some kind of an uncommon mutation, then definitely the treatment pattern might change.
Fair enough. Why I brought this up is because again, the Archer study showed that the efficacy of dacometinib seemed to persist, whether it is L8R8R or exon 19. But if you look at all the trials carefully, even though the benefit with L858R is less with osimertinib, still it's probably the best. So probably whatever the type of mutation, you would still go with osimertinib. Now, just coming to the last 2-3 things, combination with anti-VEGF, you can see that the FLORA trial was very good. In fact, it is one trial where there was no difference whether it was DEL19 or exon 21 mutation. And in fact, because it was so good, osimertinib plus minus ramucirumab is on the way. Dr. Vikas, your thoughts on this? Are there any patients now in your practice where you use anti-VEGF?
Probably I would wait for the final phase 3 OS data to be published to make it worth changing, because I believe till the time we have an OS data, an implication data to give it, I believe I would reserve my options for this.
Dr. Akhil, what about combination of TKI with chemotherapy? You just did mention this trial presented by Vanita Narona about gefitinib plus carboplatin, gefitinib plus pemetrexed carboplatin versus gefitinib alone, and with the very good improvement PFS and OS. What about the toxicity? Have you used this combination, and what is your experience been?
Yeah, this is our own trial, and we have used, while I was a resident, I was seeing a lot of patients related to this trial. And even now, when the patient is not affordable for osimertinib, the combination of gefitinib plus chemotherapy remains our first choice. Most of the time, if patient is fit, I use gefitinib plus chemotherapy as a first line option and not gefitinib alone. However, if patient has PS2, 3, then I will definitely use gefitinib alone in such patients if OC is not affordable. Toxicity, that the reason why I still keep osimertinib upfront than Gef plus chemo, the reason being toxicity. Around significant number of patients will have significant toxicity. That is why I choose the patients, not all the patients.
Dr. Shaunak, what about you? Have you used this method, and how many of them are requiring stopping the chemotherapy?
Sir, gefitinib plus platinum pemetrexed have used in a couple of patients, only a handful. Okay. But they did require stopping of the chemotherapy arm after. I didn't continue any chemo beyond 4 cycles.
Fair enough. So actually, there was a beautiful, systematic review and network meta-analysis where they suggested that the treatment resulting in the best PFS survival for exon 19 deletion is osimertinib, and for L858R is gefitinib plus pemetrexed respectively. So this patient received gefitinib with very good response, but ended up developing headache. So the last 2-3 highlights are osimertinib in these patients. So you have started somebody on gefitinib, patient develops headache. There is a study, the TREM study, where it showed that if the patient is T790 mutation negative with brain metastasis, they don't benefit from osimertinib. But there was a Bloom study where they said osimertinib activity in the CNS is there regardless of T790 mutation status. And there are some other studies also where they showed some benefit. So last 2 questions, Dr. Taha, what about you? If your patient on gefitinib or afatinib develops brain mets, would you not give osimertinib if the T790 mutation is negative?
Sir, if the patient is affording, that's the only option available actually. With the PS after brain mets, so definitely I will offer osimertinib to them.
Dr. Mehalam, your final thoughts. Would you offer osimertinib in somebody who is T790 mutation negative, was on gefitinib and developed brain mets? This is, there is no clear-cut answer. What would you think?
Sir, I would like, if he has some symptom, I would like to give whole brain radiation and would like to continue osimertinib actually. I would not
Somebody
go
has
with
been on
chemotherapy.
gepitinib.
Yes, sir. I would
Would you
like
change
to.
to osimertinib?
Yes, sir. I would, even if T790 is negative.
Fair enough. So I would like to end saying that the final overall survival analysis of FLORA reinforces osimertinib as standard of care as first-line patients, obviously because of the best efficacy, very good tolerability, and good CNS penetration. The only reason probably many of us don't use it frequently is the financial issue. If it is not feasible, we generally tend to use a combination of TKI plus chemotherapy. VEGF we rarely use, and there are no randomized trials to support sequencing, and I don't think many of us would use second generation TKI and then sequence. In few instances we probably would, probably in somebody with L858R or somebody with rare mutations. With that, I'd like to thank the panel for a nice discussion and hand it over back to the organizers. Thanks a lot.
Thank you so much, Krishna Prasad sir. That was a fabulous panel discussion. And I think without wasting time, I think I will call upon Dr. Ashish Joshi sir, who is the senior most medical oncologist working with the MOC, Borivali and Vilepalli Center. To Dr. Ashish Joshi sir.
Thank you, Dr. Sonal. I think we have had very exciting academic session, and I think one on board now is on hematolymphoid tumors. We all know probably this is one segment of disease which has seen quite a bit of conceptual drifts, significant change in the way we treat them, as we've seen in many solid tumors. So we have got exciting 45 minutes. We have got one talk, one debate followed by a panel discussion, and we've got esteemed faculties on board. Just to introduce without wasting any further time, we have got two near dear esteemed teachers with us, Dr. Tapan Saikia sir, who is a senior medical oncologist and transplanter at Prince Ali Khan Hospital, and Dr. Sandeep Shah sir, who is from Ahmedabad, Vedanta Institute of Oncology and GCRI. They would be the chairperson. And our first speaker would be Dr. Satya. Dr. Satya would obviously require no introduction, a very dear friend of all of us. He's a medical oncologist from Omega Hospital, and he would be speaking on controversies and consensus in the difficult to treat primary mediastinal B-cell lymphoma. Over to Dr. Satya.
Shall I get started?
Yes, please.
Yes, so primary mediastinal large B-cell lymphoma is the topic of discussion. Short form is PMBL. I would like to thank all the organizers for giving me this wonderful opportunity. I learned a lot in the preparation of this presentation. For the coming 10 minutes, I'll touch upon only 4 take-home messages. Next slide. So the first controversy can be, or a statement can be, PMBL is a diffuse large B-cell lymphoma, and hence the IPI score is prognostic. So let's look at that. Next slide. So we know on one hand that this disease presents as a bulky mediastinal mass, and therefore these patients usually have high LDH levels. And also this is a young patient population, predominantly adolescents and young adults, usually females. Next slide. On the other hand, involvement of bone marrow and other external sites is uncommon. You don't do a bone marrow in these patients, and usually they're stage 1 or 2 at presentation. Next slide. And therefore, IPI becomes less useful in the PMBL patients because majority of the patients are either low or low intermediate. And therefore, IPI score has low discriminative power because these patients are young, bulky disease, high LDH, and low stage. Next slide. The origin of thymic B cells, and that leads to the hematolymphoid neoplasms being either NS Hodgkin's lymphoma or primary mediastinal B-cell lymphoma, or the more troublesome Grazian lymphoma, troublesome for both the pathologist and the treating hemato-oncologist. Next slide. If we compare all the 3 diseases, PMBL usually females, superior vena cava obstruction more common, large cells in uniform sheets, no RS cells, inflammatory cells are absent, and you find fine bands of sclerosis rather than the large bands as you see in NSHD. Next slide. CD15 is usually absent unlike Hodgkin's, but CD30 is present like Hodgkin's. Unlike Hodgkin, the CD30 is weak positive and is patchy positive. Next slide. So because of these three differential diagnoses, there is a wide variety in reports with regard to IPI and surveillance. Therefore, that's because of the diagnostic imprecision. So which prognostic features do we see? There was one series from the BCCA, next slide, which looked at various features found and the PS of more than 1 and age more than 40. So the cutoff is not 60 but 40 and high LDH levels. Now in the IPS score, you look at LDH more than normal. Here it's more than 2 times the upper limit of normal. So these three have been shown to be prognostic features: performance status more than 1, age more than 40, not the 60 cutoff, and LDH more than 2 times the upper limit of normal. But more importantly, next slide, let's look at the study by name IELSG26, which looked at FDG PET, and the nuclear medicine guys, next slide, looked at the volume of activity at different percents of the SUV max in the area of the mediastinal mass. And with that, they came with a score called as TLG, or the total lesional glycolysis. Next slide. Now, the TLG score depends on the extent of disease, the size of the mass, and also the intensity of the FDG uptake. And what they found out was, next slide, that 25% SUV max was identified as the best cutoff, not 41 and not 50%. So with that, they came to understand that the baseline metabolic evaluation is prognostic. Next slide. The TLG score, if it's low, then the 5-year PFS and OS is like 99 to 100%. And if the TLG score is high, then the 5-year PFS index drops down to 64 and 80% respectively. This TLG was highly prognostic in multivariate analysis. Next slide. Whereas the bulk of the disease, be it less than 10 cm or more than 10 cm, doesn't impact the prognosis. As you can see, the p-value is not significant at all. So take home message 1. Next slide. Baseline metabolic evaluation is prognostic, and that makes us understand that tomorrow morning, please talk to the PET-CTs guys and tell them to give the total lesional glycolysis with SUV max of 25 as the cutoff. Next slide. Section 2. The controversy could be end of treatment positive PET-CT scan after the medical oncology treatment gets over. Does the end of treatment positive PET equal failure? Next slide, which means how useful is PET as the outcome measure? The patient 1 above has a small residual mass, but there is activity there. The patient 2 has a large mass, but there's no activity there. Next slide. We all know, we look at the dual criteria, and 1 is no uptake and 2 is uptake less than the mediastinal blood pool. 3 is uptake less than the liver, and we take the PET-CT as negative if, next slide, it's dual score 1 or 2. But 3, 4, and 5 is taken as positive. Next slide. So this study of 115 patients looked at patients who were dual score negative, half of them, and of those 54 patients, only 1 either progressed or relapsed. So that was the mediastinal blood pool cutoff. Next slide. Coming to patients who were PET positive because of dual score 3, 4, and 5, 61 patients, in 11, the disease came back. Now, having said that, next slide, look at those patients who had a score of 3 and none of them came back. So dual score 1 and 2 and even 3 also would be taken as PET negative for PMBL. Raising threshold for PET positive to include the liver cutoff improves the positive predictive value without loss of sensitivity. Next slide. So let's look at the OS. Whether the cutoff is 2 or 3, the MVP or the liver, the 5-year PFS is in excess of 98 or excess of 98 to 99%. Now, this was a JCO publication in 2014. So it tells us that PET negativity in PMBL would be dual score 1, 2, and also 3. Then the chance of relapse or recurrence becomes hardly 1 or 2, or at the most 3%. Next slide, 2005 and before can be called as the RT era. And based on this study where you had close to 160 patients, 78% of them received RTS consolidation after the primary chemotherapy got over. But 2005 and beyond came PET CT scan. And in the PET era, when the PET was negative, you observe these patients. If PET is positive, you give them radiation. Now you see the radiation, the number of patients who got radiation now drops down from 78% to 28%. Next slide. And even with that, you find no difference in outcomes. So compared to the RT era, the PET era tells us that 64% of relative reduction in use of RT because the PET came negative. Now that was for with regard to 1, 2, and 3. Next slide. If your patient has received a rituximab plus DA-EPOCH, very commonly you find false positive results. So if that is the case, don't jump to give radiation. Don't jump to change lines or change tracks, because you do a PET CT scan after 6 weeks. More often than not, the PET CT scan turns negative. So post DA-EPOCH-R, false positive results have been commonly seen, and in that case do serial scans, and after 6 weeks the scan actually might show a different picture than when it was done immediately after the 6th cycle of rituximab plus dose adjusted EPOCH. Next slide. So end of treatment PET post rituximab DA-EPOCH, if the PET score is 1, 2, or 3, then the dual score is 1, 2, 3, then the chance of recurrence is hardly 2%. DS score of 4, you do serial imaging and the PET scan becomes 1, 2, or DS score from 4, then the recurrence rate is only 6%. If it's a dual scores 5, then the risk of relapse is 50%. So my conclusion is, next slide, end of treatment positive PET CT scan does not equal failure. Dual score 1 and 2 is negative PET scan. Dual score 3 also is negative PET scan. Dual score 4, especially after 6 cycles of R-DA-EPOCH, don't jump onto treatment, but rather give some time, 6 weeks, do the scan again, and you'll find that the PET might be negative. Second last section. Next slide. Consolidation RT is probably over treatment. And next slide. So do our patients still need consolidation radiation therapy? In the era when rituximab was not there, 51 to 66% of patients had a PR after chemotherapy with the medical oncology treatment rituximab based, and which goes on to become 79 to 88% after weekly dose done schedules or after MACOB-B. But next slide. The advantage has not been seen in subsequent series when incorporation of rituximab happened, and therefore you found no difference in the British Columbia Agency study, or you did not give RT in patients in the RDA-EPOCH study. In the Greek series, patients who were PET negative, you found no difference whether you gave consolidation RT or not. The reason why we want to avoid RT is because of second malignancies like, next slide, breast cancer, in smokers,
we're
lung
running short
cancer,
of time, sir.
almost over 1 minute, or coronary artery disease, aortic valve disease. However, this trial will let us know, and the results are going to come out, initial data in July in the Lugano meeting. If PET CT negative, what about giving RT or not? And they have randomized 376 patients. This will let us know. So until that time, RT remains controversial. Next slide. If the patient comes back, it's difficult to rescue. Response rate is 25%. Next slide. Transplantation also rescues only 50% of patients. Next slide. Despite expression of CD30, quickly 2-3 slides more, BV doesn't work, and therefore this trial has been stopped early. Next slide. Data with anti-PD-1 antibodies is encouraging. Next slide. And CAR T cells, the data is emerging. And so lastly, my last 2 slides, next slide, is where is medical oncology in the discussion? And that's 2 summary slides. Most cures happen from initial treatment. Get it right the first time. If the disease comes back, poor salvage rates. Weekly schedules are better than CHOP. R-CHOP is better than CHOP, saying incorporate rituximab. Results with DA-EPOCH are very good, but this is retrospective data, no prospective trial. Next slide. If it's R-CHOP, always give dose-dense R-CHOP. Next slide. If it's DA-EPOCH-R, you don't have to possibly give consolidation RT. Next slide. And do put these patients on VTE prophylaxis because 28% of these patients can get VTE. Next slide. We don't have any prospective data comparing R-CHOP and RDA EPOCH. Lastly, next slide. And the next slide is my last slide. So this disease is a unique thymic B-cell malignancy, unique biology, more than 90% survival. RDA EPOCH is my choice. Role of RT is still controversial. Baseline metabolic evaluation, yes. End of treatment PET CT scan, yes. And emerging role of anti-PD-1 and CAR T cells for relapsed PMBL if you want to avoid autologous transplant. Thank you so much, everybody.
Thank you so much, Dr. Satya. It was a wonderful, crisp and succinct talk. I would just request a quick, very short comment from Sandeep Shah, sir. Sir, your choice, R-CHOP versus RDA EPOCH, primary mediastinal newly diagnosed B-cell lymphoma.
I think now practically there is no controversy as far as RDA EPOCH is concerned. And the benefit of RDA EPOCH is that if PAT is negative after RDA EPOCH, we can avoid the mediastinal RT, which has plenty of side effects. So, and almost 90 to 95% cure rate with RDA EPOCH. So, if patient can go for RDA EPOCH, nothing like it, and we can avoid the mediastinal RT, which is most important thing. I think we are already late, so
yes, thank you so much. Thank you.
Yeah,
thank you, sir. So we will move on. Our next is going to be a debate. We've seen a lot of change which is happening beyond 7+3 in the treatment of adult MDS and AML. So are these novel therapies actually really making difference in the treatment outcome, or it's just an hype? To debate for it, it's going to be Dr. Ashay Karpe, my dear friend and consultant medical oncologist and director of Sunrise Oncology Center and Sterling Hospital, Mumbai. Over to Dr. Ashay.
At the outset, I would like to thank the organizers. Thanks, Ashish, for that introduction. And I think we had so many discussions about the targeted therapies just before this. We had ALK1 EGFR that itself tells that we are going towards the personalized or the precision medicine. So this is something which I just wanted to highlight: the growing role of precision and personalized medicine in the cancer treatment. It has caused improvements between the personalized versus non-specific approach, which is 30.6% versus 4.9% response rates and 5.7 versus 2.95 months of progression-free survival in cancer. Now, in this paper, it is most of the solid tumors, but what we understand as a cancer biology, it is just not the tumor cells properties, but the microenvironment, the immunology, and the genetic markers, which we are always looking at. So treatment of AML has progressed greatly over the last 40 years. If patient is less than 60 years, we are almost 70% CR and 40% long-term survival. Even when we are saying somebody is a good risk, still they do not cross 60 to 70% of the cure rate. But the unfavorable or the adverse group has a dismal prognosis with less than 45% remission rates and least overall survival. The 5-year overall survival in the elderly patient is 1/3 what we are seeing in the younger patient. But the most important thing I just wanted to highlight that 71% of the patients in AML, this is data from the CMC below, that unable to undergo treatment, which is a standard of care, mostly due to financial constraints. So AML disease and bar MDS. So what I'll be speaking is mostly AML high risk and MDS, and this is the disease mostly in the elderlies. Median age is around 60, and what we have poor performance status, increased number of comorbidities, organ functions. Many of the times patients are coming in the late stages, they are already, their general condition is compromised, and there are a lot of molecular factors which make them high risk. So this is all the hindrance to give them the standard therapy. And most of this time, the standard therapy or the treatment of choice there remains the allogenic stem cell transplant. So in high-risk AML and MDS, if I'm assuming that they are medically fit, intensive treatment with the induction chemotherapy and is usually bridged to alloecity, overall response rate in the 41%, and even in the Western world, median OS is 10.8 months, and only 40% of these patients will be proceeding to allogenic stem cell transplant. So this is again data from the same CMC. I just wanted to highlight, now we are speaking about MDS AML. In the real world, how many patients really can go for allogenic stem cell transplant, which is deemed curative treatment? And you can see, this is the data in 2017 from Vellore, and look at out of 160, only 6 patients were MDS. So where, we have like last Globocon, we have almost 27,000 plus leukemia patients, even I assume that 40% of their leukemia. So still it is 10,000 odd AML patients are there. How many of them really can go for a transplant? Just talk about MDS. MDS is where we have understood the biology more and more, and we have all these mutations which are present: DNA methylation, chromatin modification, RNA splicing, transcriptions, and we have targeted agents. Here, the basic defect remains at the stem cells, and that's the reason why the allogeneic stem cell transplant remains only the curative option. So these are the frequency of various mutations, though most of these mutations are less than 10%, but still we are still understanding the biology. These are the various targeted therapies which can be tried based on the current understanding of the MDS biology. So this was another paper where novel therapeutics in AML, and what it has said is novel agents such as molecular targeted drugs, FLT3, IDH inhibitors, monoclonal antibody-based agents, checkpoint inhibitors, CAR T cells, they improve therapeutic strategies to eradicate persistent minimal residual disease remaining after the cytotoxic regimen or will be used as a bridge to transplant. Again, in AML, we have these various, especially FLT3 inhibitors, which are widely used, midostaurin, sorafenib we are using. Then we also have venetoclax, HDAC inhibitors being used. So all these, definitely they are increasing CR rates, and definitely those patients who can go for a transplant maybe.
So 1 minute left.
I just wanted to summarize, I just wanted to summarize certain trials. Look at this, just response rates. You know, this is azacitidine plus venetoclax in upfront, newly diagnosed AML more than 65 years. Look at the CR rates, almost 61% as compared to the 40%. Again, this is the magrolimab, which is anti-CD47. Look at the response rate in MDS, almost overall response rate of 91%. In AML, it is 64%. So definitely all these trials, what are they telling? That definitely we need a novel agents at the conventional chemotherapy regimens. So this is another trial. Again, I just wanted to highlight here that with venetoclax, along with azacitidine, look at the CR rates. There's 71% of venetoclax plus azacitidine and 74% for venetoclax plus GC. Definitely, they are not long lasting, and transplant can be offered. But in most of the patients where transplant is not possible, they can give good quality of life. These are the certain agents. As Ashish has suggested, we are seeing AML. Look at them, still 1973, 20 years, no advancements. And now look at whatever happening in the last 20 years, all are novel agents. These are another agents. These are the trials, and definitely no oncology discussion is complete without immune checkpoint inhibitors. Definitely nivolumab, ipilimumab, durvalumab, everything will be there. And I think we will have the results sooner or later, and then we might have the better response rates. This is another thing which we can see. What is the economic analysis? The problem with the MDS AML that majority of these patients will be transfusion dependent. Even if you offer them palliative care or the best supportive care, it will be. So is it really meaningful? So in this trial, basically study, it was low dose cytarabine versus, and hypomethylene agents were used as a low cost therapy. It didn't significant overall survival, but advantage of intensive chemotherapy comparatively to low intensity. So overall survival is not different, but it's cost effective in the terms of even best of care, supportive care, and required less number of transfused blood products, I think, which can make quality of life better. So my take home message, novel agents, definitely we are looking at a precision and personalized medicines. Novel agents plus or minus chemotherapy, we have better response rates. Definitely they have bridged to allo transplant. And especially in those patients, intensive chemotherapy or transplant ineligible, better response rates and survival, and less and predictable toxicity. Thank you very much.
Thanks, Dr. Ashay, for that wonderful talk. Now to talk against it, we have Dr. Sanket Shah. Dr. Sanket is a consultant medical oncologist and transplant physician at HOC Vedant, Ahmedabad. Over to you, Dr. Sanket.
Thank you. At the outset, I would like to thank the organizer for giving me this opportunity. Nice talk by Dr. Ashay, and probably he has make my talk easier. In most of his talk, he has already said that these newer agents are not affordable, or probably they are just some affordability or some beneficiary. So there is a difference between the bedside medicine and the bedside medicine. A molecule develops after a long research, then comes to the clinical trial, then approval. But the approval and the use in the day-to-day clinic is something very different. You have so many factors to encounter when you use them day-to-day practice. The same paper that has been mentioned by Dr. Ashay, if you see out of 380 patients, here in the table first line, 81% of the patient due to the financial problem did not receive the treatment in 2015. Now, the cost of treatment at that time in the same paper, it was mentioned as 5 lakhs for less than 50 years and average around 7 lakhs for elderly or adult one. Now, if you see the per capita GDP change, 2015-16 it was 93,000, while it is right now 99 or 1 lakh. So there is no major difference. So probably our setup is still remains the same, though the economy has boomed, and probably 10 or 15% patients which were not affordable at that time might become the affordable now. This is the newer algorithm by MD Anderson Cancer Center, which shows that how to treat the advanced ALL or the any AML patients. And these all are the newer agents that they have mentioned. But what about these newer agents? Well, just in a brief about all the agents. For availability, first, apart from FLT3 inhibitor, none of them easily available. We have to procure them. Mogamulizumab and eprinephrine, which is acting on the TP53 mutated, they are still in the clinical trials, not available at yet. Now, the cost factor we must have to see, and if you see, there are so many lakhs, which is much higher than even the induction therapy itself, even twice or thrice the induction 7+3 treatment. 4 with venetoclax, GO around 18, CPX 351 30, FLT3, midostaurin, even 9 lakh for the full treatment. And luspatercept, which is available for MDS, it is again 7 lakh per 3 week, which is much beyond any affordability. Now, again, data in the young, only we have the data for that FLT3I and the IDH2 for some patients only. Can replace 7+3? No. Can replace allo transplant? No. So why we are paying this extra cost over and above what we are going to pay for the treatment itself? Other points, venetoclax, like it has 30% febrile neutropenia in the Western world, so it is much higher in the Indian setup. It cannot be used with the low dose, no major benefit. It has, once you try to add 7+3, it is too toxic, single agent, not useful. Duration of response is just 14 to 18 months if you are not going for the transplant. For GO, again, dose controversies always remains there, which dose to be given, how to be given, and it is associated with a very high rate of POD if you are planning for the transplant in a patient with the young patient who are using the 7+3, where this drug is indicated. CPX 351, it is used in 60 to 75. Now at this age, probably we are not going to use chemotherapy, whatever the way it will be. Overall survival benefit is usually only 3 months despite this aggressive chemotherapy. And it produces prolonged neutropenia, which is obviously not acceptable in our setup. FLT3, as I have mentioned, it requires whole 1 year of treatment to get 4, 5 or 7% of the overall benefit, and to cost is much higher. Second generations are not available at present. Luspatercept, I probably don't talk with that because it is not much of the good molecule according to me. So to summarize, newer agents are promising and show us the strength of medical science, but are far from the routine practice in an Indian setting. At present, they are mainly a bridge to transplant. Most of our population basically not affording or have access to induction or LOSCT. So in that case, adding extra cost is not a wiser decision. For remaining Indian population, we actually focus to train our medicos and paramedicos to take care of the patients in AML induction so that we can reduce our morbidity and mortality and improve the patient outcome. Generic molecules, one will be available by Make in India. It would be of great helpful. And at that time, this discussion would be very helpful. Probably venetoclax and IDH1 inhibitors are going to be the next boon in the AML treatment. Just to summarize, if you see in the last April month, NASA's rover makes oxygen on the Mars. But at the same time in the April, India was searching for the oxygen. So whatever we find molecular target agents in the West, that does not immediately transfer our AML treatment right now. It will take few years. So currently we should stick to 7+3 or HMS and try to improve the outcome of Indian patients. Thank you.
Thank you, Dr. Sanket. I think there were two excellent talks from both the sides of the table. Would request for a comment from our chairperson, Dr. Tapan Saikia, sir, with his experience in treating high-risk MDS and AML.
Right.
Over to you, sir.
Okay. Good evening, Ashish, and good evening to all. I think listen to both the speakers. Both of them tried to speak to their given topic. Both are right. But we are in the field of medicine because we keep learning every day. So it's important, especially in oncology, we keep learning about the genetic abnormalities. Things are changing decade by decade. For 30 years, we treated all AMLs with only 3+7, or little modifications here and there. Now we have so much of knowledge. And it's a spectrum of disease, both AML and MDS, so heterogeneous. Well, we understand what Sanket has said, the difficulty in treating cases in India. But at the same time, what Sanket also does in his daily practice, tries to understand the disease and offers the new form of treatment to each and everyone. There's no doubt about that. Cost is an issue, but we keep trying. So let us keep aside the cost, but look at it how we were treating the acute myeloid leukemias. Years ago, we couldn't talk to them anything about any treatment other than supportive care. Sometimes giving hydroxyurea, sometimes low-dose RSC, spending money in supportive care, as you have said. But now we talk to people, and we see some successes here and there. That's good enough in our practice, I suppose. You can get the statistics. that's fine. But when you get derived pleasure from treating one patient and living for 4 years or 5 years with a new approach, also you get derived a lot of satisfaction. What I get to see at this moment of time in AML as well as MDS is that new drugs are not being able to be used in younger people except for FLT3 mutations, IDS mutations and other mutations, because trials have been done only in elderly people so far. But in coming years, 5 to 10 years, probably we'll get to see all this coming to the first line treatment. In oncology, we always talk about the best treatment should be the first treatment. So when you will be able to combine newer drugs with the age-old chemotherapy agents, modifications here and there, we're going to get better responses, better survival. And probably we might be able to reduce some of the toxicities given by the chemotherapy. Yes, newer drugs will have their own toxicity. So I think it's a progress. And then I'm really, personally, I'm so happy to see the kind of progress we see in AML, MDS, the way we talk to patients. We talk everything with the patients, whatever is possible. Someone understand, doesn't understand, we give over a few sessions. I'm happy that what's happening in the world at this moment in this field of hematology.
Thank you so much, sir. Thank you for those wisdom of words and clinical pearls. Now, I think we will move on. We are going next to our panel discussion. And to moderate that panel discussion, we have our senior teacher, colleague, Dr. Hemant Malhotra, sir. Dr. Hemant Malhotra, sir, does not require introduction. He is a professor and head of the department at MGM Medical College, Jaipur. And if I may take an opportunity to invite the panelists, sir, is that okay?
Yeah, Ashish, please go ahead.
Yes, sir. So we have with us on our panel Dr. Surendra Biniwal, who is a medical oncologist from Acharya Tulsi Cancer Hospital from Bikaner. We have Dr. S. Vishwanath, who is a medical oncologist from Apollo Hospital, Bangalore. We also have Dr. Krishna Prasad, who is a medical oncologist from Bangalore Institute of Oncology. We have Dr. Vinayak Mwaka, who is a medical oncologist from HCG Hospital, Bangalore. We have Pushpak Chirmade, who's a medical oncologist from MGM Hospital, New Bombay. And we also have two hematologists, Dr. Kishore Kumar, who is from MIOT Hospital, Chennai, and Dr. Ganesh Jaishetty, Yashoda Hospital, Hyderabad. We will also request inputs from our dear chairpersons, Dr. Saikia, sir, as well as Dr. Sandeep Shah, sir. And over to you, Malhotra, sir, for the panel discussion. Topic is going to be myeloma in 2020, real world scenario. Thank you so much, sir.
Thank you very much, Ashish. I was actually kind of hoping that there will be a couple of background talks on myeloma, but there are no background talks. So we'll have to cover myeloma, which is a subject of a separate conference in itself, in 20 minutes, but we'll try and do justice to some of the important issues. So like we're talking about a newly diagnosed patient, some tricks and tips about the workup and the management. We'll not discuss relapse and refractory myeloma today. So my greetings to the two honorable chairpersons, and you will please permit me if I direct a few questions to you also. I'm told that Dr. Vinayak and Dr. Kishore have not joined. Is that correct? Is Dr.
Yes, sir. Yes, sir. And so even Dr. Ganesh and Dr. Beniwal will join us soon.
Dr. Beniwal is not joined as yet?
No, sir.
Okay, let's see how it goes. So many thanks to the organizers for this opportunity, and greetings from the Mahatma Gandhi Medical College Hospital to all of you. And again, this is the organizing team of the 44th ICON. Thanks to each one of you for the wonderful job you've done. And this is the panel which I have with me, and I'm sure all of them will join subsequently, and we'll direct the questions to them. So before I move on, I'd like to pay respects to this so-called myeloma mafia in the United States. And I wish I had more time and I would have spoken about each one of them a little more. But just to very quickly recap, this is Dr. Nikhil Munshi, Dr. Sundar Jagannath, Dr. Vincent Rajkumar, Dr. Shaji Kumar, Dr. Sagar Leonel, Dr. Divesh Mehta, Dr. Seema Mehta, and Dr. Nupur Raja. These people are leading the myeloma field in the world, and we are very, very proud of each one of them and the fantastic job that they are doing. So let me present this case of mine to you, and then we'll go to the question. So we have a 58-year-old male who's a driver, 6-month history of low backache and right-sided chest pain, gradually increasing weakness. He is a known patient of diabetes and hypertension, but is controlled on oral drugs. On examination, he is quite pale. However, there is no nodes, no bleeding, no liver splenomegaly. Heart and lungs are onto examination are normal. When you press his rib cage, there is significant tenderness, particularly on the right side, and his spine on percussion is also tender. Initial investigations, he has quite severe anemia. ESR is very high. Sugar postprandial is 168. Calcium is on the upper side, and the globulin is raised. So, ladies and gentlemen, we will not waste time on this question. This is a list of differential diagnoses which we consider, and it does not require rocket science to keep multiple myeloma as our first possibility. So now I come to my first question to Dr. Krishna Prasad. Dr. Krishna, in addition to the basic workup which you have, what other investigations would you want? Would you want a marrow, biopsy, cytogenetics, FISH panel, protein electrophoresis, immunofixation, free light chain, skeletal survey involving one of the modalities which we have, a beta-2 microglobulin, or all of the above? Can you elaborate on the investigations for a newly diagnosed patient? Dr. Krishna.
Yes, sir. Thank you, sir, for having me. So yes, I think all of these above investigations would have to be done. We need to do a bone marrow aspiration and biopsy. Biopsy with probably immunohistochemistry also. Yes, do a cytogenetics and a FISH panel. Electrophoresis with immunofixation and serum-free light chain assay now are pretty much easily available in most parts of India. And of the radiological imaging, if feasible, PET-CT scan would what be normally done. Beta-2 microglobulin, yes. So all in all, I think all of the above would be the thing to go. And probably at the same time, start managing his symptoms at the earliest.
So thank you very much, Dr. Pushpak. Would you elaborate on point number 3, like what radiological investigation would be a minimum for your point of view in a patient of suspected myeloma? Is a radiological skeletal survey like X-rays of the skull, long bones, chest, pelvis enough? Or do we need to go for more sophisticated low dose whole body CTs, whole body MRIs, or PET CTs? Dr. Pushpak?
So depending upon the sensitivity of each of these investigations, I am more comfortable to do an MRI, especially in these people who have a higher creatinine, where a CT scan might be a little, or a PET CT scan might, a contrast may be a little. So I prefer an MRI of the whole body to detect the smaller lesions, because it's one of the myeloma defining criterias.
So, Dr. Vishwanath, at your center, do you have facilities for a whole body low dose CT scan done? And, could you also compare and contrast the costs of a whole body MRI versus a PET CT scan?
Yes, sir. So thank you so much for having me. So in our center, we generally go ahead with a PET CT. In this case, since the creatinine is 1.8, yes, I do agree with the previous panelists that it may be difficult to give a contrast, but we can always do a PET CT without IV contrast for the CT. And we also have this thing facility to do a whole body MRI. So the cost for PET CT is around 23,000 rupees, and the cost for whole body MRI is around 17,000 rupees.
Yeah, so I think important take-home message here is that whole body low-dose CT scans, the availability is a little limited. I tried very hard to get it set up in my center. I could not. And your options remain whole body MRI and PET CT. And with the proliferation of PET CT units all over the country, this probably is the investigation of choice rather than an MRI, and it turns out to be cost-effective also. So now my question to Dr. Ganesh is, Dr. Ganesh, what panel would you ask for in the FISH, or would you let the laboratory decide that? So what minimum FISH panel would you ask for in the workup of every patient with myeloma? Dr. Ganesh, are you there? Has Dr. Ganesh joined?
I think that Dr. Ganesh is not there.
Okay, Dr. Kishore Kumar, has Dr. Kishore Kumar joined? So
No,
unfortunately, both our hematologists are
No, sir.
engaged. But anyway, let me. Is Dr. Surendra Beniwal on board?
No, sir.
Okay, fine. We go back to Dr. Krishna. Dr. Krishna, what fish panel would you ask for minimum?
At a minimum, I think we need to look for 17q13 deletion, possible 1q gain, 414 translocation, 1416 and 1420. This would be the minimum probably.
And Dr. Pushpak, like as for CLL, you know, if you ask if the deletion 17 is negative on fish, it is mandated that you ask for the TP53 gene mutation by NGS. Does the same apply to myeloma also, or if the deletion 17 is absent, you can, you know, presume that it is absent? Dr. Pushpak? Is Dr. Pushpak on board?
He is also logged out, sir.
Ajay, sorry?
He is logged out, so we'll just contact him.
So, Dr. Vishwanath, can you take this?
Yes, sir. So generally, in my clinical practice, I'm doing fish. I don't have much experience with doing NGS in my center as of now.
So, you know, this situation in myeloma is a little different from the situation in CLL. And if you do not have a deletion 17 on fish, you can presume, and you don't have to, you're not mandated to ask for the TP53 mutation by NGS. So we'll move on. This is the
Pushpak sir has joined.
Yeah, Pushpak is joined. Okay. So this is the NCCN recommendation for initial diagnostic evaluation. And you know, this is what they recommend. They would like to look at deletion 13, 17, translocations 4, 14, 11, 14, 14, 16, 14, 20, abnormalities of chromosome 1, either gain amplification or 1p deletion. So this is the panel which NCCN recommends, but we in India can make do with 4 or 5 alterations. So again, as has already been mentioned by my panel, the treatment considerations involve the status of the patient, whether the patient is fit or unfit. This helps you decide whether you offer the patient transplant or no transplant. For the asymptomatic patients, you can monitor the patients closely, doing your tests every 1 to 3 months. And for the patient who is symptomatic or has active myeloma, any one of the CRAB features and also the SLIM features, these patients require immediate treatment. So just to highlight for our students who are on board and our young colleagues, this SLIM feature is something which has recently been added by the International Myeloma Working Group. CRAB features, you're well aware, meaning hypercalcemia, renal insufficiency, anemia, and bone disease. And bone disease means one or more than one lytic lesion of more than 5 millimeters in size on whole body CT or MRI or PET CT. And this is the relatively new SLIM criteria, which is also an indication for treatment now. 60% clonal bone marrow plasma cells, any one of the serum free light chains divided by the other non-involved light chain equal to or more than 100, and more than one focal lesion detected by MRI or PET CT scan. And these are indications for immediate treatment also now, because if you do not treat treat the patients who have the SLIM features, then the adverse outcome and very rapid progression to myeloma has been well documented. So these are some skeletal films of our patient. The serum protein electrophoresis, tall M spike, you can see 4.1 grams per cent. The copper light chains are very high. And we find that we have a patient who has 65% plasma cells, IgG kappa myeloma, beta-2 microglobulin is double the upper limit of normal. He has no chromosomal abnormalities on cytogenetics, so the final diagnosis is IgG kappa multiple myeloma, ISS3 and RISS3. Now I would ask this question to my panelists again. Dr. Pushpak, how would you manage this patient very quickly?
Yes, sir. So this patient basically falls in the standard risk of multiple myeloma with the CRAP criteria. So I'll initially start him on a bortezomib dexona based regimen. His creat was slightly on the higher side. Once the creat normalizes, I would add an IMID. So that is my preferred regimen. VRD I would start with that and see how it goes. I'll monitor every month with his FLCs and the serum protein electrophoresis.
Sir, Dr. Ganesh has logged in, sir.
Right. So, Dr. Vishwanath, are you there?
Yes, sir, I'm there.
So, tell me, Dr. Vishwanath, what would be your approach? In addition to supportive care, we've hydrated him, we've given him steroids, we've made sure that he doesn't have any spinal cord compression, we've normalized his creatinine after hydration. Then, what would be your induction regime in this patient?
Yeah, so with the creatinine, if you consider the creatinine of 1.8, I would go with the bortezomib, cyclophosphamide, and dexamethasone. That would be a very good regimen, and cyclophosphamide is not contraindicated in renal failure. If the creatinine is normalized, I would probably go ahead with Velcade, lenalidomide, and dexamethasone, and of course supporting the patient with denosumab if the creatinine is abnormal, if not zoledronic acid, if the creatinine is normal.
Yeah, wonderful. So I think the most commonly used regimes, particularly if the patient is a potential transplant candidate, are VRD, as has been mentioned, and Cybordex, right? So, right before you start treatment, you need to kind of categorize the patient, whether the patient is going to be eligible for transplant or ineligible for transplant, and then proceed further. And if the patient is ineligible for transplant, primary induction therapy is with one of the regimes which our panelists have described. And if the patient is transplant eligible, then you give 4 or 6 cycles of induction treatment, assess the response. If the patient has a good response, the patient then must move on to an allogenic stem cell transplant. So, is Dr. Surendra on board now?
So Dr. Ganesh has joined, sir.
Dr. Ganesh has joined. Ganesh, I don't know whether how much of the discussion you missed, Dr. Ganesh, but in your practice of multiple myeloma, what percentage of patients end up getting a high-dose melphalan and a stem cell rescue?
Sir, basically, I'm sure it will vary according to different practices across different groups, but in my practice, about 60 to 70% of the transplant eligible patients eventually end up being taken up for high-dose melphalan with autologous stem cell rescue, sir. About 60 to 70% patients.
That is really wonderful. We had done a survey some 10-15 years back, and only 5% of patients were going on to transplant. So I think this is primarily because the awareness is there now. We've had several randomized studies proving the benefit of transplant, and also many more centers are now doing autologous transplants. Is that correct?
Yes, sir. And also depends if the patient of the myeloma whom you are catering, if they are primarily right from the diagnosis are with you, or you just get the only transplant reference. So most of our patients who are diagnosed with myeloma right from the beginning are with us. So from day one, apart from the complete myeloma molecular profile, we keep on enforcing the necessity of transplant. So probably that might be one reason. So yes, sir. It might be, little biased because the kind of people we get from and the kind of people we cater to in the corporate practice might be different from the overall, consensus general population, the summation of all the practices.
Very true. But I think from our panel, we should send an unequivocal message to our younger colleagues that if there are no economic indications and if the patient is fit, then as of today, high dose melphalan 200 milligrams per meter square, followed by a autologous stem cell rescue, is the standard of care. And these are the primary treatment regimes which have been described in literature. And I think some of us might be using a monoclonal antibody upfront, but that makes the regime extremely expensive. So most of us make do with VRD or Cybordex, and we are lucky to have both the proteasome inhibitor and the IMID available as generic. So they come into the realm of affordability. And for the non-transplant eligible patients, you have separate regimes, and for the transplant eligible patients, you have separate regimes. So now my question to Dr. Vishwanath is let's come back to our patient. He's received the best possible treatment of IMED, proteasome inhibitor, dexamethasone, bone-directed treatment. He's also received an autologous stem cell transplant. So what would you expect his 5-year survival to be? What would you tell his family?
Yeah, so this patient, though he's in RISS3, does not have any of the high risk cytogenetics. I would still put it as 60 to 70% at the end of 5 years.
That's right. So this patient is expected to survive. Is expected to have a 5-year survival of 50 to 60%, and that is a massive advance over several years back. And this is the RISS staging for you, and patients who are stage 1 can expect a 5-year survival of 82%, and even patients who are in stage 3 can expect a 5-year overall survival of 40%. And this is the curves, survival curves for you, the 70s, the 80s, and this is gradually being moved up, and it has in the current decade, it is about 50% for most patients. And this is true for both younger patients less than 65 years of age, and even more true for patients who are more than 65 years of age, where the 5-year survival has increased from 31% to 56%. And here again in bar chart form from 1975, a quarter of patients had 5-year survivals. This has now increased to more than half. And our new drugs, these are directly impacting on this. This was the era where we had only VAD, and I remember Dr. Tapan Saikia, teaching us how to use the VAD regimes, 48-hour infusions of vincristine and doxorubicin, and now we've moved to the CRD, which can be given on an OPD basis, and we have increasing very good partial responses with our combinations. And this is the development of the agents in myeloma. A significant number of new drugs were approved in 2015, panovinostat, daratumumab, elotuzumab, pomalidomide. The red arrows are the agents which are available to us in India, and here is the here are the survival curves for you, gradually being pulled up. And these are the new agents. In the last 5 years, there have been 6 new agents which have been approved for myeloma. We now have, these 2 agents have been approved in 2021, and we now really have a lot of drugs for myeloma. Of course, the drugs are toxic, and I'm just, very quickly going to show you a snapshot of the toxicities of these agents. We need to be particularly careful about peripheral neuropathy. Our patient, this one particular patient which I showed you, had diabetes also. And all of us have experienced that even though bortezomib is very, very active in myeloma, used in most patients, but it can produce severe peripheral neuropathy, and you can have a patient who's walking into a wheelchair in a few weeks' time if you're not careful. Because the drug can be given subcute, we sometimes advise subcute bortezomib to be taken at home at the patient's native place, and then the patient comes back on a wheelchair. So this has to be, and in fact all the toxicities have to be very closely monitored and anticipated. Now my question,
can I request you to conclude, sir?
Hello?
Yes, sir. So can I request you to conclude, sir?
Okay.
Out of time.
How much time do we have? So when you,
so the time is over, sir.
Time is over. Okay. So maybe give me 2 more minutes. So once you are monitored the patient, the only thing which need not be done from this slide is serum beta 2 microglobulins. And now a few words about the MRD. Let me ask my panel one by one. Dr. Krishna, do you do MRD in your newly diagnosed or relapsed refractory patients?
So at present, no, sir, unless the patient has shown stringent CR, in which case I will think about doing it, but routinely, no.
So, Dr. Pushpak?
No, sir, I am not doing MRD for my patients at present.
Dr. Vishwanath?
I agree with the other panelists. I'm not doing at present.
Dr. Ganesh?
Sir, if resources are not a problem, looking at the therapeutic options of relapsed refractory diseases, that MRD is not a significant amount. So I will still do if the patient has no limitation, but has not bother us about the spending that much amount for MRD.
Okay, so when I think I'll just skip these MRD slides. Maybe we spent too much time on the preliminary. But just to summarize for you now, last two slides on summary. MRD is there is very solid data. The MRD might be important and it might make it into the clinic in the near future. And this is my summary slide. Last two, incidence of myeloma is increasing world over, but with the availability of good drugs and good treatment, the death rate is decreasing. It still remains an incurable disease, but with expert management, good quality of life for several years is possible, and the survival beyond 5 years now happens in the majority of the patient and is the rule rather than the exception. With the availability of new agents, we are spoiled for choice with options in both the newly diagnosed situation as well as the relapse refractory situation. The choice of the regimes or drugs essentially depends on age, comorbidity, and transplant eligibility. It still remains an incurable disease. And for the relapse refractory patient, the choice of the regime again depends on whether it is early relapse, late relapse, and what drugs were used in the first line. And the availability of monoclonal antibodies have significantly enhanced options for treatment, both again in the first line as well as in the relapse refractory setting, with improvement in PFS and OS. Availability of several new agents, the BSMA antibody-directed drugs, the BSMA CAR T cell, which have been approved last month only, have opened up options in the relapse refractory setting. Data on the role and use of MRD detection in the clinic, even though it is presently not standard of care, but this data is rapidly accumulating and it may become the standard of care in the near future. And the importance of supportive treatment in myeloma by intervention with drugs, bone-directed therapies, intervention with surgery, early treatment of hypercalcemia, treatment and prevention of infections, treatment and prevention of DVT will remain very vital components of treatment. And with that, I'd like to close. I'd like to thank each one of my panelists for their expert comments. And thank you very much. And I'm ending my slideshow now. Thank you.
Thank you so much, sir. I think it was a wonderful discussion. I think we are running late in terms of our time schedule. So if I may conclude this session and hand over the proceedings to Kashish for taking it further. Thank you so much. Thanks all my chairpersons, panelists, Dr. Hemant Malhotra sir, and all the speakers for this session. It was wonderful experience to have you on board. Thank you so much.
Thank you. Thank you.
Thank you so much, sir. We'll now move on to the GI session. Can I request our coordinator, Dr. Smith, who's a medical oncologist from Mumbai Onco Care Center at Mumbai, to take the session forward. Over to you, sir.
Good evening. Am I audible now?
Yes, sir, you're audible.
Okay. Yeah. Good evening, everyone. So moving on to the next session, which will deal with GI malignancies. It's a privilege to welcome our chairpersons, Dr. Ganesh Nagarajan, sir. Sir is a surgical gastroenterologist at Hinduja Hospital in Mumbai, and Dr. Hindu Bansal, madam. Madam is a radiation oncologist at Narayan Super Specialty Hospital, Gurugram. We will have two debates and one molecular tumor board. So moving on to the first debate, sequencing of therapy in non-operative management of rectal cancer. And speaking for radiotherapy first, we will have Dr. Pranav Chada, sir. Sir is a radiation oncologist from Kokila in Dhirubhai Ambani Hospital in Mumbai. Over to you, sir.
Hello, am I audible, please?
Yes, sir.
All right. Okay. So thank you for inviting me. Thank you, the organizers. So my topic is sequencing therapy, non-operative management of rectal cancer, radiation therapy first. So the contents of my presentation is regarding the guidelines, recommendation, the evidence for the sequencing,
stating either radiotherapy, and then the contrary point of view, I'll just touch a little bit on the chemo, its caveats and the lacuna and the ongoing trials. The rationale is that the non-operative management of rectal cancer is an emerging treatment approach. It stems from the TNT approach. It aims to enable carefully select patients to avoid the morbidity of radical surgical resection while benefiting from the same excellent rates of tumor control. And evidence from retrospective and prospective single-arm and cohort have demonstrated a high rates of local control and disease-free survival with a non-operative management of rectal cancer. So there are 3 guidelines that I could check. One is the NCCN, and it puts up the total neoadjuvant therapy. The concept comes from total neoadjuvant therapy. That is, you give the entire therapy prior to the surgery and you don't have to give anything post-surgery. And it's given both the options. That is, first, you can go ahead with chemoradiation followed by the consolidation chemotherapy, or chemotherapy followed by, then again, you can have a radiation course. The ISMO guidelines also gives an option for a wait and watch, that is to see and observe whether sort of we can get away with the surgery. This is from the ASCRS, the colorectal surgeons, and they also put up a strong recommendation so as to wait and watch, but to consider for highly selected patients. Now, this highly selected patients, we need to sort of further refine in the near future. Some of the work that has been done is related to the age more than 70, patient preference, patient wants to avoid surgery, tumor location being low lying, the assessment of response at 6 to 10 weeks. Now, this response assessment time, we'll discuss it later, but it should be a sort of a complete response, which should be based on endoscopic findings, digital rectal examination, imaging, and the CEA levels. And this is how people who are doing some sort of non-operative management of rectal cancer are following up with these sort of guidelines. In year 1, doing a CEA, DRE, endoscopy, MRI of the pelvis, CT of the chest and abdomen, and similarly and sort of analogously for years 2 to 3 and years 4 to 5. These are the selected outcomes with respect to the non-operative management. Most of the studies are retrospective, and this one, the Encore study, was a propensity matched cohort analysis. It shows quite I would say, encouraging signs with respect to the local control rate, the colostomy-free survival, especially in the Encore rate, showing a good overall survival also at 3 years. So 2 studies from the Haber Gamma, it's from Sao Paulo. They've done the maximum work. First study, they did a neoadjuvant chemoradiotherapy with the standard concomitant 5FU. I just want you to note the figures that the local recurrence-free survival, now this is non-operative management categorically. The local control with salvage surgery, which was used, was 94%. However, without surgery also, it was not bad. The disease-free survival also looks pretty sort of encouraging. Overall survival was 100%, but this was with the salvage surgery. Now, the same group again gave a consolidation chemo, that is first giving a chemoradiotherapy followed by consolidation chemotherapy. Again, things improved with respect to the local recurrence-free survival. Overall survival also got better. So the conclusion was that yes, it can be attempted, and then the prospective study, which included the consolidation chemotherapy, sort of added on that the TNT concept, the total neoadjuvant therapy, you can add the consolidation chemotherapy and use the surgery for the non-responder patients. A group from Denmark, they attempted a higher dose of radiation, in which we tend to give 50 grain, 25 fractions of 50.4 gray, but these guys attempted 1630. Now here the chemotherapy was on the lower side, that is, the more sort of weightage was given to the radiation therapy. I checked this article, there were a lot of toxicity. So we need to be careful that not to get sort of over enthusiastic when you wish to achieve a higher tumor control probability. Now, these 2 trials for my sort of my colleague, my friend that I'll be discussing now, only 2 trials are there which compares induction versus consolidation chemo with respect to chemo, that is the timing. And this is the ARO study, the German study. Now, they have studied the pathological response rate, and the arm A was the induction study, and arm B was the consolidation chemo study. So I'm just looking at the numbers. The PCR was significantly better. The toxicities I haven't mentioned, but the toxicities were also lower. This was the OPERA trial, which is still going on. They've reported the results in ASCO 2020. Now, it's quite simple that you FOLFOX or KPOX, I think the medical oncology colleague would tell me better. But the idea is in the first arm, you give the induction chemo followed by CRT versus CRT followed by FOLFOX. And you do the restaging, you check for the non-clinical responder versus the responder. For a responder, you just do a wait and watch. Again, they posted their they published their in an abstract form. They just look for the organ preservation. As of now, the primary endpoint is DFS, which they would be publishing later. However, the organ preservation is significantly better in the consolidation chemotherapy arm. Now, this again is a concept of using consolidation chemo in which a short course radiotherapy can be attempted, in which a short course radiotherapy giving 5 fractions followed by chemotherapy versus the standard arm has been also attempted in the term of this Rapido trial, which has been published. And again, all the parameters with regards to the disease related have been significantly better in the experimental groups. So this group says that even for now, this is quite important, that the distant metastases are also less with the short course radiotherapy followed by the chemo versus the concurrent chemo radiotherapy arm. Now, the caveats of induction chemotherapy, the 2 trials which I could find out, one was this GCR phase 3 trial, in which they have compared the standard chemoradiation surgery followed by that adjuvant versus induction chemo followed by chemoradiation, in which they found absolutely no difference. I checked for any difference just for the sake of it that induction is helping us, but none. So all the findings were were not there. Toxicities which were recorded as acute, I checked the supplement. They haven't mentioned the acute toxicities with regards to the significance. Late toxicities, they haven't mentioned. There are discrepancies in the arms. With a threatened CRM was more in the CRT arm, that is in the standard arm. This is the IWWG group. This is more for that you need to do a TNT. The whole idea of using induction versus consolidation stems from the fact that you do everything prior to surgery, because post-surgery for radiation as well as chemo, there are a lot of tolerance issues with regards to the toxicities. This again is a trial that I could find out. Again, there are some caveats. It's again with regards to the induction chemotherapy followed by the standard CRT. And this was the randomization protocol, simple, that you give neoadjuvant chemotherapy. There are a lot of discussions among medical oncologists using FOLFOX, FOLFIRINOX, and KPOX. So I'll leave it up to you. My endpoint as an oncologist would be to see which sort of sequencing helps the patient better. Now, these guys...
requested to conclude, sir.
Yes, sorry. So these guys wanted a 10% increment from 75 to 80%. However, they could just achieve a 76% even in the neoadjuvant chemotherapy arm. And the cancer-specific survival was not significant. There were a lot of queries with regards to the forest plot for this trial, and no comparison. Again, this Prodigy trial has no comparison with the consolidation. Authors concede in the discussion part that the cardiac mortality in the SOC, because of suboptimal patient evaluation, these guys have written themselves. The MFS and the DFS does not translate into overall survival, and it's exactly not an NOM. So people were operated in this trial. Again, it was just a simple thing that post-radiation, we should wait not for 6 weeks, we should wait for 7 to 11 weeks. There have been meta-analysis and studies which says that you wait better, then you get a better pathological complete response. So don't hurry up things. Ongoing trials, again, the OPERA trial is still going on with regards to the DFS, and a couple of cohort studies are also going on. Right, and the same sort of thing that the TNT is here to stay, no doubt about it. It will gain further weightage, gain further evidence. But the idea of giving radiation prior to the chemotherapy, that is to employ consolidation chemotherapies with respect to better PCR, which should then reflect as better DFS, and then probably with passage of time and with mature results, a better OS. Thank you so much. Thank you.
Thank you, Dr. Pranav, sir. So speaking for the second half of the debate for chemotherapy, first we have Dr. Nitin Chaudhary with us. Sir is a hemato-oncologist from Jeevan Jyoti Cancer Hospital in Surat. Over to you, sir.
Hello. Kindly allow me to share screen, sir.
So please go ahead, sir.
First of all, I would like to thank. Am I audible?
Yes, sir.
Hello.
Yes.
Yes, sir.
First of all, I would like to thank the organizers for giving me an opportunity to speak here. I would also like to thank Dr. Sneha And I would like to congratulate Dr. Pranav for his wonderful what you can say thoughts on this matter. So first of all, we should know the evolution of rectal cancer management so far. We know that total mesorectal excision is better than conventional surgery in terms of local recurrences. If you add adjuvant RT to TME, it decreases local recurrences even further, but there is no improvement in distal metastasis. Pre-op versus post-op RT, we know pre-op is better. One thing which is which is not answered even as of today is how to integrate timing of chemotherapy in the management of rectal cancer. This is still evolving science. So if you see colorectal cancer collaborative study, you will find that OS benefit was there only with pre-op RT. Similar meta-analysis by Kama et al. You will find that pre-op RT pre-op RT followed by surgery, it decreased local recurrences and it improved 5-year survival. But there was no reduction in terms of distal metastasis. So if you see patterns of failure in rectal cancer, a study done by Young Kim et al., you will find that distant metastasis was major pattern of failure even after pre-operative chemoradiation. Similar AIO 94 study done by Rolf Saur et al. It was an 11-year extended follow-up study which compared pre-op CTRT, and they found that even after such a long time of follow-up of 11 years, it was better in terms of local control. However, there was no effect on overall survival. So in this study, they had used 5-FU as a chemotherapeutic drug and with CTRT. So authors suggested to use more effective systemic treatment up front to reduce distant metastasis and to decrease and to increase survival. So what we can conclude that distant metastasis is major concern in management of rectal cancer even in today's era, even with whatever CTRT which we are using upfront. So our all effort should be directed to decrease it. So a concept of TNT was proposed, and first iconic study was done by Ian Chow. He used 12 weeks of capox, and the authors found that there was substantial tumor regression, rapid symptomatic response, and achievement of R0 section with upfront capox. Similar study by Carlos Fernandez, they found they used 12 weeks of capox as induction therapy. They found that there was similar pathological CR in both the arms. However, there was more favorable compliance and toxicity profile with chemo first. So if you analyze all these trials, including the AIO trial which Dr. Pranav quoted, you will find that all of these trials have used either 5-FU, Folfox, Capox as upfront therapy, and none of these were phase 3. All were phase 2 study. So as Prodigy 23 or already Dr. Pranav has told us, just I would like to share some things which maybe he must have missed out. This is a phase 3 study. The authors gave 3 months of FOLFIRINOX followed by CTRT, followed by surgery, and 3 months of adjuvant therapy versus standard of care arm. So primary and key secondary endpoint, that is DFS and metastasis free survival, was significantly better in the study arm. Quality of life was better when chemotherapy was used upfront. Safety was better when chemotherapy was given upfront.
1 minute left, sir.
Yeah, this is my last slide. So just to conclude from Prodigy 23 study, it was the first phase 3 study which used upfront FOLFIRINOX. We know that FOLFIRINOX has got good activity in metastatic rectal cancer, so it can be used here upfront. This is what has been happening in many other malignancies like breast cancer and others. So we can use FOLFIRINOX upfront. It increased DFS and metastasis free survival. There was also OS was slightly more for chemotherapy upfront. However, it was not statistically different and statistically significant. P value was 0.7, and also there was increased pathological CR when chemo was used upfront. So the investigators concluded that TNT with modified FOLFIRINOX should now be considered as new standard of care in the management of advanced rectal cancer. So just take home message is distant metastasis is still a major concern in management of rectal cancers, and upfront chemotherapy with preferably modified FOLFIRINOX now should be the standard of care. Thank you.
Can I do a rebuttal, please?
Hello.
Yes, yeah.
Can I offer a rebuttal?
Yes, Dr. Pranav.
Yeah, you can.
Yeah,
You can.
Yes. Okay. So Prodigy trial doesn't compare induction chemo versus consolidation chemo in the TNT. First thing. Secondly, there's a very good letter to editor by Bushko in the same editorial, which says that DFS, even though it is improved, the cancer-specific survival and the overall survival were within the same limit. Even though I totally sort of concede that the data is still not mature enough, but the DFS with regards to several meta-analysis does not translate into overall survival. So Prodigy loses out only this opera trial, which is still going on, which would tell us now regarding the phase 3 versus phase 2 sort of a quandary. A randomized phase 2 can also look for a DFS, which opera trial is doing. Actually, they've just posted their organ preservation sort of details, but they would be coming out with the DFS, which is actually their primary endpoint. The opera trial people from Memorial Sloan Kettering have kept DFS as their primary endpoint. Secondly, we have to wait after radiation for the pathological complete responses. The Prodigy trial, if we look in the supplement of the Prodigy trial, the extramural spread in the conventional, the standard of care was much higher in the Prodigy arm. Secondly, the toxicities I failed to understand were less in the induction chemotherapy arm compared to the FOLFIRINOX, compared to the standard of care. And the authors themselves in the discussion have mentioned that probably there was a sub-op. The patients in the standard of care arm have died more of cardiac mortality. They mentioned, and they themselves have conceded that they probably did not have an optimal sort of patient evaluation in the standard arm because it was an open label trial. So these are my points against the Prodigy trial. That's it. Thank you.
So
hello.
Yeah, point well. Yeah.
Yes.
So thank you, Dr. Nitin, and I think thank you, Dr. Pranav, again.
Thank you.
I think after hearing all both of your comments, I think we'll pass on the final comments to Dr. Prasad Narayan. Sir, Dr. Prasad Narayan, sir, is a medical oncologist at Site Care Hospital, Bangalore. So if you could sum up.
Thanks for this opportunity. And it's a complex scenario. First of all, the systemic therapy in rectal cancer itself is a derivative of what we know from colon cancer. And the neoadjuvant therapy, there is a lot of options of short course, medium course, long course, and then concurrent chemo, neoadjuvant chemo. But I think both Dr. Pranav and Dr. Nitin have their points right, as in most of the debates in oncology. And I think the take home will be that the question was sequencing of therapy in non-operative management of rectal cancer.
Yes,
so I thought maybe somebody would have taken it as a non-operative strategy where we are not going to operate on some patients, right? I think both of them did not touch that.
No, I did. Sorry, pardon me.
Right. So non-operative management means we should give definitely a local therapy in the primary setting because local therapy is required. So there is no doubt about that. How do we sequence that? The best possible chemotherapy has to be given along with that because then that is the time when you get maximum pathology. I think this is an evolving data. We have to wait for long-term data here because we don't have actually much data on non-operative management yet that we can leave the pay. We are all talking about pathological CR. And so let us wait for the data to mature. We all know that our ability to give more stronger and better chemotherapies is evolving, and FOLFIRINOX, we are all getting more experience by using it in these settings. Those are my comments from this.
Also, I would just like to add as a PS postscript would be that radiation therapy has also evolved. Please don't consider radiation as that of 30 or 40 years back. My request, my sincere humble request.
Absolutely.
Thank you.
That is not taken away at all, actually.
Thank you so much. Thank you.
Pranav, point well
Thank
taken.
you, everyone.
Definitely, good radiation can definitely lead to improved results. It's not just chemotherapy. So optimal radiation, optimal chemotherapy, and optimal consolidation, and optimal interval between radiation and surgery. These are the key points which we have to take into account.
Yes. I just want to quiver the first.
Most of the studies are from Haber. Yeah. Yeah, exactly. Both speakers.
Dr. Smith?
Yeah, so thank you everyone. So moving on to the next debate, which is regarding first-line treatment in left-sided RAS BRAF wild-type metastatic colorectal cancer. Speaking for EGFR inhibitors, we have Dr. Reshma Puranik. She's a medical oncologist at Avinash Cancer Clinic in Pune. Over to you, Dr. Reshma.
Thank you, Dr. Smith. I thank the organizers for this opportunity today. And in this debate, I'll be talking for EGFR inhibitors in the first-line treatment of left-sided RAS-BRAF wild-type metastatic colorectal cancers. I hope I'm audible.
Yes, ma'am, you're audible.
Okay. So the selection of initial therapy in metastatic CRC depends on various factors like fitness, comorbidity of the patient, molecular profile of the tumor, which is the most important nowadays, location of the primary tumor, intent of the therapy, and the affordability of the patient, of course. So what is the evidence which favors EGFR inhibitors in the first line? So coming to few landmark trials, that is the Crystal trial, which included 1198 patients of metastatic CRC randomized into two arms, that is FOLFIRI plus minus cetuximab. So this arm, in which the subgroup analysis of this trial clearly demonstrated that in the left side RAS wild-type tumors, the PFS objective response rate and the overall survival were clearly favoring the EGFR arm. So the overall survival was 21 versus 28 months. So adding cetuximab to first-line FOLFIRI clearly benefited patients with left-sided tumors. The second trial was the Taylor study, in which instead of FOLFIRI, we had the FOLFOX arm. So Erbitux plus minus FOLFOX plus minus Erbitux, and the endpoints were PFS, OS, and objective response rate. So this study, there was a significant benefit of Erbitux plus FOLFOX versus FOLFOX alone in all the three secondary endpoints, clearly establishing the role of EGFR inhibitors. Then there was a meta-analysis which included the trials which also had panitumab. So this was the meta-analysis of the four important key trials of the two EGFR inhibitors. In this, if we see the forest plots for overall survival, PFS, as well as the objective response rate, there is a significant improvement in OS observed in patients with left-sided RAS wild-type tumors treated with chemotherapy plus cetuximab and panitumab compared with chemotherapy alone, HR for which was 0.76. So this meta-analysis established the benefit which these EGFR inhibitors offer and also proved that RAS wild-type left-sided tumors derive a more benefit from these agents. Going ahead to the most important head-to-head comparisons. So we are going to talk about three important trials: FIRE trial, PEAK trial, and the CALGB trial. So the important landmark FIRE 3 trial had FOLFIRI plus either cetuximab or bevacizumab. So if we look at the overall trial results, definitely there was not much of a difference in the OS and PFS. But when a subgroup analysis was later on done, benefit of cetuximab over bevacizumab was limited to patients with left-sided primary tumor. The median overall survival for whom was 28 versus 38 months. So this was a very significant, as well as the objective response rates for left-sided RAS wild-type were very high. So left-sided RAS wild-type tumors, cetuximab plus FOLFIRI is greatly superior to bevacizumab plus FOLFIRI. Then the second important trial was CALGB or SWOG. In this, again, the chemo backbone was compared with into two arms, cetuximab versus bevacizumab. Overall, the OS and the PFS were the same, but in the retrospective analysis, amongst the patients with RAS wild-type tumors, cetuximab provided superior survival for those with left-sided primary tumors, that is a 39 versus 32 months. In left side, RAS wild-type, again establishing a superior efficacy of the anti-EGFR inhibitors. And the important trial, that is the PEAK trial, was similar except that it had panitumab, and we compared it with bevacizumab. So the median PFS was longer for panitumab versus bevacizumab in the RAS wild type, that is 12 versus 10 months, and in the RAS BRAF wild it was 13 versus 10 months, HR of 0.6. And the median OS for panitumab versus bevacizumab in the RAS BRAF wild type was 41 versus 28 months. So this was a very, very significant. So all these three were very much important and landmark trials which established the superior efficacy of these drugs. Then there was a meta-analysis by Heinemann et al. Again, an important analysis because it included the analysis of the three trials which we just saw, as well as it had one more endpoint, that was the effective early tumor shrinkage. So ETS of 20% at week 8 was an exploratory endpoint. So we can see totally in this graph, we can see that the objective response rate, ETS, and the OS were clearly, the HR for him was clearly much significant for the EGFR inhibitors. So the meta-analysis supports a benefit for first-line EGFR with chemotherapy with respect to OS, ORR, and ETS. So this is just illustrated in the same. And ETS was a new endpoint which was pointed out by these meta-analysis. Now, why is ETS important? Because tumor shrinkage improves long-term survival, promotes symptom relief, and increases the chance of resecting mets. And it is correlating with the overall survival. Like we can see, ETS more than 20% has a more median overall survival as compared with that less than 20%. So, and one more meta-analysis, which was the Holsch meta-analysis, it included the primary tumor location. So the same trials which we just saw, but the analysis clearly showed that PTL was predictive of survival benefit from addition of anti-EGFR to standard chemotherapy. So overall survival HR for left side was 0.69. And meta-analysis of the 3 important trial indicates that patients with RAS wild-type left-sided tumors, greater survival benefit from anti-EGFR, HR of 0.7. So the same graphs which are illustrating. And just one last point, which also I want to emphasize, if we use cetuximab in the first line, we have an opportunity of using bevacizumab in the second line. So the trial of Liu et al. Had 2 groups. Group A was cetuximab in the first line, followed by bev in the second line. And group B only had exposure to bev. So in this trial, they clearly demonstrated that group A patients had a better OS and PFS. So cetuximab first line application may provide a favorable condition for promoting the effect of subsequent bevacizumab. So my conclusions are, left-sided CRC tends to be more enriched for EGFR expression than right-sided, in which MSI and BRAF are predominant. That can explain the selective efficacy of EGFR in left-sided tumors. Cetuximab is better choice for RAS wild-type because in FIRE trial, we had excellent response rate of 72% and ETS of 68%. Now, many of the meta-analysis that we just saw of the landmark trials clearly showed a benefit of anti-EGFR and that left-sided tumors responded more to cetuximab. The application of first-line application cetuximab may provide a favorable condition for promoting the effect of subsequent benefit. Bevacizumab, this is one more benefit. And ETS can be an important secondary endpoint. So concluding, patients with RAS wild-type, BRAF wild-type, metastatic CRC with tumors on the left side of colon are recommended to start first-line treatment with chemotherapy combined with EGFR, considering all of the significant data that we just saw. Thank you. It was a very short time.
No, so very well said. Thank you, Dr. Reshma.
Yeah.
Moving on to our next speaker for VEGF inhibitor. So speaking for VEGF inhibitors, we have Dr. Hemant Dadis. Sir, sir is a medical oncologist at Sudha Hospital and Medical Research Center at Kota. Over to you, sir.
Yeah, can I share my slides?
Yes, sir. Please go ahead.
One more minute.
Sir, are you having any difficulty? So you'll have to unmute your mic, sir.
Good evening, everybody. Can I audible?
Yes, sir. We can hear you, sir.
Yeah. Good evening, everybody. I thanks to organizing for providing me this opportunity. I will speak for favor of VEGF inhibitor in first line treatment left-sided RAS BRAF wild type metastatic colorectal cancer patients. Slide is now moving. Yeah. So coming to FIRE 3 trial, it was phase 3 trial and it randomized cetuximab plus cetuximab versus bevacizumab with fall-free. And primary endpoint of this trial was overall response rate. And this trial failed to meet its endpoints for bevacizumab containing arm. Overall response was 58% versus 62% in cetuximab containing arm, and p-value was 0.183. If we have a goal of treatment is survival, the stable disease is also very important. In bevacizumab containing arm, it was 28% versus 17.5% in cetuximab containing arm. if we see the PFS curve, whether left side or right side curve were identical. So based on this, can we change our practice? And if we see the peak trial, it was phase 2 randomized trial, and it has very small sample size. And if we look at the response rate and overall survival was not statistically significant, and response rate were identical between both comparative arm in RAS wild or BRAF wild type subgroup patients. And we know the intensification of upfront chemotherapy backbone positively affect the prognosis of our patient. So in TRIBE trial, the FOLFIRI was added with bevacizumab and compared with FOLFIRI plus bevacizumab. And the result, what we have found that the bevacizumab significantly prolonged the overall survival in patient of unresectable metastatic colorectal cancer patient compared to FOLFIRI plus bevacizumab. And another important finding that this improvement is independently of their RAS or BRAF wild type mutational status. So triplet plus bevacizumab is superior to doublet plus bevacizumab. And in metastatic colorectal cancer, 20% of the patient will have resectable or potentially resectable liver metastasis. In that subset of the patient, the new EPOCH trial has compared systemic chemotherapy with or without cetuximab, and mature data what has shown in this setting, cetuximab has shortened overall survival by 2 years compared to chemotherapy alone. And this detrimental effect was whether it was left side or right side, and those patients who had RAF mutation wild type also, this detrimental effect was there. So chemotherapy plus cetuximab was inferior to chemotherapy alone in this subset of the patients. And we know that triplet plus bevacizumab is better than doublet plus bevacizumab, but there is no head-on trial comparison. So one propensity score-based analysis has just published in the Oncologist in this year. It has analyzed 5 randomized controlled trial containing FOLFOXIRI plus BEV, and it has compared doublet plus anti-EGFR therapy, and what it has found that there is no superiority of anti-EGFR therapy comparing to FOLFOXIRI plus bevacizumab. And if we look at the data, PFS was 13.3 compared to 11.4 month, and OS was 2.8 month more in FOLFOXIRI plus bevacizumab. 1 minute more. So which side still are on you? And if we see the KLGB trial, it has shown that nanobiological monoclonal antibodies has shown greater overall survival in this metastatic colorectal cancer setting. Even post hoc analysis, survival was not different in expanded RAS mutation subsets. And one element I want to highlight that the element not included in own study information was primary cancer sites, that left side or right side. It was in this information was collected post hoc through chart review. So we know that 5 to 10% of the left-sided metastatic colorectal cancer patient will have HER amplification or c-MET mutations. And we know these are the detrimental to response and detrimental to benefit of cetuximab. And NCCN guidelines also include the different strategy to treat this type of the mutations. So I hope better science has prevailed. We know response rate are not superior in all head-to-head randomized controlled trial. PFS is not consistently superior and is identical in FIRE and KLGB trial. OS for peak data itself speaks for itself. KLGB, it is post hoc analysis, and we should not change our practice on these exploratory analysis on the basis of this exploratory analysis. And the data of triplet BEV, it's for me resonance of choice. And we know the inferior data for cetuximab in operable liver metastatic disease. And remember that we are living in a developing country and we pay most of our medical expenses out of our pocket, and with the per capita income less than Bangladesh. So even should I even mention the cost difference between bevacizumab or cetuximab panitumumab? I think 30 to 40K for bevacizumab and 2 to 3 lakhs per month treatment for cetuximab or bevacizumab. So the eyes are useless when the mind is blind. And truth is so obvious, even blind man can see. Thank you.
So, thank you, Dr. Hemant, again for sharing your thoughts. I think we would like to hear final conclusions, I think, from Dr. Krupa Shankar. Sir is a medical oncologist from NSR Can Cure Center, Coimbatore. Sir, if you can, make this subject less confusing.
Yeah, thank you. I'll try to do that. But first of all, before I begin, I'd like to congratulate the organizers for having put together this wonderful academic extravaganza, and also thank them for the opportunity. And I also like to congratulate both the speakers for having put up a wonderful debate. I think they really stuck to their guns, and both of them really made pertinent points. So I'm not sure if I'm will be able to give the expert comments here, because I'm just not going to proclaim that I'm a self-proclaimed expert, but I'm just going to share my thoughts and views on the debate. So I think primarily you'll have to look at identifying your intent of treatment, and like was rightly discussed earlier, you're going to have patients with liver-limited metastatic disease, and somebody with resectable liver-limited metastasis, there is just no role for any biologics there. So somebody with borderline resectable or in the unresectable setting is where we're going to use biologics, be it VEGF inhibitors or EGFR inhibitors. So for me, this debate is bordered only on these two subsets, the borderline resectable and the unresectable subset. And yes, there is a paucity of data, but whatever data that we have had until now, which is the head-on-head comparisons based on these three studies, the CalGB, the FIRE3, and the PEAK studies, this is a meta-analysis. And as you can see from the forest plot, clearly favors the anti-EGFR. And when we're talking about left-sided patients with wild-type RAS-RAF as well. Agreed, yeah, the point that was made about HER2 amplifications or the other downstream signaling pathways like the PI3K and the c-MET as well, which can be amplified. But again, for the sake of the debate, I think we'll have to stick to a completely wild-type tumor. So what are the reasons as to why we believe that probably EGFR inhibitors are probably better than VEGF in the first-line setting? So first thing is obviously they sensitize the tumors towards subsequent lines of treatment. You still can use VEGF inhibitors in the second line. Whereas if you use a VEGF inhibitor upfront, they can desensitize the tumor to subsequent EGFR use. And like was alluded to earlier as well, the early tumor shrinkage and depth of response are much more better with the EGFR inhibitors. And that's a primary, primary goal, probably if you're looking at cytoreduction in somebody with unresectable or borderline resectable disease. So that thereby definitely showing that the EGFRs will have an edge. And if you look at all, all these phase 2 and phase 3 trials looking at chemo with biologics, again, the response rates have consistently been about 10 to 15% higher with the EGFR inhibitors as opposed to VEGF inhibitor. So I think, again, this is a very important consideration that we'll have to take into account, especially if you're looking at cytoreduction as your primary goal. And again, this could also be a surrogate endpoint towards predicting for a better survival, and maybe only a surrogate. And again, if you look at the resection rates as well, again, I think we had the data from the TRIBE study, which the other speaker also pointed out about using a triplet with bevacizumab. Agreed. Yes, the response rates are really high if you use a triplet with bevacizumab. But it's not like we don't have data to use triplets with cetuximab as well. We have data from the cricket study and also from the Wolfie study, which has looked at using a triplet with cetuximab. So that can also be done. So again, this is just retrospective data, and again, here you can see when you combine a triplet with cetuximab, the response rates are very high, up to the tune of around 80-85%, and about 48 months survival. So to me, the EGFR inhibitors probably tick all these 4 boxes: the response rates, maximal tumor shrinkage, duration of response, and the safety profile as well. And when I talk about safety profile, we all know about the issues which bevacizumab has, especially if you're contemplating surgery, you'll have to definitely look at stopping bevacizumab for at least 4 to 6 weeks. The product insert says 4 weeks, NCCN says at least 6 weeks. And there's obviously delayed wound healing, GI perforation, fistula formation, and necrotizing fasciitis with bevacizumab. So if you have a patient whom you're opting for cytoreduction, then probably you're only going to do 1 cycle of bevacizumab and then give them 6 weeks off. So to me, not a great option. So I think probably I'll end this debate by saying it's not about winning, and it's just about the exchange of knowledge, which we've had in plenty today. So thank you.
Very well put. Thank you, Dr. Krupa Shankar, sir.
Thank you.
So we'll move on to the third session, which is a molecular tumor board case presentations on clinical implications of next generation sequencing in non-colorectal GI cancer. And We are privileged to have our moderator, Dr. Viraj Lavangia, sir. Sir is a medical oncologist from HCG Hospital in Ahmedabad. If I can introduce the panelists. So, yeah, we have in the panel for discussion today Dr. Lalit Mohan, sir. Sir is a medical oncologist from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Amol Kotalwar, medical hemato-oncologist from Shalby Hospital in Surat. Dr. Rohan Bise, sir. Sir is a medical oncologist from KLES, Dr. Prabhakar Kore Hospital and Medical Research Center, Belgaum. Dr. Jacob George, sir. Sir is a medical oncologist from Manipal Hospital in Goa. Dr. Piyush Bajpai, sir. Again, a medical oncologist from Manipal Hospital in Delhi. Yeah. So I think I will like to hand over the session to Dr. Viraj, sir. Over to you, sir.
Thank you, chairpersons. Thank you, MOC, and thank you, ICON, for having me here. This is a difficult topic for moderation, NGS for non-CRC GI cancers, predominantly because of its rarity. So what I have thought is I have brought some of my cases here, which I have encountered during my clinic, and we'll have all the people who are here on the Zoom to vote. I have put 4 answers to question. All 4 answers are same for each and every question. So I want everybody to vote, please. And once we have a vote, I will have each of my panelists discuss that vote and have his comment in the end. So I'm not here to preach. There's no right or wrong answer. In the end, I'll just tell what I did with those cases and we'll move ahead. So I request all my panelists to turn on their video so I can direct questions at you. I see only Dr. Lalit and Dr. Jacob. I see Dr. Rohan, Dr. Amol. Dr. Piyush, are you here? Okay.
Dr. Piyush, you'll have to unmute your mic, sir.
All right, but I don't see his video. All right, so let's start. And Kashish, you are with me, right?
Yes, sir.
So why can't, can you see the case or no?
Yes, sir, we can see the case, sir.
No, we can't see on the left side of this slide. We can see only the biomarker finding.
How is that possible?
Do you have some animations?
No.
Sir, it's clear on my screen, sir. Can I request you to reshare your screen, sir? Probably that will help.
Oh, yeah. Yes, correct. I'm sorry. I forgot it's an animation. Okay, so this is the case 57, and this is for Dr. Lalit Mohan, sir. All right, so 57-year-old male, periamp carcinoma, had a Whipple in 2012, was T2 and 0. He didn't receive any adjuvant therapy then, so we are talking about 9 years ago. Then 5 years later, he has isolated tumor bed relapse, which he underwent CyberKnife because that was the only lesion. And then during this COVID pandemic, he had 3 liver lesions in 2020. They were not resectable. We did ask surgeons, but just for the sake of this discussion, we'll keep it unresectable. We put him on FOLFOX, 8 drums, and we finished by November 2020. His PS is 0, except he has got grade 2 neuropathy. Now, at the same time, we also sent this liver biopsy for foundation, and the report is on the right side. There are several alterations, except one being ATM splice site variant. So all the cases will have these 4 questions. Is this report, and patient wants treatment, is this report good enough for you to go for target therapy? Or you would say no target therapy because there's no level 1 evidence, or you would say no target therapy because you don't justify using PARP inhibitors for this ATM variant. Or the 4th answer, which is of course not applicable for this case, but maybe for other case, is no targeted therapy because I doubt this lab and I would like to do NGS again. So Kashish, can you bring the voting? Okay, I urge everybody in the Zoom to please vote. And we'll have 15 seconds. So Kashish, once you have enough answers, you can put the vote on the screen.
Sure, so we got 10 out of 21.
I think so that's good enough. Let's put it on the screen. Okay, so Dr. Lalit sir, this is what our own colleagues are thinking.
Yes.
That they would use olaparib maintenance in this scenario. And half of them also think they would not use olaparib because there's no level 1 evidence. Forget there's no evidence for ATM mutation in GI malignancies. So what would you think? What would you do in your practice?
No, I'm also, in fact, not very sure, and there is no clear-cut evidence. And most commonly, these things like this molecular tumor board in non-CRC, first time I'm witnessing. So there is no clear-cut evidence to use any of the targeted drug. But again, the ATM positivity guides towards use of platinum in some of these studies. So this is what I
The
interpret.
patient has already got 8 cycles. Would you continue 5-FU or capecitabine maintenance or go for olaparib? What would you do?
In fact, if already we had given 8 cycles, so there is no point in continuing the same drug if there is. So maintenance, I'm not very sure honestly how to handle this.
Okay, Dr. Piyush, any comment before I move on to the next case?
So now that ATM is definitely one mutation which has come up, and I would consider, since I have done Foundation 1 and I have got this report, the intent was to look for some targeted therapy. Now, talking about evidence, yes, we have proof of the concept that yes, olaparib could work in this particular, and there are anecdotal data. Probably the percentage might not be there in this particular cancer, but
So
otherwise it is there. So a discussion, of course, is required that this is going to be something that on an anecdotal basis with the patient. So a discussion with the patient, and yes, if the patient is ready for it, yes, I would.
For non-CRC, it will be all anecdotal, right? Because we just don't have much data. So I'll tell you what we did. This patient is already on 7 months of olaparib and he's maintaining his disease. I don't know that's right or wrong, but this is just what we did. All right, next case is for Dr. Amol. So Dr. Amol, this is gallbladder cancer, 62 female, underwent cholecystectomy in 2017, T3N0, got adjuvant capecitabine for 6 months, like Bilcaps-3, and just within a year, patient had multiple unresectable liver lesions. Patient had 3 cycles of gemcitabine cisplatin and had progression on first-line treatment. Performance status was 2, but the patient insisted they want some form of treatment. So of course, the next treatment is irinotecan-based chemotherapy or best supportive care, or we did this NGS report. This report is from Positive Biosciences, and this is what it came, IDH2 mutation, for which we have now data. We have IDH inhibitors. So again, the same questions. Would you go target therapy, no target therapy? So let's have the vote.
So we've got 12 months.
You got 10 answers?
Yes, sir.
Great, let's show up. Okay, nobody wants to doubt this lab. Okay, great. Amol, so what are your thoughts?
Actually, sir, as it is a rare cancer, and I haven't used any NGS for the gallbladder, and there are some case report which is showing IDH ivosidenib having some result, and we can use if patient is willing for the same.
So you may consider use of IVO in this.
Yes.
That would cost around 8 lakh rupees a month.
Yeah, cost is the issue. We will explain to the patient. If they are okay with that, then we can offer the benefit and he can get treatment.
Okay. Dr. Jacob, your thoughts on this?
Cost is always the elephant in the room. That goes without saying, but given the chance, gallbladder cancer, chemotherapy, we all know the prognosis is bad. So they can afford it, certainly. But I'm not sure it was available in India, actually.
Correct. You have to import it. Yes, Lalit sir, you have a point.
Yeah, Viraj. In fact, looking to this, and this mutation is positive in 20 to 30% of the gallbladder cancers. And of course, we are discussing the science part, not the economics part. So if everything sets in, we would like to use that because we don't have otherwise any solid options left over.
Okay, so my patient couldn't afford this much. She was ready for 1 or 2 lakh rupees a month treatment, but not this much treatment. So anyways, this patient went on irinotecan and unfortunately died within 2 months. So that is what happened. But yes, I agree. At that time, IVO was not freely available. It was not even approved that time. IVO got approved recently. But okay, I'm glad to know. Any questions on, so Dr. Lalit, just a question. Do you feel that one lab of NGS may be different than another lab of NGS? Have you any experience with that?
Honestly, not, because we trust most of the labs are now reasonably doing good job, and I'm happy that the NGS cost has also gone down, in fact, with the availability of various labs. As clinicians, it becomes always that we use the best lab, but how to check that lab parameters is also beyond the clinician's say discretion. So honestly, we trust that most of the labs are doing good job.
Okay. All right, Dr. Jacob, this is for you. This is one of my recent patients, actually. 65 male, metastatic intrahepatic cholangiocarcinoma, finished 8 rounds of gemcitabine cisplatin with a very good response. We did response at 3 cycles and then response at 8 cycles. Patient wants to continue some form of treatment. One option was, of course, to continue GemCis because there's no maintenance like in this scenario, or put capecitabine maintenance. Or this is the NGS report, which showed BRAF alteration, but it was marked as VUS and not classic V6. What's that? V600E, correct? V600E. So let's have the voting, Kashish. Let's see what people would do here.
So we've received 8 out of 20.
Only 8. So please, I urge everyone to please vote. Even the non-panelists, please, I request everyone to vote. It's anonymous. Okay. Okay. So Dr. Jacob, what would you do?
I would not use a BRAF inhibitor because other than V600, I'm not really sure whether these things work. Toxicities, and apart from toxicities and cost, I'm not really sure they work. I mean, rarest of rare and it's unknown. I mean, it's a VUS. I probably would give something else or follow up.
So you would just continue the patient on follow-up and not give any further treatment.
Or maintenance capecitabine is another option. Certainly not BRAF inhibitor.
Certainly not BRAF inhibitor. Okay, Dr. Piyush, what are your thoughts?
I agree, actually. So
okay.
BRAF V600E, if it's not there, then I would also not consider looking at the toxicity profile of the molecule, as well as, yeah.
Great. So we all agree that BRAF inhibition, apart from V600E, although tempting. Intrahepatic cholangiocarcinoma, we have a phase 2 study in ROAR, which showed 40% response rate with just dabrafenib trametinib. But that was, I agree, all V600E. So patient had a question that, sir, can we try? This is his son is in paramedic, and he searched out and said, sir, can we try dabrafenib trametinib? And I said, wait, let me ask my other colleagues and I'll get back to you. So the answer is, I think so we should not be tempted to use BRAF inhibitor in this, right? Any of my panelists would want to?
Viraj,
I see 25%. Yes?
Yeah, in fact, I'm not very sure, but I would like to repeat the test before taking the final conclusion, because
so
I'm not
do it
sure.
in another lab? You do
Yes.
it in another lab?
Yes.
Okay. That's an interesting thing. So this report is from 4-Base Care, which is launched new, I think so, year and a half. Okay, fair enough point. So any of my panelists said targeted treatment, or they were all from the other? Anybody, 25% got said that they will push for dabrafenib trametinib. Any one of my panelists said that? No. Okay. So let's move. Dr. Piyush, this is for you. 72 male, metastatic G junction, adenocarcinoma, HER2 negative MSS. We did FOLFOX times 8 and patient progressed. Had some response after 4, but at 8, the response was lost, which is classically what we see in gastric cancer. Had 2 months of Paclitaxel and again progressed. Progression is just few nodules in peritoneum. Otherwise, performance status is in fact 0. And patient wants further treatment. And this is the NGS. This is from MedGenome. And let's have the vote, Kashish. Cost issue, okay. Dr. Piyush, half. Half wants to do it, half does not want to do it. What's your thought?
So actually, I can see APC is 36.8% and BRCA2 is the prominent one. So
yeah.
I really do not know. I really do not know.
Okay. Still, let's say this patient comes
this is
for an opinion to you, you know, what would you tell them? Because this is what
refer to a molecular oncologist in the city.
Okay, Dr. Rohan, I see you. Can you comment?
Yeah, because BRCA2 is an actionable mutation here. So I would rather, if the patient affords,
well, there is an important
option for treatment.
Can you all see my arrow? You can, right?
Yes, we can see.
Okay, so it is the table of VUS. So what I have experienced is VUS of one company is not VUS of other company, because I think I have enough samples now to suggest this may not be pathogenic, or this may be, but if you, like Lalit sir said, I would check it in another lab. So would you push any olaparib? Now you have rucaparib generic, its cost is not a problem. Would you target, Dr. Rohan? What would you advise this patient?
Sir, if the patient wants treatment, wants to go ahead, and if affords, yes, sir, I would offer.
You would offer on a VUS. Excellent. Vashish, are you there? Vashish? Yes, Dr. Piyush.
TMB, what is the score?
TMB is low in this patient.
TMB is low.
Vashish, are you there? Or he's not there?
PDL1 is also negative.
I didn't do PDL1.
Okay.
MSI?
MSS, it is MSS. Dr. Ashish is there, or he's also not there? Okay. Any more comments? Lalit sir, what would you do? This patient comes for opinion.
No, again, I'm not very sure because age is 72 and metastatic, heavily pretreated disease. So I'm not very sure based on this report.
But what else do you have to offer?
Immunotherapy, I think.
Best
Okay.
supportive
So
care.
you would
in
do
the
nivolumab based on attraction 3. Okay.
Yes.
Fair point. Fair point. All right, let's move on. Kashish, you watch the clock and tell me when to stop. Okay, I have 10 cases. So tell me when to stop.
If we can take 2 more cases because
I'll take
we
2 more
overshot
cases.
that time.
Okay, okay, fair enough. So another case, gallbladder. This is again my recent case. Gallbladder cancer 47. HER2 is 3+ on IHC. MSS. We did GEMS trastuzumab for 8 rounds. Excellent response, followed by trastuzumab maintenance for 4 months, and then he started to have some mediastinal and some supraclavicular lymph nodes. Gallbladder mass was still under control, and you know, like in GI, I always like to repeat biopsy because HER2 often gets lost, like in gastric cancer. It's unlike breast cancer. So HER2 was IHC 3+, and we did NGS. And Dr. Rohan,
yes, sir.
NGS for you, and let's have the vote, Kashish. This was interesting. Kashish, ready with the vote? Okay. Wow. Dr. Rohan, 2/3 want to do some treatment target therapy. What target therapy you would want or you would not want target therapy?
Sir, with the available slide that you have showed, I don't know whether I can pick a target. MSH6 is likely pathogenic, but I don't know if I can target with any drug.
What about ERBB2 amplification or 2 amplified? And the copy number, I don't know.
HER2 you have already given trastuzumab. I don't know whether there is a first line evidence for any other second line HER2 targeted therapy here.
Okay, I know there is no evidence, but would you do it?
Sir, right now, no, sir.
No? Okay. Dr. Piyush, copy number 8, which is high, considered high amplification. What would you do?
I think so. I would also ask for MMR over here.
It's MSS.
It's MSS. Okay. On a single MSS6, it does not make it immunogenic, but ERBB2 is amplified. So if that is there, TXD trastuzumab deruxtecan is there to show the survival.
Okay.
So that can be considered.
That's 8 lakh per dose.
Sorry.
And HER2 is 8 lakh rupees per dose.
Yes. No, the trials are also the phase 4. The phase 3 trials. The phase 3 trials are also going. So
gallbladder?
I mean, the induction. Gallbladder. This is gallbladder.
Gallbladder. We are in gallbladder.
Yeah.
So I heard, I think Dr. Vineet Gupta from Delhi, he was telling me that he's going to get a trial of NHER2 in non-CRC GI malignancies. Lalit sir, would you be tempted to use TDM1 since it is cheaper now? Zydus came up with cheaper TDM1.
Yeah, theoretically, yes, because still the tumor is HER2 positive and we have used the first line trastuzumab. So otherwise, we don't have much options for this patient. So if finances are not a barrier, patient GC is good, affordability not an issue, we will.
Okay, so this patient just underwent 2nd dose of TDM1. Next time I will let you know whether he has responded or not. So that is what I did. Okay, last case, Kashish. Okay, Dr. Rajiv. Dr. Rajiv is with us?
No, sir.
No. Okay, so anyone. 37 male gallbladder cancer. This is very interesting. Gallbladder cancer presented with Krukenberg. HER2 was negative, MSS by IHC. We did GEMSIS ×3, and that lady progressed in her ovary. She had a 15 centimeter mass became 22 centimeter. So we had to remove the ovarian mass, just debulking surgery, no R0 resection, because thinking that that's a sanctuary site and chemo wouldn't go there. And now she's ECLBPS 0. She can do all her housework. She's a homemaker. And patient wants further treatment. And on NGS, there is an EGFR exon 21 L858R mutation. So let's have this vote and we'll end with this discussion. By the way, there is anecdotal data of TDM1 for gallbladder cancer. Based on that, MD Anderson is doing a study on that. Wow, 100%. Yes. Awesome. How many votes were there, Kashish?
There were 2.
Only 2?
Don't ask Kashish about this.
8.
Oh, 8 votes, everybody. So Dr. Piyush, let me come to you. EGFR targeting for gallbladder, yes, no?
Yes, if in case this is there, EGFR mutation is there, and it's also a subset where mucinous tumors can have EGFR amplification.
This was mucinous tumor.
So EGFR needs to be looked into mucinous tumor because cetuximab has trial, and
so would you want to use EGFR antibody or TKI?
TKI, afatinib, probably.
Osimertinib?
No, osimertinib. Osimertinib is very specific. So,
Lalit, what about you? Osimertinib for exon 21 EGFR mutant gallbladder cancer.
I'm not very sure about use in gallbladder, so I'll be comfortable with up to afatinib.
Afatinib. Okay, Dr. Jacob?
Cholangio or GB, there's data for Erlo-Bev, no?
Yes, there is. Cholangiocarcinoma can have EGFR mutations, yes.
So I'll add Erlo-Bev.
Erlo-Bev.
Like, I mean, it's lung in PFS is more. What are we going to lose? I mean, it is toxicity is probably less. She's young.
Then Ramucirumab, I hear those.
I won't go that far. I mean,
not that far.
Erlo-Bev, at least evidence is there for cholangio.
Okay, Dr. Rohan, what about you?
Sir, any EGFR inhibitor, be it erlotinib or afatinib, not osimertinib because of the cost.
Because of the cost. Okay, so I put this patient on gefitinib, and patient is 4 months on gefitinib. CA99 was 3,000, now is 85. Amazing response, and we are all happy. I selected gefitinib, I don't know why, but afatinib could have been an appropriate choice. So that's it, Kashish, time up, right?
Yes.
Dr. Vijay and NVS have not joined, right?
No, sir. No, sir. They haven't joined.
Okay. Just last case, can I quickly ask, because this patient wants an answer. Again, this is a recent case. Quickly, can I take Kashish?
Sure, sir. Please.
Right, thanks. No, not this one. This one, 9th one. Okay. So 84 male, G junction adenocarcinoma, HER2 positive, 3+, nab-paclitaxel, carbo, trastuzumab, weekly I did because of the age. Initial response, then progression. Performance status still 1. He still goes to work for his factory, but has got peripheral neuropathy. And the biopsy continued showing HER2 positivity, amplification, and CHEK2 mutation. And patient is asking me, can we do rucaparib, olaparib, or target HER2 again? Mind you, HER2 targeting in second line in gastric cancer has failed. TDM1 is negative, lapatinib is negative. So this patient wants some answer. So let's see if my panelists can give answer. Let's not vote. Okay, let's vote quickly.
I can't.
So in lack of time, Lalit sir, what would you do?
In fact, honestly, I'm not sure about, and I don't find the 5th answer that I am not sure about.
What is that? What is the 5th answer?
No, there is no 5th answer. Otherwise, the option would have been that I really don't know.
No, but if patient comes to you for opinion, because these are real cases, these are absolutely real cases.
In fact, I would like to review the literature before commenting on. So if you have reviewed, I'll suggest you to enlighten the
Okay. No, so these are again all anecdotes. Dr. Piyush?
Again, TDXD is an option because this is stomach, right? This
G
is
junction.
G junction.
Yeah.
So there, definitely that's an option because ERV.
Which one you said?
Druxitican, trastuzumab druxitican.
Correct. Okay.
It's an option because it's amplified and.
Okay, and HER2. Apart from HER2, would you target olaparib or rucaparib based on check 2?
I do not know the apart from BRCA, PALB2 and other mutations are somehow have not been so promising. That's the only bit of disappointment from other data sets. The proof of concept likes that check2 should respond, but then eventually the data is not coming with prostate and other organ sites. So I'm apprehensive. If TDXD is there, I would choose for that.
Yeah, that is expensive. Vikas, hi, I see you. Vikas, any opinion on my last case?
I will agree with them, sir, because yes, it's a very dangerous territory right now to terrain with. And I definitely say that I put up my case there. If you could just put it up in a SMAT7 and a FWB7 mutation that have picked up in the NGS in a gallbladder cancer progressed on GV.
Yeah.
I've never have gone through it and have looked up into detail, but then couldn't find anything related to
Well,
it.
they are not target. We cannot target them.
So that's what the problem with NGS is, that when you do it, you come up with these things, and then you have to bite your nail that why did we do it?
Okay.
So,
all right. So I'm thinking about going HER2 and some form of PARP inhibition. I don't know whether that will be successful or not, but patients definitely want some treatment. With that, I thank you all. It was a wonderful panel discussion. Thank you, Lalit sir. Kashish, back to you.
So, thank you, Dr. Viraj, for this interesting case series. And thank you to all the panelists. I would also like to thank the chairpersons for sharing this session. And in the interest of time, I think we'll move on to the next session. Yeah. So over to.
This session is sponsored by MCure. Our speaker is none other than Dr. Vikas Talreja, who's a medical oncologist from Regency Hospital, Kanpur. Over to you, sir.
thank you. I hope my screen is visible and I'm audible, and I won't keep you much long because it has been a long day and a very fruitful sessions of very intellectually challenging panel discussion by Dr. Viral and a very excellent discussion by the panelists. So we'll be discussing today the role of ferric carboxymaltose in the GI malignancies, and we have come to a consensus that the incidence of cancer-related anemia is quite common. 3/4 of the cancer patients have anemia at some time during their illness. 66% of the solid tumors, 72% of the hematological malignancies, 40% of them, 36% of the solid tumors, and 47% of hematological malignancies are severe enough to warrant RBC transfusions. In Indian context, these figures are likely to be higher because of the prevailing malnutrition in the general population. And when you look at the causes of the cancer-related anemia, they are numerous. So in India, nutritional deficiency, a common cause, B12, folate, iron, a lot of them, hemolysis, blood loss. Many times the bone marrow is infiltrated by the tumor cells, and we give a lot of toxic therapies, chemotherapies, radiation therapies, which causes this myelosuppression and has these implications. Cancer is also an important cause of anemia of chronic disease, other being infections, inflammatory disease, and renal failures. And what this leads to an overall impact in the quality of the treatment which we deliver, the quality of the life the patient is having, a prolonged fatigueness, a poor performance status, impaired cognitive functions, aggravation of already existing comorbidities like respiratory and cardiovascular, compromise, premature deaths, poor tolerance to the chemotherapy, compromised dose, the intensities we have to tamper with, and the tumor progressions. In cancer patients with anemia, hemoglobin less than 10, more symptoms and poor performance status, therefore leads a linear correlation with the status. If we look at the National Cancer Institute anemia scale, mild is less than 10, moderate is 8 to 10, severe is 6.5 to 8, and life-threatening is less than 6.5. And all of the chemotherapy regimens which we use across all tumors have some implications of grade 1 or grade 2 anemia in them. And who are those patients who are most likely to develop chemotherapy-related anemia? These are those older patients whose the baseline hemoglobin is marginally or just below the lower limits of the normal, who have been planned for a potentially myelosuppressive therapy, who had received transfusions in the last 6 months, likely to receive furthermore myelosuppressive chemotherapy and radiation therapy, especially to the flat bones for it. That's why the baseline evaluation and correction of cancer-related anemia plays a very important role in the overall treatment prognosis. So you have to evaluate those hemoglobin, reticulocyte count, MCVs, RBC morphology. You'll have to look at the peripheral smear, as these are microcytic, hypochromic, anisocytosis. You have to look at additionally where the blood is getting lost from. Is it the stools, where you have to look for the occult blood? You have to find out the concomitant nutritional deficiency of the patient. Look at the iron, TIBC, ferritin, B12, folate levels. Also look at whether the erythropoietin stores are adequate or not by looking at the kidneys. So creatinine and GFR does have a surrogate on the kidney functions. And also for the hemolysis, the Coombs test, direct or indirect, and haptoglobulins. And that's where the deficiency, iron deficiency, do have to play a very important role. So you have to look at the 3 parameters, the hemoglobin, ferritin, and transferrin saturation. The goals of the treating chemotherapy-related anemia is not only it improves the hemoglobin level, it also improves the quality of life, reduces the need for the RBC transfusion. And when we have to treat, we have to look at the guidelines. The latest guidelines from the NCCN plays a very clear-cut morphology, that you have to first look at how the RBCs look, what's the reticulocyte count, what is the MCV, look at the causes where the blood is getting lost. Is it this hemorrhage? Look at the stool occult blood test, look at the endoscopies. Is it is getting lost by an autoimmune hemolysis, direct or indirect, Coombs test, haptoglobulins, indirect bilirubin, LDH. Look at the intake, so nutritional factors, the iron, B12, and iron binding capacity and ferritin. Look at the kidneys where the erythropoietin is getting produced. Look at the bones where you are getting the radiation. Also don't tend to miss out the endocrine part of it. Look at the hormone dysfunctions, whether there is a concomitant hypogonadism or adrenal dysfunctions or hypo or hypothyroidism. And also look at the anemia of the chronic disease, the C-reactive proteins, the ESRs, and therefore these all, it's not just a single factor cause, it's a multifactorial cause, and that's why it's a multidisciplinary approach. And that's where it plays a very important role, especially at this table, when the iron stores are normal and the circulating iron are normal. So look, these parameters where we look at the bone marrow reserves are good. They will be 3+. The ferritin will be between 50 to 200. The transferrin total iron binding capacity will be between 300 to 360, and iron levels and saturations will be normal. But when there is a negative iron balance, the first place where the iron gets consumed is from the bone marrow, and that's where the stores gets the first replenished. So stores in the bone marrow becomes 0 to 1+. The ferritin gets reduced to less than 20. The total iron binding capacity increases to 360. And again, iron and saturations, they tend to fall down. This further subsequently leads to a poor erythropoiesis. Again, the bone marrow stores aren't there, ferritin below normal, iron binding capacity increases, iron and saturation also gets reduced. And this further eventually leads to an iron deficiency anemia, where everything is decreased except the total iron binding capacity. So it's a perpetual cycle that we have to look to it as where the patient is right now, and to bring it back to the as normal as possible. So for transfusion also, NCCN clearly lays out a very good guideline. It says that all those patients who are asymptomatic without any significant comorbidities, for initial transfusion, you have to hold your horses. For high-risk patients who have a tendency to have a decline in the hemoglobin with the intensive chemotherapy you're planning or radiation you're planning, or those who have comorbidities, because for them a decline in the hemoglobin would lead to a cardiac or a renal compromise or a pulmonary compromise. So for cardiac diseases, chronic pulmonary diseases, or a cerebrovascular diseases, you have to consider the RBC transfusions. And those patients who are symptomatic for in acute settings for the anemia, they have tachycardia, they have tachypnea, they have chest pain, they have dyspnea, they have lightheadedness, syncope, severe fatigueness, then also you have to consider for transfusion. And what's the benefit of the transfusion? Immediate relief. You get an rapid increase in the hemoglobin levels, symptomatic control, and you can avoid the risk of erythropoietin stimulating agents. But everything that has pros also has cons with it. There is an increased thrombotic events, transfusion transmitted diseases, congestive heart diseases, transfusion related many reactions. We see a transfusion circulatory overload, hemolysis, febrile, non-febrile hemolytic reactions, transfusion related acute lung injury, transfusion associated graft versus host disease, bacterial contamination, iron overload, and all these have an impact in the treatment delivery. And where the role of iron injections do come to play, I believe in all. And because when you assess the iron deficiency, whether it's an absolute iron deficiency or a functional iron deficiency, absolute is there is reduced iron stores as demonstrated in the labs. The ferritin is less than 30, or the transferrin saturation is less than 20%. Functional is where even though iron stores are normal, the ferritin is between 30 to 500, but the reserves aren't there. And there is a potential of iron deficiency. That's a possible functional iron deficiency, where even though ferritin is normal, the transferrin saturation is less than 50%. So you have to look at all the three parameters. You have to look at the iron stores, you have to look at the ferritin, you have to look at the transferrin saturation, and all of these consider IV iron supplementation. If even after the iron supplementation, most of the time the hemoglobin does increase, but you have to evaluate after some degree of, let's say, 4 weeks. Then if it doesn't improve, then you have to look at the other parameters to find out what has been the cause for it. And what's the best preparation for the formulation? I believe over the last 2 years, the ferric carboxymaltose has far preceded all those of low molecular weight iron dextrans, ferric gluconate, iron sucrose, feroxetol, or ferric dairy isomaltose. Why? Because a very simple injection can be done in an outpatient procedure. Usually, when we started with a test dose, but for last 6-8 months, no test dose is required because there hasn't been a documented anaphylactic reaction ever for this. The dose calculation is also very simple, 750 milligram for patients weighing more than 50 kgs, and you have to repeat the dose at least 7 days later, or you can give a dose of 15 milligram per kg for those who have a body weight of less than 50 and repeat the same. The total dose treatment course is around 1500 mg, and all across the guidelines, be it the NCCN, be it the ESMO, those patients who have a confirmed functional iron deficiency or who have a potential functional iron deficiency should receive a dose of 1000 milligram as a single dose or multiple doses. Patients with confirmed absolute iron deficiency should receive according to the body weight. And the ESMO lays out a very clear-cut guideline. So if any of those factors, that there is an iron deficiency, you give IV iron, you correct the B12 and folate stores also if they are subsequently below normal, and that's how you go on treating the anemia of it. Because ultimately the goal is to minimize the risk of the transfusion to find out a correctable cause for it and to replenish the stores also, so that with the future treatment, it doesn't get compromised with it. How much is the prevalence of iron deficiency across the tumors? The GI tumors are particularly the notorious one, because it causes a multifactorial loss, not only poor appetite, the chemotherapy toxicities associated with it, and also the loss of the occult loss of the blood leads to it being a very concomitant factor where the anemia is caused by the iron deficiency for it. And as told, that it's not a single cause that is leading to the iron deficiency anemia. It's basically a multifactorial cause. In GI cancers, you have a nutritional problem, cachexia, malnutrition, malabsorption, and occult blood loss, either during the surgery or during the because of the tumor bleeds. There is also an improper utilization of the iron, because there are a number of factors, especially the HIF, the VGF, the epithelial mesenchymal transmission. It all leads to what is known as an impaired utilization of the iron from the sources, leading to a further perpetual loss of iron in the body. And among the most notorious, the colorectal is the one which is often associated with anemia, with a reported incidence of up to 40% in newly diagnosed cases. The etiology of this anemia is frequently due to iron deficiency, secondary to chronic blood loss, or impaired utilization of the iron stores, iron sequestration, or functional iron deficiency. In addition, the treatment of the underlying colorectal cancers using surgery or chemotherapy can also lead to the worsening of anemia in these patients. Iron replacement therapies such as oral iron, the problem with them is always there's a lot of GI side effects associated with it. So you are giving a concomitant chemotherapy, you are giving iron store, iron tablets, the pain, the nausea, vomiting, constipation, diarrhea, all leads to a non-adherence and a compliance of the oral iron supplementation in these patients. And with intravenous iron preparations, they are more safe for, better tolerated, more efficacious, and therefore a better treatment option for iron deficiency anemia. Across the papers also, people have put it up that ferric carboxymaltose reduces the transfusion, hospital stay, morbidity, more treatment compliance, and also reduces a significant RBC transfusions and a hospital stay for these patients. And the more you give it early in the course, the better it is. So the impact of the pre-operative intravenous iron on the quality of life after colorectal cancer surgery is much more better, because you can see across that trial, which was an open label randomized controlled trial, where the efficacy was to compare the hemoglobin levels and the transfusion requirements following intravenous or oral iron replacement in an anemic colorectal cancer patients undergoing elective surgery. So 116 patients recruited across 7 UK centers, 50% received oral iron, 50% received IV iron. And what were the key finding? That quality of life component increased clinically significantly in those who had received intravenous iron as compared to the oral iron. The visual analog scores were quite better with the IV iron as compared to the oral iron. The median outpatient scores were also higher, leading to a favorable functional assessment of the cancer therapy for patients who have received IV iron as compared to the oral iron. So therefore, to conclude, the intravenous iron is more efficacious at improving the quality of life scores than the oral iron in anemic patients. The FAIRY trial, as lovely now the name sounds it to be, is a randomized controlled patient blinded phase 3 to compare the efficacy and safety of intravenous ferric carboxymaltose in 2 placebo in patients with acute isovolumic anemia after gastrectomy. Basically, the trial was to find out whether the isovolumic post-operative anemia in gastric patients, is there any benefit of it, and you find out that the administration of ferric carboxymaltose is considered to be superior to the placebo for anemia correction in patients without the possible risk of blood transfusions. Also, ferric carboxymaltose is a very simple, effective, and well-tolerated especially also on an outpatient-based procedure. A real-world clinical practice paper does show it from the Portugal that with iron deficiency, it is there. And its dosage should be adjusted to improve the iron deficiency anemia. And across the papers, we see that the response is quick, it is immediate, and it is sustained. So that also makes a very important prognostic marker when you use the ferric carboxy maltose across the patients. Be not only the cancer patients, if it has been an inflammatory bowel disease, those who had a heavy uterine bleeding, those with a postpartum iron deficiency anemia, across uh, the, 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 the the groups you see, it has a consistent and sustainable performance. Even in chronic kidney disease who are dialysis or non-dialysis dependent, there has been a sustained um, uh, for it. And if you look at the comparison of ferric carboxy maltose with ferrous sulfate, the oral formulations, I think so it has been a clear-cut beneficial of reduced headaches, nausea, constipation, diarrhea, abdominal pain, vomiting with the ferric carboxy maltose one rather than it. Um, so iron deficiency anemia with or without anemia is the most frequent thing which is associated in individuals with cancer, and especially in patients with a colorectal cancer. Potential interrelations of iron deficiency anemia with cancer has largely been neglected and not well defined. Emerging evidence indicates that reducing iron intake, low iron levels are associated with pathogenesis of colorectal cancer, suggesting that optimal iron intake must be carefully balanced to avoid both iron deficiency and iron excess. Insufficient iron availability may enhance the oncogenicity by impairing the immunosurveillance for the neoplastic changes and potentially altering the tumor microenvironment, and therefore iron deficiency is associated with inferior outcomes and reduced response to therapy in patients with colorectal cancers. And therefore, IV iron therapy definitely improves the overall outcome without increasing the risk of infections or cardiovascular morbidity. Oral iron causes a lot of GI side effects, leading to a poor tolerance, poor compliance, and uh, therefore it should be that IV iron is an effective, almost no failure rates. Rapidity is immediately with the response, relatively free from the adverse events, no test dose is required, and no GI intolerance. Simple to administer, 15-minute single setting, an outpatient patient procedure. Even for a primary care, non-hospital settings, it's a cost-effective, reduces the risk of blood transfusions, avoid the need of the blood transfusion, and reduces erythropoietin requirements. Up to 1 gram can be given in a single administration, leading to a speeding delivery of the iron and at the same time save the resources for it. It's convenient for the patient and potentially cost saving for healthcare providers. With 1 gram injection, there is a fewer clinical visits, more patient compliance, preservation of the venous essence, reduction of the blood transfusion, and improved utilization and reduced doses of erythropoietic stimulating agents, leading to a savings, a total cost of disposals, monitoring, hospital visits, and a productivity cost. And that's why ferric carboxy maltose is one of the most convenient and a better preparation for it. Thank you for your patient listening. Would love to have any questions if there are any.
Thank you so much, sir. If we have any questions from our panelists, I believe Vikas sir would really would like to take them. Sir, it seems we have no questions. Dr. Smith, Smith sir, are you there, sir?
Yes, hello. I did.
Sir, can I, sir, if we don't have any questions, sir, can I request you to give the closing remarks of the day?
Yeah, so thank you, Dr. Vikas, for the session. We had a wonderful day today, and I would like to thank the organizers and all the panelists, all the chairperson, the speakers. I'm looking forward to day 2, which is on. The workshop is on 12th, and on 30th we'll have again LCD of lectures. So thank you for everyone. Once again, thank you to our panelists, and have a great Sunday. Bye.
Thank you very much, sir. Thank you very much to the faculty. We've come now close to the close of today's scientific agenda. Like Dr. Smith said, please join us on 12 June, Saturday, for day 2 of the 44th ICON workshop. The workshop will start at 5:30 p.m. sharp. Wishing all of you good evening, and you may log off. We will continue the Zoom meeting for another 30 seconds for the benefit of the participants in the virtual conference venue.